Committee on Public Health will come to order. Clerk will call the roll.
Chair Van Dever.
Here.
Vice Chair Campos.
Here.
Busey. Collier.
Here.
Cunningham. Frank.
Here.
Johnson.
Here.
Jones. Olcott. Pearson. Schofield. Schaffner. Simmons.
Quorum is present. Chair lays out House Bill 1656 as pending business. Chair lays out a complete committee sub, and we will continue with testimony where we left off. Chair calls Javier Patlin, Scott Rubin, Lee Johnson, and Guy Herman. Okay, do we have Javier?
Scott. Okay.
Javier is not.
Did not
Okay.
testify.
We will show Javier as registered, testifying against the bill, but not registered against the bill, but not testifying. We have Scott Rubin. We show you registered as the Assistant Director, Texas Police Chiefs Association, testifying for House Bill 1656. Is that correct?
That's correct, sir.
Thank you. You may proceed.
Good afternoon, Chairman, committee members. My name is Scott Rubin. I'm the Assistant Director for the Texas Police Chiefs Association and a retired police chief. I had a lot of prepared testimony in 2 minutes, so I just wanted more speak from the heart. And so, Representative Campos, so a day like you described with your friend is kind of what led us to where we are with this bill. So I worked for an agency in a very urban setting in Bexar County, and mental health was really not that big of an issue for the department when it came to resources. I retired from that agency and went to a very rural area where there was less residents in the entire county than there was in the city that I retired from. And that's when I really became exposed to a lot of things that were going on with mental health and our ability to deal with those calls and the lack of resources. And in that county, there's mental health providers were not there. We had no hospital in the county. We had no clinic in the county. And so every call resulted in law enforcement, and if there was emergency detention, an hour and a half at minimum transport to Austin. Prior to that, I had served on the 988 working group as the only law enforcement representative on that group. And what I learned in that group was that when someone calls a crisis hotline, less than 85% of the people who call that hotline actually need to meet with someone. It's usually taken care of on the phone. And so when I saw what was going on in the rural county, and the only resource that those people had was to call 911, and with the current law, the only ones who were sent to those calls were the police, I realized that all these people possibly did not need police intervention in these type of calls. And so on this call in particular, there was a young man who had several interactions with law enforcement. And in a small town, everybody knows everybody. There's a chance that there's been some criminal activity with that individual. He knew all the police officers. There's 1 to 2 officers on shift. And in fact, there's more people on a fire truck than there is total law enforcement at any one time in the entire county. And so it's a call for a medical crisis or a mental health crisis. The paramedics were there. They were dealing with him.
Thank you.
Okay.
Thank you for your testimony. Chair calls Lee Johnson, CEO, Texas Council of Community Centers, testifying neutral on House Bill 1656. Is that correct?
Yes, sir, that's correct.
Thank you. You may proceed.
Thank you, Chairman. My name is Lee Johnson. I serve as the CEO for the Texas Council. We represent the 39 LMHAs across Texas. I'm testifying here on House Bill 1656. I want to thank Representative Howard and her staff for adding provisions in the committee substitute that would require counties, LMHAs, and hospital districts to work together to determine how EMS and paramedic emergency detention could work. However, we remain concerned about the cost of implementation without an identified funding source. The committee substitute contemplates funding this approach through the Justice Involved Grant Program managed by HHSC. Unfortunately, there's no additional funding for this grant program contemplated in the budget. It's also not clear how the new training program would be operationalized without funding to support its development. The intent may be for HHSC to cover these costs, but that would impact the agency's budget as well. Again, I want to thank Representative Howard and her staff and the stakeholders we've engaged in conversations about this bill. We appreciate this effort to find alternative options for transporting people with mental illness. As everyone knows, when contemplating statutory changes to how this process works today, we have to be mindful of the resource limitations that exist. These limitations must be addressed in conjunction with proposed statutory changes, or there could be unintended consequences. That concludes my testimony. Glad to answer any questions. Thank you, Chairman and
Okay,
members.
thank you. Members, any questions? Vice Chair Campos.
Scott, if you could go ahead and continue with what you were testifying on.
Yes, ma'am. So we'll try to make this more brief. And so it turned into the paramedics were dealing with the individual. He was going to comply with them. Things escalated. The officers got there, and it turned into a use of force incident. And then there was arrest, and this individual had been arrested many times before. Our thought was if we could stop this upstream before the law enforcement had to be involved, then these things would not occur. And we had worked out, we had a great relationship. And so as far as charges pending, because of that relationship that we had, we would not always file charges, even if the officers observed it. And if the charges were filed, we could work out things through the magistrates, where a PR bond and some other things to try to get them some type of treatment, because we realized that it was a mental health issue and not a criminal issue. To the point where we changed our reporting system, where if you were dispatched to an assault and the officers got there and discovered it was a mental health call, they would change that call code to reflect what it really was. As far as the cost, so Blanco County, I think, was very forward-thinking, and the county judge supported this program, and they initiated community paramedics. And so those paramedics, because of no resources, they follow up on all of these treatments and look for that continuity of care. And so they're in the community every day, and this is really all they deal with is mental health. So they're not coming off an ambulance. The ambulance is not required to transport anyone. They would transport that person in an Explorer, which would be cheaper than sending a police officer. And many of these agencies have one officer, so you have to bring someone in off duty. It'd actually be a cost savings to the community to be able to institute this plan as requested. And if I could just one more thing, I really think I hear the concerns about transfer of authority, and I really think we're dealing with really a definition issue. I know there are some other states that do this, and I was a police officer for 27 years, and this is what I do now, working for the Chiefs Association. I cannot think of another thing that we would send a police officer to arrest someone when no crime has been committed. Yet under the Health and Safety Code, this is called a warrantless arrest. Well, what is the arrest for? No crime has been committed. So the part of the attempt of this bill is to decriminalize some of those mental health problems.
Yeah, and definitely, I think that's much needed. Like this one situation, she had to pay like 10 grand to get an attorney, and then all her probation fees, and no matter, whatever happened in court, they just never got the case dismissed. So it's just, she's got more issues now than ever. So it's just a matter of figuring out how we can, I wish there was like a separate line where you could call instead of 911 to call for just mental health, because San Antonio is doing a good job with the PD, and they have a mental health unit, and so does the sheriff, but there's just not enough officers with that experience.
And I think that as we would love to see this approved, but as this advances, you have multi-facet departments, right? So you have police, fire, and mental health in big cities. The rural areas can't do that. We tried to do that. We just can't fund that. But those protocols can be taught through dispatch. Just like when someone calls and says someone's having a baby, dispatch has that cue that comes up and it walks them through that questions. And the same thing can be done for mental health, where they know, do we send EMS, or do we send the police, or do we send both? So I think it is very doable on having the right resource sent at the right time to handle the situation.
Right, because some of those mental issues are, there's too much involved. You have someone that's violent that maybe has a weapon, and then you need an officer. It's kind of like a double-edged sword, trying to figure out what we can do best for the people. But thank you for your testimony.
Thank you.
Members of Representative Collier.
Thank you, Mr. Chairman. Assistant Director Rubin, are you a police chief too? I'm sorry, I want to make sure.
Retired police chief,
Okay,
yes, ma'am.
Retired Police Chief Rubin. My question, I heard you say that officers do not make arrests if they witness an assault or a crime?
So
If
depending,
somebody's in crisis?
so if they're in crisis, they may not make an on-site arrest. And so we could refer that case to the county attorney, district attorney with those mitigating circumstances and see if they would accept the charges or not due to that mental health crisis. We believed that the best thing for that person at that time was to take care of that mental health crisis, and the county jail was not the place to do that.
Oh, I completely agree, but that's not what's happening. What I've seen is that people are getting arrested while they're in crisis and they're taken to jail. And I understand that this bill is trying to avoid that type of situation.
Right.
But I wondered, now that you brought it up, is this protocol? Is this what you're saying is protocol, that officers should not? Or you're just saying,
Well,
Best
you know, it depends on where you're at in the penal code. Is it may arrest, shall arrest,
Okay.
on how that works, and depending what is the level of the offense that occurred on the officer's discretion to file at large or to make an on-site arrest. And so that may play into the factor as well.
Okay.
But as you know, there's at least 5 bills introduced this session that talk about diversion programs.
well, I just want to stick on this one.
Well, I'm saying, so that diversion would play into that, right? And so if those diversion plans were there, then you may try to divert that person, instead of going to county jail, to one of these other approved diversion processes for that person in that mental health crisis.
So we heard that this bill would allow paramedics or to do emergency detention, right?
Right.
If instead of taking the person to jail, if the officer has a shell arrest, 'cause that's what you just said. I don't know. I'm not familiar with the code or statute or process between the different which ones are shall and which ones are may. Who would trump? Like who would have the last say? Which one would be the one that they follow?
So, there's 75,000 police officers in the state, so I can't speak as to what everyone would do. But I think part of the bill that talks about the requirement for the medical director to meet with every law enforcement agency head within an area that covers and requires the law enforcement agency to write new policies to address this statute, those questions would be answered within that local level by including the county attorney or the district attorney in those conversations about what would be acceptable to them based on the call. Just like when it went to dispatch, there would that prearrangement, I think, would be made on if EMS went or police went. And so I think that would transcend all the way into the filing of charges. And so shall arrest is the same thing. If the person's injured, they have to be medically cleared, right? So if a person's injured, you don't take them straight to the jail. The jail won't accept them until they've been cleared by medical. My thought is the same is true on mental health. So if there's a mental health crisis, even if we shall arrest, it might be after that treatment or that observation period is done, and we would file at large on the individual.
Okay, so you said you think that the bill has something in there where they could work out something that says this is the protocol if somebody is in crisis and there's a crime that's committed in front of the officer, they can make a call in that protocol
Yes, ma'am. The bill requires that they meet
to have a
to
discussion.
have that
of-
discussion about those type of things.
Okay, and then you said something about the officer and the paramedic coming up with an agreement about which one has the last say, and then, I just forgot it. I'll come back if I
Yes, ma'am.
think about it, because you raised some other point in there that made me have more concern. Because I like the concept of the bill. I'm just concerned about how it's actually going to play out. Like, would it really work out this way that it's envisioned in our head?
So just from my experience in the county that I was in, I would tell you it's basically working, other than the point of the paramedics being able to transport. So the community paramedics are going to make those calls, and in many cases, there's the officers conferring with them. They're the experts. They do this every day, is deal with mental health issues. And so I think it's also, by statute, 21 years old, the day after the police academy, you have the authority to do this.
So that's what I was going to ask. Do the officers have the chance to, do the officers come out at the same time as the paramedics, or is it one or the other?
So depending on those protocols. So currently, I think in a lot of, well, it's hard to say because, some cities have these multidisciplinary teams where they're all in the same vehicle when they arrive. In a more rural area, a lot of times, depending on how the call comes out, if it comes out as a medical call, then medical will go prior to law enforcement. If it comes out as a mental health call, depending on what the situation is, they may dispatch both.
So under the provisions of the bill, you see it that if somebody says 911, what's your emergency? And they say, oh, so-and-so's having a crisis, or my son is this. Would 911 operators know to do one or the other, or? how does
Yes,
that-
so within those protocols built into dispatch, so there's automated, so depending on the dispatch center, there's automated questions. And so just like if there's a suspicious person, dispatch, it'll ask questions, and then it'll be prompted to the next question based on the answer. Does the individual have a gun? If the answer is yes, then it goes to a series of questioning. If it says no, there's a different series of questioning. So so within that system, the same thing could be developed for these mental health calls to determine who would go. And I think a lot of times we envision mental health calls as this person having a mental or a medical an episode on the side of the road, standing in the center line of traffic, or somebody armed with a machete. But a lot of times, this happens in elementary schools. So there's special needs students, 10, 12 years old, who have these episodes in the elementary school. Are the police necessary to go to the elementary school to deal with one of these children in crisis? The same is true with the elderly people. And so right now, the police are the only ones who have that legal authority to do that.
What is the answer?
I'm sorry?
You just posed a hypothetical question. What's the answer?
The question is that under
No,
the
the
current.
hypothetical. What's the answer to your hypothetical question?
Is that I don't believe that law enforcement needs to make a call to a 10-year-old in an elementary school setting that is off their medications and possibly harming themselves, attempting to harm themselves.
All right, thanks.
Representative Pearson. Okay. Any other questions for this panel? Representative Sharper.
Thank you. In your scenario, who is paying for the program in your county? Who's paying for the paramedics?
So they work for an
Company.
ESD, the Emergency Service District.
Okay, and so that's paying for the
ma'am.
transport or
Well, currently, they can't transport unless it's voluntary,
Right.
and they do transport when it's voluntary.
and when it's voluntary, the district pays for it.
The Emergency Service, yes,
Yeah.
ma'am.
And sir, what about you? Who do you think that should pay for this,
Well, I think
especially in rural
today,
communities?
but today that's a burden on local taxpayers to pay for it. And all I'm suggesting in my testimony is that if we are to change the statute in this way, that we also have to think about the resources that are necessary to implement that. Because as Scott described, there are examples of programs that exist in certain communities that have been able to leverage the resources to create them, but that doesn't exist in all 254 counties of our state. And there are communities that do not have co-responder programs or other transportation options. And so we have to be mindful of the resources that are necessary to operationalize this when we're contemplating a change of the statute that will affect the entire state of Texas.
And if I may, and that's why I really think it's very important that this was a permissive bill and not a shall bill, because for those areas that are working it and that have that local funding, I think it would be wise to allow them the opportunity to do this. And the medical directors who don't want to incur the expense of the transport or finding alternate financing, they would have the opportunity to do that. I would say that in a law enforcement agency where there is one officer on duty at a time, it's cheaper to send a paramedic and explorer than send the officer and have to call somebody in on overtime. And the same taxpayers are paying regardless. So city taxpayers are paying county tax, and they're also paying ESD tax. So it's the same taxpayer burden regardless of who's transporting.
Do you think that this program will deter officers or law enforcement in arresting, if it does need to be a situation where someone needs to be arrested? Do you think it's going to deter anything like that? They'll shy away from, or?
I don't think so, and I think we were very careful when working on the bill where, it's, law enforcement is still going to be necessary in certain times of these calls. Obviously, if someone is armed with a knife, someone's armed with a gun, and there's imminent threat to other people, then I think law enforcement needs to be there. And so that's going to depend on that cooperation between law enforcement and EMS on, is this appropriate to arrest now? Is it appropriate to file at large? Is it appropriate to use a diversion type plan? So I couldn't say, because I think it's so situational based, and everything we do is we deal with people, and it's just unpredictable.
Sure, and I'm sure you have to, think quickly and decide quickly, and so it doesn't escalate and whatever, I'm sure y'all rock, paper, scissors on who's gonna take the person. I mean, it's gonna be hard. I mean, I defer to y'all's judgment, obviously, on the situation, and I want y'all to have that judgment as well. Thank you so much.
Thank you.
Representative Jones.
I heard you testify that if it's voluntary, the cost, who it goes to. And in a real world sense, initially taxpayers may pay for it, but they ultimately end up charging people, because you're gonna get, at least in Harris County, you're gonna get a bill from EMS saying you owe this much money. So you said in a voluntary situation, somebody pays it. I wanna know who pays it in an involuntary situation.
So that response was, if it's voluntary, EMS can already transport. So in the situation where I was in, so the ESD pays for that, because it's not an ambulance, they're running an Explorer. Just like now, if it's involuntary and the police officer has to transport, the police department pays for that, the taxpayer. So in Harris County, that would be HPD, or Harris County Sheriff's Office would be paying for that, because it's their officer, their deputy, their patrol car that's currently doing the transport and spending however many hours it takes to do this process. So I guess right now the difference is that if police
No, my
do it,
concern is if you let paramedics do it,
right?
who pays it? This isn't a who's paying for it now. This is a, if this bill passes in a voluntary sense, it would make sense that the person who volunteered to go in the ambulance would pay for it. That makes sense to me.
Right.
But in an involuntary situation, who pays for it?
Well, and again, I think that is conditional on the entity that's doing the transport, because like I said, in the county I was from, they're transporting in a Explorer and they're not billing. In Harris County, they may not have community paramedics that are driving separate vehicles, and that would be their decision to charge if they use an ambulance. But again, as he pointed out, in 254 counties, it's very hard to determine what charging mechanisms, what billing mechanisms are in place. And I imagine within Harris County alone, with all the different municipalities, if they're running their own fire, they're running their own EMS, or is the county, or is it an ESD, that could depend within that one county, multiple different billing authorities.
Right, so if, I will presume, just because I used to be on city council,
Okay.
that if HFD transports, because there are paramedics who work for HFD, right? You're gonna get a bill from the city of Houston saying you owe this money for this ambulance, because this is, because they took you. So I know you're gonna get a bill,
Yeah.
right?
In Houston.
Well, that's what I'm talking about. I
Yes.
represent House
Okay.
District 147.
Okay. Well, in Houston, you're gonna get billed. I'm saying I can't speak
Okay.
for the rest of the state.
Well,
So
I mean,
I'm
I-
agreeing with you in your city.
So if this bill passes and private ambulances can do the same thing that HFD does, does the private ambulance pass on the cost to the person they involuntarily took to wherever they took them to?
And again, I would say that would be based on the contract that private ambulance service had with the municipality or county in which they were providing that service as part of that contract negotiation. So just like in some cities opt out of ESDs and they pay a flat rate, other cities, each individual ratepayer pays up to 10 cents per hundred on their taxes for that ESD service. I worked for one city where we did not have an ambulance service, and we contracted with a private ambulance service, and so you contract with that provider.
May I ask you this?
Yes, ma'am.
Because you are being evasive, but that's
No,
fine.
I can't
That's fine.
answer
So-
something
so-
that's
so-
different in
so-
every city.
So do you see any scenario where a private ambulance service they're the ones taking the people, where they don't charge that person they involuntarily took to the mental health facility?
I see a scenario where that could occur if it was part of the contract with the city, and the city was paying that ambulance provider for services within that city, and part of that
Without
contract.
passing off the cost to the
and part of that-
involuntarily taken
Well,
person?
the city would probably pay a higher fee for that, but that would be spread out amongst all the ratepayers, not the individual who's taking that ambulance ride.
Thank you.
Thank you for your testimony.
Thank you.
Chairman. Okay, I had called Guy Herman. Is Guy Herman not present? Okay, we'll show Guy Herman registered against the bill, not testifying. Chair calls Mark Escott, Becca Hackleroad, and Liz Case. Mark Escott,
Yes, sir.
okay. Have you registered as your chief financial officer, chief medical officer, big difference there, testifying on behalf of the city of Austin for House Bill 1656, is that correct?
Yes, sir, that's correct.
Thank you. Proceed.
Thank you, Chair and committee members, for the opportunity to testify on this excellent bill. As you said, I'm the Chief Medical Officer for the City of Austin, which also means I'm the EMS System Medical Director for the Austin Travis County EMS, the Austin Fire Department, and through interlocal agreement for the Texas Department of Public Safety as well. I want to address a few discussion points from earlier. First off, the concern about overly detaining people. That's a legitimate concern. But what the evidence tells us, there's a few Australian studies, because there are not other states that authorize paramedics to do this. But what those studies show is that when a clinician is added to the police team that's responding to these mental health crises, there's an 86% decrease in involuntary detentions compared to police alone. Additionally, another study from 2014 indicated that 67% of people detained by law enforcement officers did not require hospital admission. So this is over triage. Another study from 2013 showed that when a clinician ordered the involuntary detention, that 60% of those individuals did need to be hospitalized. So what we're talking about is adding clinicians to a team that is hopefully going to decrease the inappropriate detentions, decrease the overall number of detentions, and increase the accuracy of those decisions. Regarding the constitutional issue, states have this balance, right? This balance between civil liberties and parens patriae. I'm not a lawyer, but that's the term. The responsibility to look after people who can't look after themselves. This is applicable in many areas, but there are 20 other states that today allow physicians to do detentions. Florida has had the Baker Act since 1971. Pennsylvania, where I used to practice, since 1976. This is not something new. It would be new for Texas.
Thank you for your testimony. Okay, Becca Hackleroad. Okay, we show Becca Hackleroad registered but not testifying. Liz Case, show you registered, testifying on behalf of yourself against House Bill 1656. Is that correct?
That's correct.
Thank you. You may proceed.
Thank you, members, for letting us speak. I am definitely opposed to this Bill 1656 because I see many places for abuse. Currently, we've got a system where a judge, you have to go before them and get a court order or a warrant. If somebody is taken in, they have to be taken to the least restrictive environment. So we've got a thoughtful, step-by-step process. When you read this bill and you look at it, now we're going to let any Tom, Dick, and Larry come by, and they're going to be able to be the ones who are going to be doing this restraining. I live in a rural area, and in rural areas, we have a lot more private ambulance companies that are the ones that are doing this. So the levels of training between a place like Dallas, where I used to live, and being out in the rural area, those are completely and widely varying. So I wouldn't call a lot of them clinicians. They don't have psychological training. So who are they to say who is mentally disturbed and who's not? You know, our illustrious CDC will tell you that 1 in 25 people are mentally disturbed. So these people have the right to restrain and detain people. Let's think about the cost. These ambulance rides cost from $940 to $1,300. Now, those companies would benefit greatly if they were to transport somewhat unstable people to a facility where they get at least $1,400 a day. I can see those two working together, and that would make a nice profit for both of them.
Thank you. Thank you for your testimony. Members, any question for this panel? Representative Schaffner.
Ms. Case, would you like to finish?
I just think that this is ripe for abuse. We know that people take advantage of a system like this, and I think we need to oppose this.
Okay, thank you for your testimony. Thank you. Is there anyone else who wishes to testify on, for, or against House Bill 1656? Okay. If not, Chair recognizes Representative Howard to close.
Thank you, members, for your thoughtful and deliberative discussion here. This is obviously a very complex situation. I want to emphasize that what this bill is purporting to do is addressing one factor in what currently exists. A lot of the issues that you all mentioned, the concerns that you have, valid as they are not what this bill is addressing. This bill is addressing one thing and one thing only, and that is who has the authority to do these detentions within the system that we currently have, which clearly has many issues that need to be addressed. I want to talk about a couple of things before I close. Expanding emergency detention authority outside of law enforcement is not a new approach. As you were hearing from Dr. Escott, and unfortunately he wasn't able to continue his testimony, but at least 22 states already allow a physician to initiate an emergency detention, and several other states, such as Colorado and Minnesota, all allow for registered nurses and social workers to initiate emergency detentions. We don't have paramedics at this point in time, but it's not a new idea to have health-related professionals be involved with these detentions. I also want to reiterate that House Bill 1656 is not a mandate. This bill was designed to allow communities the option to expand this authority if it works for them in their community. Likely some communities will not feel comfortable expanding this authority. However, others may see this expansion as an opportunity to strengthen their existing community paramedic or co-responder models. HB 1656 is not a silver bullet solution. It is instead just another tool in the so-called toolbox for communities to be able to address their community's mental health needs. My office remains committed to working with stakeholders to discuss opportunities to strengthen this bill and improve care for individuals in crisis. Our goal is to bring a health-centered approach to mental health crises and thereby decrease hospitalizations and incarcerations, escalating events, and at the same time, more appropriately utilize law enforcement so that they are able to focus on public safety. I will be happy to try to answer any more questions. I know y'all have heard a lot. Please consider this. We'll work with you in whatever way we can. We need to do a lot here. We need more facilities. We need more personnel. We need funding. Part of the problem we have here is, as you've heard from the testimony, there's not clearly designated funding sources for these things. But mental health crises are affecting our communities, and we know here in Austin, and we hear about it here at the legislature, about how the mental health crises on our streets are affecting people feeling like they're safe here. We've got to figure out some ways to address this. This is one way that we can do that, and I would appreciate your favorable consideration.
I think we have a question. Representative Jones.
I just want to make sure I heard what I heard.
Okay.
Did I hear you say that paramedics nowhere in the United States are allowed to do this?
Right now, there's not a situation that I'm aware of, from what I've been told, where paramedics are doing this, but other healthcare professionals are. And a paramedic operates under the authority of a physician who would also be authorized in this case.
So I just want to make sure that nowhere in the United States are paramedics doing this. Is that
That's my
accurate?
understanding.
Okay. And you said that in 22 states, that physicians are allowed to do this.
Correct?
Did I hear you say that?
Yes, that's my understanding.
And paramedics, would you agree with me, don't have the training of a physician?
I would. As a nurse, I can tell you that we
Okay.
do a lot of things that are delegated to us by physicians. And I also mentioned that there are others, like registered nurses and social workers, who do have delegated authority to do this. So absolutely.
How long do you have to go to school to be a registered nurse?
It depends. There's different pathways.
What's the minimum?
Mine was a baccalaureate degree.
So you got to go to college for 4 years.
Correct.
Do paramedics have to go to college for 4 years to be a paramedic?
There is a route that's the case, yes. It's kind of like with nursing, where you have ADNs who have gone to associate degree programs and take the same licensure exam for an RN. My understanding is that for paramedics, there's a 4-year baccalaureate program, but there's also an associate's degree programs where they take the same exams, similar to nurses. That's my understanding, and I may not be absolutely correct.
Then maybe I need to find out
Okay.
because I know that at HFD, I mean, I'm from Houston.
Yeah.
Yeah, you can go through the academy and you end up being a paramedic, and you didn't go to college. Like, so I'm just trying to. I mean,
Right.
I guess my concern is that we're equating paramedics with physicians, paramedics with RNs, and I think to be a social worker, I think you need a 4-year degree as well. My mom's a social worker, or she was. She couldn't get no job doing it, so she delivered mail for the post office. But that's another story for another day, right? So, and so if you're involuntarily taken by a paramedic who is not employed by a municipality, who pays for it? Does the involuntarily detained person
and-
pay for it?
Representative Jones, I'm sorry, I can't tell you that, because when I have tried to understand the payment mechanisms, it varies from community to community, and the agreements that are made in those communities. So that is absolutely a concern. I agree with you, and I think that's something we have to address. This bill does not do that.
So if the bill doesn't do that, would it be an unfunded mandate?
No, because this is a permissive bill. It's up to the community to decide how they want to set it up. Right now, they can do the same thing. This doesn't change anything about that. They can still have their memorandums of understanding. They can still come up with their contractual agreements. That doesn't change. This doesn't change that.
So maybe I didn't hear, did you just say that right now, a community, a city, a town can authorize paramedics to detain people going through
No.
mental crisis? Is
I'm
that what
sorry,
I
I
heard you
didn't-
just say?
Let me say it more clearly. They can authorize paramedics to transport. They can't actually, they don't have the authority to do the emergency detention order.
Okay, thank you.
Thank you.
Okay. Okay, thank you, Representative.
Thank you, committee members. I appreciate it.
Okay. Chair withdraws committee sub. If there's no objection, House Bill 1656 will be left pending. Is there objection? Chair hears none. House Bill 1656 is left pending. Chair lays out House Bill 4504. Chair lays out a complete committee substitute. Chair recognizes Representative Bonin, Chairman Bonin, to explain the bill.
Thank you, Mr. Chairman and members. I appreciate the opportunity to lay out House Bill 4504. This bill would establish parameters for physician non-competes in order to help protect patient access and reduce some of the legal ambiguity and the burdens of litigation. It also helps to safeguard the integrity and the mobility of our healthcare workforce, and it does promote competition. For those of you who may not be familiar, a physician non-compete is a section in an employment contract that prevents a doctor or other type of provider from practicing within a defined area. Sometimes these non-competes can place very large geographic boundaries around the current location, which may be very problematic for a physician wanting to change to another position. And sometimes there may be very large buyouts that would be beyond what could reasonably be expected. This bill clarifies in statute that it limits the buyout to no greater than the physician's annual salary at the termination of their employment. It limits the applicability of the non-compete clause to 1 year. And it sets the broad geographic restrictions to be within 5 miles from the location the physician primarily practiced at, meaning there could be satellite locations, but the 5 miles would be tethered to the primary location. And it clarifies additionally that managing or directing services and performing administrative type capacities would not be included in this legislation. I'm happy to answer any questions and would like to reserve the right to close.
Okay, members, any questions of Chairman Bonin? Representative Frank.
Yeah, thank you. Chairman Bonner, I appreciate what you're trying to do here, because you're trying to limit the consolidation in the healthcare arena. Is that right? To some degree?
Yeah, so I can give you some examples if
Yeah,
you know,
please.
if that might help. So imagine that, and so first of all, by way of background, a majority of physicians are actually now employed. So the time in the past when people were in solo or even small group practices is largely ended. Those still exist. I'm actually in a solo practice myself, but a majority of physicians, maybe as much as 70% or more, are employed by a hospital system or an insurance company, for example. We're also seeing increasingly commonly that private equity is coming in and acquiring practices, and then they will bundle those practices and then presumably at a later time flip them. And I'm not arguing against any of that, but the nature of the way we practice has changed. And so let's say a physician comes in and takes a job, and they are subject to a non-compete that is 50 miles. Or they could buy out of it, but it's, $2 million to buy out of that. So realistically, should they leave that practice, they're effectively going to have to completely leave the community, or certainly the bulk of that geographic area, in order to continue to practice. And the flip side of it would be, why don't we just completely eliminate them, right? Well, I mean, there are scenarios where somebody may come in, they work for a year, they're completely unknown in the community, start to become established. The employer or the practice makes a substantial investment in helping them get on their feet. I can understand where somebody would say, I don't want them to walk across the hallway and then begin to take all those patients from our practice and compete against us after we just spent hundreds of thousands of dollars helping them get established. And so we're trying to maintain some balance. So it doesn't completely eliminate non-competes, but it restricts it to 5 miles and 1 year.
Okay. Thank you, Dr. Ball. Thank you,
Representative
Chairman.
Jones.
I don't know if I saw this, but let's say I go to work at a place, I'm a physician, and I go to work at a place and they give me a bonus to come work there. And I decide to leave. I don't know, maybe I'm driving too far or something. If they make me sign a non-compete, it can be for a year, it can be for 5 miles. Do I have to pay back the bonus they gave me if the contract that I had was like for a certain time, like you get to keep the bonus if you stay here for 5 years? Do I have to pay it back pro rata? What? I'm curious.
Yeah, so bonuses aren't really contemplated in the legislation. I think that would come down to the contract that you had signed. And I can give you a little bit of a different example, not precisely a bonus, but in years gone by, we've certainly seen times when physicians would be given basically a loan, if you will, and that loan could be administered or given up front, and then it would be forgiven over time. Perhaps over a course of, say, 5 years, it would be amortized as long as that provider remains in that location practicing. And if they were to leave, then they would have to pay that, that amount back based upon, when they left. But, signing bonuses are not a part of what's in this bill.
So in the scenario, I just want to be clear, the scenario you just gave, I'm gonna give you a loan, but if you stay here for 5 years, you don't have to pay the loan back. Is that the example that you gave?
There have been arrangements to that effect, yes.
Okay. And so one of the parts talks about, here are my glasses, that you have to, the non-compete must allow access to the list of patients that you've seen within 1 year prior to termination. Do you know what that's about?
So I think that comes back to whether or not you can continue to communicate with the people that you have already established a patient-physician relationship with.
So after a year and outside of a 5-mile radius, then I can go back and talk to them. And the non-compete has to give me access to them.
That's right.
Okay, thank you.
Representative Schofield.
Chairman, with respect to the non-competes, I mean, as you know, over the last couple of decades, they've been disfavored in general. It used to be it was contract, you had to enforce them. The federal government tried to get rid of them entirely in employment context a couple of years ago. Basically, where we end up landing most of the time in an employment context is about where you did. If you limit it in scope and in time, it will be upheld. And in all of those instances, the focus was on the right of the employee to make a living. But there's a second aspect at play here, which is the need of the community to have medical care. And that, I think, is a second driver that puts your need for a limit on non-competes in an entirely different light, which is not only is the doctor need to have the right to go make a living, but we have many parts of this state where it's difficult to get a doctor. And the last thing I think we want to do is allow contracts that will make it impossible for them to practice and provide the service.
Yeah, thank you for that. I appreciate that. It's well said. And I guess one other element I would add to that is a more aggressive non-compete, as you mentioned, may not stand up in court. However, there's an old saying, you may beat the rap, but you won't beat the ride. So if you want to spend tens or hundreds of thousands of dollars fighting it over a year or two, you can. But as a practical matter, you're not able to, you may very well, unless you get an immediate injunction, you're going to be stuck. And you're not going to be able to continue.
From the beating the rap standpoint, the non-competes you're talking about in your bill, are they primarily for physicians who are employed as opposed to physicians who own part of the practice?
Yeah, yes, absolutely.
Okay, and again, the courts have been disfavoring them for employees. It's a little different if you and I and the gentleman in the first row go into business together and have a non-compete. That's a little different. They kind of expect that we knew what we were doing when we got into them. I have a second question for you about a section of the law that you're amending, but only for word choice. And it's a section, it's on page 1, and it talks about how the covenant that you have with the employer can't deny you access to your own patient list, which is now current law. Is that something was that a major part of physician-employer agreements, that if you leave, you can't even have access to your patient list?
Yes.
Is that something you were aware? So they were really.
Well, as you can imagine, that's considered a value. And so the concept is pretty simple. Will people be able to follow the physician, or will they be disallowed from following the physician should the physician leave and then remain either in the practice, or obviously they could choose to go to a different physician who's not their current physician or in the practice, and I'm sure that happens as well. But that's
again,
what that's speaking to.
It's, in other businesses, it's common to say you can't take the client list, you can't take our trade secrets. But again, this is the clients don't have the same kind of interest in being sold something as they do in being able to see their doctor.
It's a different relationship.
And I just want you all to know, I love his bill even though he never puts my stuff in the budget. Thank you, Dr. Bond.
Okay, thank you. We will reserve your opportunity to close. Chair calls Dr. Zeke Silva and Steve Woleb. Okay, I show Dr. Zeke Silva testifying on behalf of the Texas Medical Association and yourself, and you're for House Bill 4504, is that correct?
That is correct. I'm speaking for House Bill 4504. My name is Zeke Silva. I'm an interventional radiologist. I practice in San Antonio, and I'm chair of the TMA's Council on Legislation, which sets legislative policy for the organization. I want to thank Chair Bonin for his thoughtful approach. We certainly understand the need to balance non-competes between the employer's interest and the employee's interest. And with 59,000 members at the TMA, we have physicians that are on both sides of that equation. We think this strikes an important balance between those two interests. But I do want to expand on the points that the chair made, and I think the questions were excellent from the members. Medicine is different. What we do requires continuity of care. What we do requires patients to maintain access, and importantly, it requires that patients have a choice. To Representative Schofield's excellent question, it is certainly about us, but it is unquestionably about the patients and unquestionably about the community. We support the provisions in this bill, including the one-year limit, the limit on the buyout being wages and salary, and we speak to the radius of 5 miles, and we do concur with the approach of having that the primary location of the practice. If there were any improvements to offer, we would like to see an exemption for a scenario where a physician loses their position without cause. Imagine a practice scaling down their operations or becoming smaller. We think the physician should be exempt from that. And we always advocate for the non-competes to be clear and transparent at the time that the employment agreement is undertaken. But with all of that provided, again, I want to thank and acknowledge Chair Bonin. The TMA is pleased to speak in support of House Bill 4504. Chair, members, thank you.
Okay, thank you. Chair recognizes Steve Wallab, General Counsel, Texas Hospital Association, against House Bill 4504. Is that correct?
Yes, all correct.
Thank you. Proceed.
Thank you, Mr. Chair and members. The Texas regulatory scheme for covenants not to compete is a time-tested system that balances the interests of the employer and the employee. Non-competes are a legitimate way to protect an employer's interests from unfair competition. Like other businesses, hospitals and medical groups want to safeguard their competitive edge as well as protect significant investments in recruiting, training, and developing their employees. While each non-compete clause is different, every non-compete must be able to withstand scrutiny if challenged. Judges in these cases apply a reasonableness standard. For example, a court is unlikely to enforce a non-compete clause that would prohibit an employee from supporting their family or earning a living, or depriving an entire community of access to care. Determining what is reasonable is relative when considering non-compete clauses. For example, a 5-mile radius in dense urban Dallas is much different from the 5-mile radius in a rural area. A limitation to a broad field of work is also different in a large community with many professionals than it is in an area experiencing a shortage of certain types of workers. This reasonableness standard is the backbone of our non-compete statute and has been dependable for over 3 decades. This allows for non-competes to be tailored appropriately for each unique employer-employee relationship across our incredibly diverse state. This bill upends that system. By adding arbitrary, fixed criteria for all non-competes across the state, the bill unnecessarily prohibits individual agreements between parties. A singular geographic radius is not appropriate for every situation, and neither is a singular time frame. Specifying the exact criteria for buyout limits the employer and the employee deprives the employer and employee of their negotiation on favored terms. Perhaps of more concern, the bill would render existing agreements that renew after its effective date unenforceable if they do not comply with the bill's requirements, depriving willing participants to existing contracts of the benefit of the bargain they struck. We've made some suggestions to the bill author, but in its current state, we oppose. Thank you.
Okay, thank you. Members' questions. Representative Schofield.
I understand your concern that a one-size-fits-all, a time frame and a mileage might not be what you would consider the best, but frankly, over the last 20 years, courts have been requiring it. So in most contexts for a non-compete. So I hear what you're saying in that it might be different in an urban area or rural, but this is kind of the direction the courts have been going for quite some time now. Normally I would say let's work something out that doesn't do a one-size-fits-all, but that would be going against the jurisprudence of the last couple decades.
Well, sir, and I don't claim to be an expert in employment law, but I'm not aware of any, any pronouncement by courts saying, this is the specific geographic limitation that's reasonable, or this is the specific time frame that's reasonable. I think these decisions for decades now have been left up to local judges, locally elected judges, to determine the reasonableness of the scope, time, and the limitation on the activity. So that's where these cases are adjudicated, and I would say, in my own personal experience as an attorney, that disputes around the reasonableness of a non-compete rarely even get to that point, because the parties recognize, when the employee leaves employment, that if the originally tailored non-compete clause was unreasonable for some circumstance that exists at the time that employment is terminated, both parties understand that. They come together, they work it out, and they reform the agreement on their own before anybody even has to go to court.
Well, they do now, but I mean, I've seen lots of these, because when courts started saying we're not honoring them, everybody had them. And so you had a just blanket non-compete, and the courts were saying this isn't enforceable, and they're making them start to, it basically, the rule came about jurisprudentially, not through the legislature. And it's been, like I say, it's got to be 20 years now. I'm getting old. But, so I hear your concern, and maybe Dr. Bonham will work with you on the scope, but it was the courts that said you have to limit it in time, you have to limit it in mileage. And that's where it came from. It wasn't, the parties weren't saying, well, instead of mileage, why don't you limit it by, we expect this many customer density in that area, so do it that way. It was the courts that just threw a rope around it and said, that's how you're going to do it. I don't know why it would be different for doctors than others.
Well, I think I understand what you're saying. I will say our statute's been around for 30 years. I mean, it may have originated in court opinions and court holdings, but the legislature did come in and say, all right, here is going to be our statutory regulatory scheme for non-competes, passed the law, and it has withstood the test of time.
Thank you.
Representative Frank.
Just a question for TMA, because if you limit the non-compete to 1 year, obviously it frees up a doctor who sells his practice, or I don't know if we use that term or not, but is that what y'all use, by the way? Am I being pejorative when I say sells the practice?
You can imagine a scenario where a more senior physician might sell their practice to a
Okay,
younger
if
physician.
you limit the non-compete to 1 year, would that not decrease the amount of money that you would be able to expect to get from it?
When you say get from the buyout, or
Yeah, from a
this,
buyout.
Well, this is
I
just
mean,
this is just a non-compete. So this would be once that person becomes part of the practice, would be limiting their ability to leave. If they left, that would be the point where the buyout clause would be applicable. But just as far as the value of the practice, I suppose you could work that into the overall value.
Right.
But I think most of
Which,
us.
I mean, I like the
Yeah,
bill.
I
I
think
mean,
most of
honestly,
us
I'll do almost
assume-
anything to keep
Yeah.
from the consolidation of the market that's already happened. I think this,
Right.
really, the testimony here, like, doctors are frustrated with how consolidated the market's gone, where I think it's like 20 years ago, 70% of doctors were independent, and now it's closer to 30%. I may be a little bit wrong on that, but it's
38%-ish.
30. Oh, is it as high as 38? But it is dramatically changed, and it's going to continue to. And if there's 5-year buyouts, then essentially once a doctor sells, they're just going to have to leave.
Yeah, they
I
have
mean,
to leave.
the market is consolidated and will never change, and so it may affect the amount of your buyout, I would assume.
Right, but in that agreement, the contract would be between the two parties. They could choose not even to have a non-compete agreement. This would be in place if there were a non-compete, would put limits when it is created. But you could choose in that scenario to simply not have a non-compete for the more senior physician.
Right, okay. Thank you very
No,
much. Thank you,
Thank
Chairman.
you.
Representative Jones.
This is to the Texas Hospital Association. Question, you said something about with the current language, we oppose it. Is there any language that you'd be okay with?
We have submitted some language to Chairman Bonham's office, which we think, if you were agreeable to, would be something we could live with.
And, and like with these large hospital systems, and there's multiple branches all over the place, I'm just curious, is the 5-mile limit 5 miles outside the big footprint of the system? Or if you are good enough, you can find 5 miles between two, how does that work?
I think, Representative Jones, the 5-mile limit is tied to their principal place of practice, where they were practicing when they left employment. So that part, I believe, is pretty tight.
Okay. And I was, well, okay, I'll ask Dr. Bonner something else later. Thank you.
Representative Pearson.
Thank you, Chairman. Dr. Silva, you're right. The position that you are in as a physician is a completely different animal. It's not like a typical business. Mr. Walib, if we are looking at a patient-physician relationship, it is a very intimate, deeply personal relationship. And I realize to the corporate entities around the business see people as customers. And I heard you mention reasonableness, and you were working with the author on what that would look like. But my question is, when you have this relationship, and I've experienced this in healthcare 14 years, independent practices, and I've seen patients in tears when they could not follow their doctor, who's been taking care of them for pretty much ever, and in some cases, several generations. And so I'm trying to figure out why it's reasonable at all to tell doctors they can't take their patients with them. So I'm just curious.
I understand, and you know, the enforcement of a non-compete could result in those kinds of hardships. We certainly understand that, but this is in the end an investment by the employer in many cases. You know, they have invested a lot of time and money in recruiting the physician, in helping them build their practice. Perhaps, you know, didn't have a relationship with that patient before they came to the practice that employed them, and now is trying to enforce the non-compete. And so I just think there has to be a balance. I understand the hardship that it could cause on an individual patient basis, but don't believe that necessarily justifies, you know, those isolated cases sort of tipping the scale so far in favor of the physicians in this case. I do think we've got to maintain the balance. Our position is we need to maintain the balance that the current law provides for.
Well, in some cases, there are groups who do have established patients, multiple physicians have established patients that eventually are acquired. So you didn't invest in them, you didn't build their patients, you inherited them. Is there a separate non-compete for those physicians?
I think that would depend on the facts of those cases, but if that resulted in, you know, just sort of a broad swath of physicians that were unavailable to the community, I think that would be exactly the type of argument those physicians, if they were under a non-compete under that scenario, would argue to a judge to say this simply is not reasonable the way this is playing out. And the current statute allows for that and provides for that.
Okay, thank you.
All right, thank you for your testimony.
Thank you.
Is there anyone else who wishes to testify on, for, or against House Bill 4504? If not, Chair recognizes Chairman Bonin to close.
Thank you, and I appreciate your time in the discussion. I do think there were some important points that were made, and so the suggestion that this has stood the test of time for 30 years is a really good point, because 30 years ago, the environment was completely different. And so it's a little spurious to say, yeah, it worked really good when the world didn't operate the way it does today. That really doesn't make a lot of sense. When this was put into place, there were very few physicians that were actually employed by hospitals. And then it's just been within the last session or two that some of us have sat on the dais and heard the hospitals testify that they don't employ physicians because that's illegal. It's against the law. But then they come and they testify against the bill, saying, well, gosh, you know, we have a lot invested in these physicians. And so within the letter of the law, they don't, but they have their nonprofit that actually does, and they control the market. And that's really what, you know, this is about. In addition to that, a suggestion that we received was 25 miles instead of 5 miles. Well, I mean, that's clearly a non-starter, right? I mean, that doesn't work for any physician that wants to continue to practice in the community. And that you could go litigate this, well, you can, but again, if you're a physician and you're having to go to litigation, you've already lost. I mean, you're not going to be able to continue to practice. You're going to have to go and start over. And then maybe to prove a point, you could continue in that litigation. But I don't see how you would simultaneously sustain a practice while fighting a non-compete, just as a practical matter. Technically, perhaps, but in reality, I don't see how that would successfully work out for you.
Representative Jones.
So I was trying to see something, Dr. Bonin, and I have heard, and tell me if you know, that other healthcare practitioners have limited scope non-competes, like they generally, like for dentists and stuff, they normally are protected against, I guess, excessive non-competes. Do you know if that's true or you don't know?
I'm not as familiar with what's happening in dentistry. I'm happy to look into that, but I don't
I'll
have that
look. I
information.
actually heard that limited scope non-competes are sort of the norm in other areas, but I was just wondering if you knew. That might bode well for your argument, but I was just trying to see if you knew.
Okay, members? All right. Thank you, Dr. Bonin.
Thank you. I close.
Chair withdraws the committee substitute. If there's no objection, House Bill 4504 will be left pending. Is there objection? Chair hears none. House Bill 4504 is left pending. Chair lays out House Bill 5459. Chair lays out complete committee substitute. Chair recognizes Chairman Wilson to explain the bill.
Good afternoon, Mr. Chairman, members. Try to make this quick for you. I know you got a long day. Yes, there is a committee substitute. Thank you for laying that out. It's simply council version with some additional definitions for clarity. Members, House Bill 5459 addresses a large but not unnoticed concern within the farming and local food producing community. Farmers and local food producers with a food manufacturer or food retailer permit from the Department of State Health Services can sell their products to the consumers in the state. However, if there is a local health department, they need to obtain a permit from the local department and pay additional fees, even though the substantive regulations governing them are the same. This is challenging for farmers, especially smaller farmers selling at multiple farmers markets or small venues. As producers in rural or low-income areas cannot expect to generate enough revenue to cover the cost of multiple permits. This bill allows Texas small farmers and the food businesses under $1.5 million in gross annual sales to sell anywhere in the state if they have a permit from the Department of State Health Services. House Bill 5459 maintains high standards for food manufacturers, retailers, removes unnecessary burdens on small farmers and small food businesses, and encourages small farmers and food businesses to sell in more locations, making healthy choices, local food, more available for our Texans. Thank you, Mr. Chairman, and I respectfully reserve the right to close.
Okay, thank you. Members, any questions of Chairman Wilson? Okay, we'll reserve your right to close. Chair calls Judith McGarry, Steve Smith, and Stephen Poprovsky. Show you registered as Judith McGarry, Executive Director, Farm and Ranch Freedom Alliance, and you're testifying on behalf of Farm and Ranch Freedom Alliance and yourself, and you're for House Bill 5459, is that correct?
That's correct, Chairman.
Thank you.
Thank you, Chairman, members of the committee. I want to clarify, particularly given earlier bills that we've come before y'all with, this is not a deregulation bill in any way. We're talking about producers still having their permit from the Department of State Health Services, but simply not having to go through the paperwork, the delay, and paying the fees to local health departments who are applying the exact same standards. Just to give an example, I'm in Milam County. We have a food manufacturer's license. We can go dozens of other counties and sell at any farmer's market. But if we go to Austin and Georgetown and Waco farmers markets, there's 3 more permits, 3 more sets of paperwork, 3 more sets of fees. This is infeasible for many small farmers and smaller food businesses. I want to touch on the $1.5 million and how we got there. This is something that may sound big, but first of all, remember it's gross sales, and these types of businesses have very small profit margins. So when the FDA was asked by Congress to define very small food businesses, they set it at a number that is now inflation adjusted, and that as of 2023 was 1.34 million. So we're very rapidly heading for FDA defining very small food businesses as 1.5. Small food businesses, according to the Small Business Administration, are anywhere between 2.25 million and up, basically, depending on the exact industry we're dealing with. And so we're trying to make it possible for our small farmers who want to be in more places, where consumers want them to be, that they can go and be part of those markets and part of those events and venues. And I'm happy to answer any questions.
Okay, thank you. That's Steve Smith, testifying on behalf of yourself for House Bill 5459, is that correct?
Yes, sir. Thank you.
Okay, thank you.
Thank you for listening. My name is Steve Smith. I'm a small-scale producer and a founder of a small farmers market nonprofit in Devine, about 30 minutes south of San Antonio. In late 2020, my wife and I launched Smith Pastures, where we raise, process, and sell premium nutritionally dense chicken to customers throughout the greater San Antonio, New Braunfels, and Hill Country area. We are very low-volume producers operating under an exemption from DSHS that allows us to process and butcher our products on farm in our own facility. This means we can ensure end-to-end quality control that provides untainted food to our customers. And we are just one of many small producers throughout Texas that work hard every day to provide folks healthy, local food. We have the best customers and value the trust they place in us to feed their families. As such, we maintain personal relationships with them, and they have an open invitation to visit our farm and observe our operations. We believe that that level of trust and transparency, along with dogged adherence to our personal safety standards, is why we've had zero complaints or customer health issues related to our food. When we launched our business, we did a demographic analysis that showed a large customer base in Bexar and Kendall counties, but we chose not to serve in those areas because their health departments require these redundant permits. And we operate on incredibly tight margins with zero administrative staff. It's better for us just to forego those markets. This means the folks looking for us cannot access our products, and we cannot increase our services to those communities because of bureaucracy that not only doesn't promote healthy outcomes, it actually prevents them. What it also means is we cannot hire and employ additional staff, and we understand the need for regulations and work closely with the teams at DSHS. However, the nature of small producer means we have to be convenient for the customer in multiple locations and multiple jurisdictions. With that, I ask for your support on this bill.
Okay.
It would really help us out a lot.
Very good. Thank you for your testimony. Chair recognizes Stephen Poprovsky, testifying on behalf of Chief Collaboratives, Chef Collaboratives Incorporated, and yourself, and you're testifying for House Bill 5459. Is that correct?
Yes. Thank you, Chair and committee members. My name is Steve Poprovsky. I'm a chef, food entrepreneur, and founder of Chef Collaboratives, Inc., a nonprofit dedicated to supporting small food producers and hospitality workers throughout Texas. I'm testifying today in support of House Bill 5459 because I've seen firsthand how duplicated permitting requirements create serious, unnecessary barriers for very small food businesses. Back in 2016, I stood with vendors in San Antonio to oppose a controversial new fee imposed on farmers market participants, despite many of us already holding permits from the state. Our fight was covered by San Antonio Express News, San Antonio Report, and multiple news stations. The result, more paperwork, more delays, and more money pulled from businesses that already operate on razor-thin margins. We're not corporations. We're farmers, chefs, and food artisans. Some of us work 2 or 3 jobs just to keep our dream alive. Duplicated permits don't make food safer, it just makes survival harder. House Bill 5459 will reduce bureaucracy and make it easier for food entrepreneurs like me and hundreds of others across Texas to operate legally and sustainably without being taxed twice for the same privilege. I urge you to support this bill so we can spend less time chasing permits and more time feeding our communities. Thank you.
Thank you for your testimony. Representative Collier.
Thank you, Mr. Chairman. I just don't know, so I have to ask these questions. What is the cost for a permit, the food permit that you're asking to eliminate?
Ma'am, I'll give you a lawyer answer on that one that I'm not, but it depends.
Okay.
They can range between $20 to $100, sometimes $150, depending.
And do you have $150? Is that like the most?
Go ahead.
So it depends. We're having trouble finding that out. It's actually supposed to be capped at $100, but we keep running into jurisdiction after jurisdiction that is not respecting that cap. And I think I just got I'm sorry, and I'll find the number and get it to you. I recently just got an email from another producer, and I believe they're being told that it's 175. You know, we keep getting different numbers.
Is that per year or is that monthly? How does that work?
Again, it depends on the jurisdiction. Some of the jurisdictions are doing annual, which is what they're supposed to do, again, under a previous bill. And some of them are doing it quarterly or, different time periods.
So if they're doing it quarterly, does the amount exceed the $100 cap?
The ones I'm hearing about, yes.
And so if it exceeds the cap, what is the recourse? Like if they're violating, is that in law?
So the producers could choose to sue. So actually, let me use Kendall County, the farmers market he mentioned, as an example. We got reached out to by the organizers because they were arguing with the Kendall County about not respecting the cap. We actually arranged, DSHS got on the phone with the Kendall County attorney and health department and said, this isn't how we interpret the state regs. What are you doing? And the Kendall County attorney was basically like, well, this is how we're doing it. And it was like, so are you going to sue us? And these are small producers. I mean, you were just hearing the testimony about doctors not having, and I fully sympathize, not having the resources to sue over non-compete. I'm talking about tiny businesses working 3 jobs, 2 jobs to pay bills. They're not going to sue the counties, and the problem is the counties know that.
Well, so is there concern that, I mean, even if this bill doesn't pass, what is the recourse for dishes? I mean, maybe that's something we need to
Dishes doesn't have
reevaluate.
authority to stop them. And that was what came up, that's what sort of came up in the call. Dishes has the authority to guide them and say, like, this is our interpretation of state law.
Oh,
But the way it's written, it's not like Dishes has the ability to order the local counties to do something different.
But is there a number in the law, in the statute, in the code?
In the
that says-
statute, yes.
And you're saying that.
They're still thumbing their noses at it.
So does the Attorney General, does somebody have the authority to go after?
Yeah,
To
so it
enforce
could be
the law?
private lawsuits, but actually there is a waiver of sovereign immunity so that people could sue. The Attorney General could. We haven't been able to get their attention on it.
Okay. Well, then the next question that I have deals with the local health departments. And I don't know the answer to this. So you said Dishes, you have to get a permit through Dishes, right? Does Dishes do inspections?
Yes. They have an inspection program, correct, yes. We have standards we have to abide by in our facility, we have to abide by food safety, handling, trainings that we have to go through as well.
Okay, and so this bill does not eliminate Dishes, the food permit or the handling, whatever the permit
No,
is through
no,
Dishes?
ma'am.
All
No,
right.
my understanding is this just says DSHS is good for everybody. And it's
Okay.
the same standard across the board because we operate in so many different jurisdictions that there's a standard across the board.
Okay, I didn't get that part. I missed that part of your testimony. So you're traveling,
Ma'am, I operate in 7 counties.
okay, so you have 7 counties, and this is for if you are selling.
I do pasture-raised poultry, ma'am.
Okay, and you're saying in 7 counties you have to put up a food permit for all of them?
If the counties themselves do not recognize our DSHS food retailer's permit, then they require us to get their permit, and that's where we just say we just can't afford the time and the extra money that is required of that.
Okay.
And so we choose not to serve those communities at that point. And to that end, I've actually been I went to the Kendall County Market with my thinking I was great, because I'd been to a number of other markets that allowed that. And the inspector came in and asked for my permit, and I said, "Here you go. Here's all of our documentation." And he said, "No, shut it down." And so what that did is that was right at the beginning of the market. I lost an entire day of revenue and sales because that inspector just made the choice just to shut me down.
So that was what I was going to ask. So you said Dishes does do inspections, and so the local government who's saying that you have to have a permit, they also do inspections?
Yes.
And are they looking for something other than what Dishes is looking for?
No, ma'am. Exactly the same things. Identical. Everything has been identical that they've asked for permitting. They,
But sorry, I just wanted to clarify, and I need to get the numbers. I apologize for not having it. So what happens is, with the way these permits are, DSHS has primary jurisdiction wherever there isn't a local health department that does food permitting. And so there's some number of counties, I don't remember the exact number, where DSHS is primary jurisdiction. So like with the food manufacturers or food retailers permit from DSHS, you can go to any of those counties right now and sell. The minute you step into a county that has a local health department that does food permitting, all of a sudden you have to get a second permit.
Okay.
Does that?
Yes, it does make sense.
Okay.
Then my question is, if you have to get a second permit, I mean, they are doing inspections, so I guess that's what the permit is supposed to be covering. I suspect, I don't know.
So what they check for, and I'd love to hear, not be the only one to answer, but let me start. They check for, do you have your permit? They check for, are you keeping safe temperatures? And they check of, do you have correct labeling? I've been through those. My husband and I sell at a farmer's market. It takes about 2 minutes tops to do that inspection. It is not like they're coming in. It's not like walking into McDonald's and they're having to look through all of this.
Right.
You're talking about this operation that's set up for a few hours in a 10 by 10 tent. And here's our food. Here's the temperature gauge. Here's my permit. So even to the extent that they do these inspections, and remember, we are talking still about being inspected by DSHS.
And this is for the people who go to the farmer's market?
Primarily, yes.
Yes.
All right, okay. And then, does my county do this, Tarrant?
Yes.
I'm just asking, okay. All right.
Yes, if Tarrant County does this, yes.
Yeah.
I'll speak with them.
Representative Jones.
I'm just curious, do you have any idea, any of you, if the cost of the permits are the cost that the people who put on the farmers markets, if there's a cost to putting on the farmers markets, do you have any idea?
The farmers market booth fees are charged by the farmers market organizer, can range anywhere from being free to being $40 a week, and it's entirely up to them, and we're not trying to get in the middle of that one.
So the right answer to that is the permits, the farmers markets charge you for you to be to the farmers market. The permit-
It depends a lot. So for instance, in the bigger city farmers markets especially, where you can expect better revenue and they are doing a lot to promote it, you can expect to pay higher booth fees. When we went, for instance, to Manor Farmers Market, it was, if you make enough, please throw $10 in the tin to help cover the cost
So,
of the
but
farmers
the
market.
booth fees are,
that's
are
separate.
paid by the farmers
By the
market,
farm-
are taken by the farmers
Are
market.
taken by the farmers
That's
market.
separate from the permitting fees.
Exactly.
Okay.
Can
And how long?
Can I add something to that, ma'am?
Yes, sir.
If you would think of it, I used to run markets, so
Okay.
if you would think about the farmer's market itself, much like a shopping mall. The individual tenants still have to maintain their own licensing and their own food safety or whatever they're doing. But the farmers markets, the fee for farmers markets are typically for coordination, promotion. Sometimes in some locations there's rent fees on the property that they're using that those have to be reimbursed. So if we all had pop-ups at a market, that's what those would go to.
I was literally just trying to figure out what the purpose of the permitting fees were. You already told me that I can move that out of the way.
Yeah, okay.
How long does it take to get these permits?
Ooh, another lawyer answer? Depends.
Yeah, I mean, sometimes it's taken us up to a month, sometimes with Travis County, when we've had to get the permits from Travis County Health Department.
Do you know if the permits pay the cost of dishes coming to inspect? Do you know that?
No, has nothing, the ones for the individual counties has nothing to do with the state.
So you just want to be able, if you have the state permit to go pay your booth fee at whatever farmer's market, and they can't do anything to you as long as you whip out your permit, that's it. That's enough.
So first of all, by the way, so DSHS does charge permit fees as
No,
well.
I'm saying,
So,
but
yeah.
But you have that one already.
Yeah,
You're
so
saying
the idea is,
you're-
yes.
You're like one
permit and
one
done.
permit fits all.
Yes,
is what
for
you're
the
asking
same
for.
business selling the same food, meeting those same standards. Yeah.
Okay, thank you.
Thank you.
Representative Schaffner.
What is the cost generally for the county health department permits?
That's what we
Again-
said earlier, ma'am. It can be $50 to $150. It really varies depending on the county, what they decide.
Thank you.
Okay. All right, thank you for your testimony.
Thank you.
Is there anyone else who wishes to testify on, for, or against House Bill 5459? If not, Chair recognizes Chairman Wilson to close.
Thank you, Mr. Chairman. I close.
Okay, members, any questions of Chairman Wilson? All right, thank you, Chairman Wilson. Chair withdraws committee substitute. If there's no objection, House Bill 5459 will be left pending. Is there objection? Chair hears none. House Bill 5459 is left pending. Chair lays out House Bill 1896. Chair recognizes Representative Cole to explain the bill.
Thank you, Chairman, committee members. Stan Gertis passed 1486, which required law enforcement agencies with telecommunications staff to have a mental health leave policy for telecommunications staff. However, EMS departments use licensed EMTs that do not receive the same licensing as required under HB 1486. This bill would close that loophole and allow all emergency telecommunication workers to benefit from mental health leave policies. The work that began in the 88th legislature is vital to care for our first responders, and mental health leave policy should cover all of those choosing to serve in public safety. I believe there is one witness from EMS to answer any questions. And I reserve my right to close.
Thank you. Members, any questions of Representative Cole? Okay, I think we have a witness. Chair calls James Monks. I show you registered as James Monks, Austin EMS Association, and self, testifying for House Bill 1896. Is that correct?
That's correct.
Thank you. You may proceed.
Good evening, Chairman Van Dever and committee members. My name is James Monks. I'm the president of the Austin EMS Association, and I am here to testify in favor of HB 1896. Last session, as Representative Cole pointed out, legislation requiring mental health leave policies for emergency telecommunicators passed, but there was a little bit of a loophole when since we have EMS dispatchers in our department, they go through different certification processes as opposed to other telecommunicators. And so essentially there's a little bit of a disparity. And so in Austin, Travis County, there's some comms folks that could get this leave policy, but our folks are unfortunately kind of left out of the loop. So essentially this bill would go ahead and close that loophole and ensure that we could provide that to our folks. So I appreciate y'all's time, and if y'all have any questions.
Okay, thank you. Members, any questions? Okay. Is there anyone else who would like to testify on, for, or against House Bill 1896? Hearing none, Chair recognizes Representative Cole to close.
Any questions? Thank you, Chairman.
Thank you, Representative Cole. If there's no objection, House Bill 1896 will be left pending. Is there objection? Chair hears none. House Bill 1896 is left pending. Good job. Chair lays out House Bill 4076. Chair recognizes Chairman Leach to explain the bill.
Thank you, Mr. Chairman. Good evening, members. I appreciate you allowing me the opportunity to lay out this important piece of legislation, House Bill 4076, to you today. Members, I know you've got a busy agenda tonight, so I'll be brief. Members, organ transplantation is a life-saving medical procedure for individuals with end-stage organ failure. Eligibility for organ transplantation is determined based on various medical criteria to ensure the best possible outcomes for both recipients of the organ and for the donor of the organ. There have been recent reports of patients who are being denied placement on transplant waiting lists, who are receiving lower priority on transplant waiting lists, or who are being refused related medical services solely due to their vaccination choices. While transplant centers must consider various health risks to ensure public safety, and for good reason, the lack of clear protections in Texas law has led to concerns that individuals could be unfairly excluded from receiving organ transplants for non-medically justified reasons. House Bill 4076, the legislation in front of you now, seeks to do something important but very simple and straightforward. It's simply to prevent discrimination against individuals seeking organ transplants in Texas based solely on their vaccination status. Under the bill, House Bill 4076, healthcare providers would be prohibited from doing the following. Number one, they would be prohibited from determining that a person is ineligible for an organ transplant solely due to their vaccination status. Two, they would be prohibited from denying medical services to transplantation, including evaluation, surgery, counseling, and post-operative care based solely on vaccination status. Three, they would be prohibited from refusing to refer an individual to a transplant center or a specialist because of their vaccination status. And finally, they would be prohibited from excluding individuals from transplant waiting lists or from assigning them a lower priority based solely on vaccination status. While protecting against discrimination, the bill allows healthcare providers to consider vaccination status when making individualized medical determinations if a physician assesses that it is medically relevant to the specific organ transplant. This will ensure that medical professionals retain the important ability to make necessary health-based decisions while also preventing unnecessary exclusion from life-saving transplant procedures. By establishing these protections, this bill aims to ensure that transplant eligibility decisions are fair, individualized, and that they're based on legitimate medical considerations rather than any non-medical institutional policies. Mr. Chairman, thank you again for hearing this bill. That is what it does. I'm happy to take any questions and would reserve my right to close.
Okay, we do have a couple of witnesses.
Thank you, Chairman.
We're going, Chair calls Michelle Evans and Jackie Schlegel. Okay, I have Michelle Evans, registered to testify on behalf of Texans for Vaccine Choice and yourself for House Bill 4076. Is that correct?
That is correct.
Thank you. Proceed.
Good evening, Chairman Van Dever, committee members. In 2023, the Texas legislature took a huge step toward expanding healthcare access and patients' rights by passing HB 44 to prevent certain providers from denying care based solely on vaccination status of the patient. Unfortunately, organ transplant patients were explicitly left out of these protections, and it did not apply to all healthcare providers in the state. As you can tell from my handout, specialists at facilities across Texas, including Texas Children's Hospital and Houston Methodist, have communicated to patients that they require any variety of vaccines in order to be placed on a transplant list. Some of these patients are not even a year old, and parents are being put into a situation in which they either comply with a flu vaccine, for example, or quite bluntly, die. Potential recipients have also been told they must comply with a COVID vaccine, even if they can show past infection and presumed immunity. These mandates not only make no logical sense, they are absolutely unethical. Our state has accepted that forcing Texans to choose between their job and a COVID shot is an egregious violation of liberty. What would it say about our lawmakers if they fail to have the political will to say that no Texan should have to sacrifice their ability to live a full and healthy life if they believe submitting to a vaccine would be a violation of their deeply held values? I appreciate Chairman Leach's willingness to engage with us about the need to expand this bill to include, at a minimum, medical device patients. And I'm speaking as myself here. My daughter, who suffered protracted and devastating adverse events following her routine infant vaccinations, was considered at age 7 a candidate for bilateral cochlear implants. Cochlear candidates endure months of exams with speech pathologists and audiologists, interviews with neuropsychologists, and a long list of diagnostic testing. After going through that, she was forced to undergo a series of vaccines in order to qualify for a needed surgery. We had to choose between possibly putting her at risk again or allowing her to access a full life with full hearing.
Thank you for your testimony. Chair recognizes Jackie Schlegel, testifying as the Executive Director for Texans for Medical Freedom, and yourself, and you're for House Bill 4076. Is that correct?
That is correct.
Thank
Thank you, Chair Van Dever. And first, I want to thank Chairman Leach for his unwavering dedication to vulnerable Texans and for the willingness to take on tough subjects like the one we're discussing today. As the Executive Director of Texans for Medical Freedom, I've received countless calls about patients being denied organ transplants solely due to vaccination status. Honestly, far more than I ever imagined possible. I'm not a transplant expert, but I have become a witness to the suffering of families caught in this deeply broken system. Let me tell you about one story. A dear friend's daughter entered end-stage renal failure at just 9 years old. Once stable and on dialysis, her family began the transplant referral process, only to be told she would not even be considered unless she received every single vaccine on the CDC schedule, including HPV, a vaccine for a sexually transmitted disease. She was 9 years old. On the advice of their physician, this family had previously stopped vaccinating after the child experienced a seizure following a DTaP shot, and they were willing to get her up to date on the school-required vaccines, but the hospital refused to accept titer tests and push full compliance even with vaccines that had previously harmed her. What's worse is they were told, if you don't comply, we'll just take you to court, and they meant it. The family began calling transplant centers all across the country, and what they discovered was chilling. Adult transplants programs varied widely, often allowing titer testing and showing flexibility, while pediatric centers were rigid, punitive, and absolute. When she turns 18, the same young woman transferred to an adult center out of state. Not only were vaccines not required, when they asked her whether to mention her exemption status to the transplant board, they were told, we don't do that with adults. Same diagnosis, same patient, same need, but wildly different standards simply based on the age and location of the transplant center.
Thank you for your testimony. Members, any questions? Representative Collier.
Thank you. Michelle, every now and then you get me on something. You'll get me like, you have my interest. And I'm like, oh, wait a minute, that's wrong. But I want to make sure I have a clear understanding So are there federal standards on being part of the transplant program? And does this bill change that?
There are, I believe, I don't know that there are any federal vaccine standards for transplant patients.
Okay, for qualifications to be in the transplant program. That's what I'm asking. I don't know if there is or not.
No, I think, like she said, it varies widely
From state to
depending
state.
on the center that you're in. So one of the families that reached out to us actually moved their entire family to Florida, and they were able to opt out of those requirements.
Okay, so then because what I want to understand is that if you're having a problem getting on the list, this doesn't change that if it's your time to be called up, like it's your turn on the list, and there's an active case of measles, and somebody in your family has measles, but you haven't received the measles vaccine, it doesn't prevent them from denying you the transplant.
Are you asking whether the bill would?
Yeah, there's a
prevent?
bill.
As far as I understand, the bill as written would prevent both. So the denial of being on the list or given lower priority or the denial of the transplant itself.
It would not, okay.
If, my understanding of how the bill is written, if there's a medically significant, reason, such as an outbreak, yes, that could be taken into consideration. The way the organ transplant system currently works is the very first step is an evaluation, and that's where they review your immunization status.
Right.
That's the goal of this bill, is to ensure that in that very first step that there's not a blanket denial of you're not up to date with every vaccine, therefore you're not getting on the list. That's what this fixes.
And Jackie, that's exactly what I was trying to distinguish. So thank you so much. That's exactly
Yes,
what I
ma'am.
wanted to know. Thank you.
Members, other questions? Representative Schaffner.
This is for both of y'all, how does this protect patients and doctors?
Well, these are life-saving procedures, right? And so a lot of the communication that we've gotten is for a flu vaccine requirement for an organ transplant. The flu vaccine has typically abysmal efficacy rates because it's predictive, right? So requiring that a flu vaccine is taken before somebody gets on an organ transplant list or receives the life-saving transplant, I think is, this would protect patients from being denied that based on very little scientific evidence that this would benefit them.
I would say medicine is not a one-size-fits-all, and this is going to strengthen the doctor-patient relationship. As many of you know, I have a medically complex child. This is not something in particular that I have dealt with in my own family, but anytime we can strengthen the doctor-patient relationship to allow them to make those decisions based on medical significance, I think is a step in the right direction for trust. And let's just be honest, mandates don't have a great track record of working, and I can assure you on this issue, they're not working. Families are just going without life-saving care, and I think that's unacceptable.
So this is individualized per
Yes.
the patient?
Yes.
Correct.
Thank you.
Chairman Frank.
Thank you, because I'm, in reading the bill, it's real clear. It says they cannot solely based on that.
Correct.
So like that is, honestly, I was talking to Chairman Leach, it's like, that is a very low bar. It's just saying, and the kind of amazing thing is that ever happened in this country, to be honest with you, that literally somebody said, only based on this and only that, we're just going to take you off the list. It is, I mean, to me, it is embarrassing, unscientific, and not the actions of a medical doctor to say, based solely on that. Because the bill then gives the doctors total carte blanche to make a decision. A physician who, in good faith, makes a determination that the vaccination status actually matters can take them off. But you just can't say because you don't have a certain type of vaccine that you're not on the list. And particularly, so is that y'all's understanding?
Yes.
I'll
Yes,
ask
sir.
a question. Because the other thing that you said, and this is the thing that bothers me the most about some of the way that COVID was handled, even when you prove that you had COVID in the past, something that we have literally since time immemorial is somebody gets a virus and you can show that you've got it, you have acquired immunity, but acquired immunity was not recognized by some in the medical community, and it's not most, but some in the medical community for somehow checked out and failed to recognize acquired immunity. Is that correct?
Yes, and there's also the idea that there are patient populations that are at higher risk of severe infection and patients that are at very low risk. So under 18, the pediatric population was not nearly as much of a risk as over 65. Yet in your packet, you can see that these children who are 1 year old, 17 years old, were being denied organ transplants because of the COVID vaccine.
Thank you, because I mean, I love the bill, but what it does is very little. It
Yeah.
literally just says, you can't do it. You can't just carte blanche say you can't.
It would
Be
be
there involved. You actually have to use medical-
life-saving for many of our families.
Yeah.
Life-saving.
Yeah, I apologize. I didn't mean to pretend I wasn't slamming the bill. I love the bill, but it is not something to be afraid of if you are
Yes.
on the other side. Thank you.
Thank you, sir.
Okay. All right, thank you for your testimony.
Thank you.
Thank you.
Is there anyone else who wishes to testify on, for, or against House Bill 4076? Not, Chair recognizes Chairman Leach to close on the bill.
Thank you, Chairman. I'll be brief, and Chairman Frank, I don't think I've ever considered it a compliment, more than as a badge of honor before when someone says my bill doesn't do anything. But I do know what you mean. No, I do know what you mean, and I think you make a great point. I'm being tongue-in-cheek when I say that. I get the heart and the intent of your comment. Members, the fact that this does happen should shock us. It kind of shocked my conscience when I first learned of it, that I couldn't just sit still. I had to file this legislation, and as I've learned more about it and have heard Jackie and Michelle and read the stories of folks who this has happened to, I'm more passionate and insistent that we do everything we can to get this solved. I can't think of anything worse than having either myself or even worse, having one of my children need an organ transplant to survive, and to find the perfect match, and everything else, every other box is checked for my child's life to be saved by the generous and sacrificial donation of an organ from someone else, only to be told by a medical professional, that's perfect for your child, that could save your child's life, but we can't do it because your child isn't vaccinated. I can't think of anything worse. My children are vaccinated, by the way, but for someone who doesn't vaccinate their child, I cannot think of anything worse, and that can't be the public policy of this state that we allow that. At least that's my position. I hope you agree with me, and I hope that you'll give favorable consideration to this bill as soon as possible.
Okay, we have a question, Representative Collier.
Okay, thank you, Mr. Chairman. Chair Leach, I just want to make sure, because Jackie made the very important distinction, in my opinion, that a physician or whoever's making the decisions, if there's an active outbreak of a condition, a disease, and that person's in that group, or they're near the people who have not been vaccinated, and their name comes up on the list because your bill's passed. If the medical team opines that, oh, it's just too risky because we've got this active outbreak, and you are in that community where, there's an active outbreak in your community, so we're going to have to skip over. Now, that's the reason why they are not being eligible for it, is because there's an active outbreak, and their chances of recovery or accepting the organ may be compromised if they catch the condition, whatever it is. So would your bill prohibit the physician from making that call?
No, it's a great question and a legit concern you've brought up. We've been very careful to craft the language to no pun intended, to take a scalpel approach to this problem instead of dropping a bomb on the problem. And so this still allows and respects the decision and the expertise of medical professionals to look at all of the facts of a transplantation, not only from the donor but from the recipient, and to make what's in their medical opinion the best medical decision for both. However, it's what the bill is simply doing in a nutshell is saying that solely the decision cannot be based solely on vaccination status. But certainly if they determine that there's going to be some sort of outbreak, or the donor or the recipient are going to suffer harm, then of course we wouldn't want that to go forward.
But that's because they're not vaccinated, and it's only for, like, I'm with you on, like, let them get on the list. But if there's nothing going on at the time and they're not vaccinated, then they should not be discriminated against. But if there is an active outbreak that they are closely associated or near, then that could compromise their recovery. But it's because of their vaccination status, and that's the type of situation I'm wondering if your bill limits.
So you just used the word that I believe best captures the heart of the bill, and that is discrimination. There are certain classes of people who, under the law, we do not discriminate based solely on. And it is truly an anti-discrimination bill. In other words, you cannot discriminate against someone solely because of the reason that they haven't been vaccinated.
Mm-hmm.
And so, yes, this still allows and respects the decision of the medical professional. And I don't know for certain, I could be wrong about this, and I may regret saying it, but I think the fact that again,
don't say it then.
Public testimony has closed. Saw those people behind me, but I think the fact that the Texas Hospital Association and Medical Association, we've been trying to work with them on this, and I think we've arrived at language that works for everybody.
Okay, sounds good.
No.
Representative Simmons.
Thank you, Chairman, and thank you for being here. I guess my question is around the discrimination term. Is it actually discrimination, or is it just a stringent set of requirements to make sure that the person who receives the transplant has the best case for survival? Because I'm looking up, and I know different states have different metrics on how they measure that, but it seems like there's a lot of different, very stringent criteria for people because there's such a limited amount of these available organs once somebody passes away and they're able to do the transplant. I'm trying to understand, is it actually discrimination, or is it just a limited supply and we have to have the best case for survival? And so maybe a vaccine status is a predictor of a person who's gonna try to maintain their health in a certain way because you can't be a smoker. There's a number of different things. And so I'm just a little, I guess, confused about it being discrimination versus we're just trying to make sure that the person that receives this transplant is going to do the things they need to do to stay alive, so this is not like a wasted opportunity.
Yeah, so Representative Simmons, again, it's a great question, and I don't use the word discrimination either in my testimony here, or as you'll see, we'll actually use it in the language of the bill. And the reason for that is because if I were to see an individual who needs a transplant, and I were to say, knowing nothing else about them, that they're not eligible simply and solely because they're not vaccinated, that is what this bill is truly targeting. And I do believe that that is discrimination. Without knowing any other factor, without caring about any other factor, me just carte blanche saying at the outset that they're not eligible for a transplant because they haven't been vaccinated, that is, in my mind, discrimination, which is why we use the word.
Members, other questions? Okay.
Thank you, Mr. Chairman. Thank you, members.
Thank you, Chairman Leach. If there's no objection, House Bill 4076 will be left pending. Is there objection? Chair hears none. House Bill 4076 is left pending.
Thank you, Mr. Chairman.
Chair lays out House Bill 3749. Chair lays out a complete committee substitute. Chair recognizes Representative Orr to explain the bill.
Thank you, Chairman Vandever and members. I wish I wasn't having to lay out this bill before you today, as it is in response to an unimaginable tragedy that occurred in my home House district. In 2023, a beloved mother, wife, friend named Jennifer Cleveland visited a med spa in Wortham, Texas for what should have been an easy, routine experience. However, the unthinkable happened when Jennifer received an elective IV treatment from the med spa director. The med spa director was not a medical professional, and her lack of necessary knowledge and experience resulted in the administering of a lethal infusion that tragically cost Jennifer her life. Now, while cases like this may be rare, they shouldn't happen at all. The goal of this legislation is not to disparage an industry or harm businesses that treat their patients well. The goal is to ensure patients receive safe and effective wellness care that they expect when visiting similar establishments. I have worked with a variety of stakeholders on this legislation for nearly a year, and I believe that the bill we have before you today is the most common sense approach to solving the problem that manifested in my House district. The committee substitute focuses solely on what went wrong in Jennifer's visit by requiring that a physician may only delegate the duties of an elective intravenous therapy to registered nurses, advanced practice registered nurses, and physician assistants. Through my numerous discussions with medical professionals and med spa representatives, I believe this change in law will be a tremendous step in the right direction for the safety of patients receiving this treatment. Lastly, this bill, if passed, will be named Jennifer's Law in memory of Jennifer Cleveland. Jennifer's husband's with us today, and my hope and prayer is that her family can find some solace, no matter how small, in knowing that her story will prevent similar tragedies from happening in our state. I know we have some medical professionals and representatives from the med spa industry here to provide additional information. With that, I welcome any questions and reserve the right to close.
Okay, members, any questions of Representative Orr? Okay, we'll call the witnesses and reserve your right. Chair calls Dr. Zeke Silva, Alex Thiersch, Alexis Gordon, and Brian Rudman. Okay, I have Dr. Zeke Silva testifying on behalf of Texas Medical Association and yourself for House Bill 3749. Is that correct?
That's correct, Mr. Chair.
Thank you.
Yep. Zeke Silva, interventional radiologist, San Antonio, speaking on behalf of the Texas Medical Association and speaking in favor, in support of House Bill 3749. TMA wants to thank and acknowledge Chair Orr for her important efforts. I mean, certainly the case that led to this being referred to as Jennifer's Law is significant. But we think even on a larger scale, we're obviously all seeing the growth in IV hydration services. IV lounges, recovery drips, hangover relief, pick a term and you can find it online or find it in your community. However, from our perspective as physicians, the administration of an IV, medication, fluids into the bloodstream is considered an invasive medical act. With that belief in mind, we think this bill will work toward strengthening protection from patients by ensuring that those professionals that are administering these IV fluids are doing so under the delegation of a physician, under the supervision requirements that the state implements for that process. And that's not just ordering, but that is also the administering of the intravenous therapy which is prescribed. Again, we think this will be an important step towards patient safety, making sure that physicians are engaged early in the process and that the appropriate supervision is provided so those individuals treating these patients in their clinics, we can ensure that they're qualified and that the patients have the best outcomes possible given the therapy they are pursuing. I want to be clear, members, we are talking about elective IV therapy, statutory language to unify that service with established medical practice of traditional IV therapy for therapeutic purposes in a medical setting. With that, on behalf of the TMA, I'm pleased. I want to thank Chair Orr again. We're honored to support this bill, House Bill 3749. Thank you.
Okay, thank you. Chair recognizes Alex Thiersch, testifying as CEO of American Med Spa Association. On behalf of the American Med Spa Association for House Bill 3749, is that correct?
Yes, sir.
Thank you. Please.
Thank you, and thank you to the committee. And I also want to say thank you deeply to Representative Orr for her very, very hard work on this bill. I think it has been a tremendous effort, and she has been very receptive and listened to all the feedback that we have provided. And I think what she has arrived at is certainly the best that we could have certainly hoped for in this situation. From a medical spa perspective, we're devastated to learn what happened to Jennifer Cleveland, and we believe wholeheartedly that we should, all of us in our industry and in the IV therapy industry, should be doing whatever we can to ensure that that will never happen again. We believe that this bill goes a long way to shining the light on what some of the issues are in this industry. This is an industry driven by small business, many of which are owned by women. The issues that we deal with, though, and the one thing I would like to highlight to this committee is that regardless of what we do and what we pass with this bill or others, some of the primary issues that we deal with in the IV industry and the med spa industry deal with actors who do not follow the law and who are doing things beyond the scope of what they're supposed to do anyway. And that is the thing that we most want to draw attention to so that we can start enforcement and education of those medical spas, those IV clinics that are not doing things the correct way. It is absolutely correct. This is medical treatment. They should be, these IV centers, these treatments should be and are in fact treated as medical treatments. They were in fact treated as medical treatments prior to this bill. I think what this bill does, though, is it does draw attention to the fact. And we support this bill, and we look forward to answering any questions. Thank you.
Thank you. Chair recognizes Dr. Alexis Gordon, testifying on behalf of American Medical Spa Association and self for House Bill 3749. Is that correct?
Yes, that's correct.
Thank you.
Thank you, Chairman, and thank you, members of the committee, for listening after a long day. Like Alex and Dr. said over here, the IV clinics are medical clinics. Med spas are classified as medical practices in Texas and have been for some time now. And they must be treated as such. And so there must be proper supervision by an MD who can then delegate if they feel like they meet the requirements to an NP, an advanced practitioner, or even an RN, with proper on-site protocols for safety, communication, and a way to address complications. Something that what happened to Jennifer Cleveland never should have happened, and it just saddens me greatly, because I know that while the med spa industry is growing and these laws have been in place, there's not a lot of awareness of these laws. And the IV, I thank Representative Orr tremendously for narrowing it down to the IV clinics for now, but there are several complications that can happen even in well-trained hospitals with well-trained staff with IVs. I think the percentage was something like 43% of complications can happen even in a well-trained facility. So most of the as far as clinical aspects, the most serious complications from IV therapy occur under three main conditions, and it's improper evaluation or diagnosis of a patient or their medical conditions, improper mixtures which were administered, or incorrect dosages, and all three of these sadly occurred with Jennifer Cleveland. Again, we have to be very vigilant about treating this as it is. It's infusing substances into the human body, and without knowing someone's medical history or proper way to deal with any complication, this could be a disaster, and it was. We are dedicated in AmSpa to really do whatever we can to eliminate the clinics that are operating without supervision.
Thank you.
Thank you.
Thank you for your testimony.
Appreciate it.
Okay. Chair recognizes Brian Rudman, Dr. Brian Rudman, testifying on behalf of Formula Wellness for House Bill 3749. Is that correct?
That's correct.
Thank you. Proceed.
Chairman and committee members, my name is Brian Rudman. I'm a practicing physician with over 20 years of experience. I'm also the co-founder and chief medical officer of Formula Wellness, a Texas-based organization that provides medical and aesthetic services focused on wellness, disease prevention, and overall health and well-being. As chief medical officer, I lead a team of licensed and dedicated clinicians who are committed to serving our patients and ensuring their safety. To achieve this, Formula Wellness operates a clinical advisory board structure that promotes collaboration amongst all providers and locations. The structure includes the standardization of clinical policies and protocols, comprehensive training for Formula Wellness providers, and the careful evaluation of emerging technologies and treatments. We appreciate Representative Orr's efforts to bring attention to our area of practice and the importance of patient safety and proper clinical oversight. We believe that the revised version of House Bill 3749 correctly focuses on elective intravenous therapy and recognizes the vital role that nurse practitioners, physician assistants, and registered nurses play in comprehensive clinical care and patient service. These providers are essential components to the healthcare ecosystem in Texas, and their contributions should be recognized and supported. Thank you for your time. We look forward to working with you in the future to promote health, wellness, and safety for all Texans.
Thank you. Representative Frank.
Yeah, thank you. And this is really for anybody who can answer it. How are these regulated now? I think you said these are already medical procedures, therefore, are people operating outside the law now?
Yes, sir.
So, and if so, then what is the bill actually doing? Are we just bringing enforcement to it? So,
right. So it's a tricky question. Right now, these laws have existed, and the people operating outside of the law either say that they didn't know, or they're trying to go around it. And so this bill, though, as Alex said, really does bring attention to it. It's horrible that it took a tragedy like this to bring attention, but we are committed to working on the next step. We see this as a stepping stone to further get some regulations.
And Chair Frank, to expand, I think that was a very good answer. To expand on that, in the current law, there's no clear, bright line definition of elective IV therapy versus other medical practice. This statute will clearly define what IV therapy is and unify that with existing laws regarding IV therapy in general.
okay, because right now, I guess I could have saline drip or something, and maybe that would be, maybe it wouldn't be considered a medical procedure right now, or it'd be a gray area. Y'all would say it is. Others might say it isn't. Okay. No, I'm just trying to understand. I'm not that familiar with med spa, and I can't
So
spend a lot of time on it, but I just was.
I think the answer is that is considered a medical treatment, and under current medical law in Texas, that would be covered. However, this is much more definitive in what it is saying, and it shines a light on it so that people actually know. For whatever reason, I think your point is well taken. That distinguish between folks who are doing IV treatments, getting a saline drip, they don't realize that is in fact medical treatment, but it is in fact medical treatment. It is in fact covered by all the medical rules right now. What I was mentioning before is we do need to also make sure that we are enforcing these rules, but I think that to the point you were making, it is very clear that it does make it much more obvious, which is not a bad thing.
Okay, thank you, Chairman.
Representative Alcott.
Yeah, my question might have been answered. I had the same question because Ms. Gordon, you had mentioned that there are laws that already exist that kind of prevents this, and so, like, what are those exact laws? I'm just trying to figure out what. So you're saying that what happened in this particular case that Representative Ward brought to our attention, they were likely breaking the law?
Exactly.
Okay.
Yes, this
And
was an,
so like what?
So
what
that
law
so
is
the
that?
law currently states that if a physician is properly supervising, i.e., that's kind of a broad term, but feels that the person is well trained, is the medical director on site actively involved, taking a history physical, all the medical conditions that this person has, then if this physician feels comfortable to say, okay, you can do this procedure and they're well trained, then they can do it. So that's part of the law. The part that happened with this particular case is that this person was non-medical whatsoever. There was no proper oversight, and the medical director was about 107 miles away, and there wasn't a proper protocol in place.
So if this law passes, the physician would be required to be on premises?
No, not necessarily. That it just to treat it like any other medical clinic that we have now, any other medical practice, which has certain rules about the delegation and the distance between the medical director and or delegating to an NP/PA.
Okay, thank you.
Thank you.
Members, other questions? Okay, thank you for your testimony. Oh, I'm sorry, Representative Jones.
So how specifically does, if it's already against the law, how specifically, like, what is different with this bill and the one that it's amending? It defines IV, elective intravenous therapy. Is that one of the?
It's not so much about the definition. It's more about the oversight and making sure that that patient is actually a candidate. I don't want to get into specifics. I don't know if I can about the case, but essentially this person had a pre-existing medical condition and there wasn't a proper history and physical performed. The non-medical person ordered some a substance that's very, very dangerous and had no medical knowledge of that, and then it was administered. So this law would require
a doctor, a physician to do it, and they have to supervise or monitor the people.
Right, they have to pre-screen the patient. And it can be a physician who then delegates to a nurse practitioner or advanced practitioner to do a history and physical, which is like any other medical clinic in Texas.
If I could, I'm also, I'm a lawyer also who practices in healthcare law. How I got into this, the way it works under the Texas Medical Practice Act, well, the rules made by the Texas Medical Board, is that the physician-owned practice, anyone who comes in for a medical treatment needs to be seen by either a nurse practitioner, a PA, or a physician, in which case the physician can then delegate down to somebody else to do the treatment. The issue that we were dealing with here is that, and order, under proper circumstances, the issue that we're dealing with here is that IV treatment for whatever reason, as it's been built up and grown up in this industry, has not been seen uniformly, I think we can all agree, as medical treatment. So there's been a lot of folks who don't believe that it is in fact medical treatment, so these rules have kind of been skirted. What this bill does is defines it specifically as this is medical treatment, and it slides it into those rules, Chapter 157, subchapters A, B, and B, Texas Medical TMB Rule 168, 25.25 to 228. These are the rules that are applied as it does to any other doctor's office.
So now what this bill does is it says, hey, this is actually medical treatment.
Correct.
Hey, a doctor's got to supervise or monitor or delegate.
Correct.
But you're not going to treat this, I guess, as like a walk-in treatment where anybody who hangs their shingle can order these drugs that can kill you, like they did.
Correct.
So that, this isn't done in a doctor's office. This is done in a spa.
Some are.
Yeah, I can take that. So there's a wide range of kind of retail-based clinics that it is currently being practiced in Texas. And the majority of these are operated as medical clinics or medical aesthetic clinics where these services are then performed. There's been a lack of clarity in the regulations on who can perform these services. Are they a defined medical act? There's not a lot of controversy of if someone was coming in to get, a minor surgery or even, an aggressive laser or Botox, whether that patient would need to be, seen or evaluated by someone first. There has been a lot of gray
Seen or
area.
evaluated by somebody. Does that mean
By
a doctor?
by at least an advanced practice practitioner. Or
But who's been delegated that authority by a physician?
correct.
All right.
But there has been this gray area since IV therapy or vitamin IV therapy has come into practice over the last 10 years. So this really defines kind of a minimum set of standards and really some level of credentialing of the people that the physician can delegate the acts of services to.
Okay, thank you.
Representative Frank.
Just a clarifying, and maybe you can't talk about the case, who wrote the prescription for this dangerous drug that was taken? There wouldn't be a non-medical person couldn't write a prescription for it.
As I understand it, she used the medical directors, who was remote and
And the medical
no
director
knowledge.
was a what?
So,
Anesthesiologist.
anesthesiologist.
So the medical director was a doctor, so so she was already, so how would that, like if I,
Well, they're not allowed to order it. The physician would have had to order it, and the person, I guess, illegally took
right, but I
his
mean,
or
there's
her
nothing,
number.
there's
don't know
nothing
the
in what we're
specifics.
doing here that would change somebody breaking the law.
Right,
And I mean.
but it brings awareness.
Well, I guess, guess I'm saying that this person was already working under the doctor. I mean, they had their script. I'm not familiar with it, but I'm
Yeah,
just
no.
saying,
So, Chair
like a
Frank-
non-medical person can't write a prescription unless they steal it.
Which is what I believe
Right, so-
happened. I can't speak to that for sure, but that's what my understanding.
It's
I
an
just don't
important
see how- I
question.
don't see how this
Chair Frank.
changes
So,
that.
so within our state as physicians, the state has given us prescriptive authority.
Right.
So we can order anyone else that does what we are otherwise allowed to do by an order, established protocol, or through delegation. So for this clinic, the supervising physician was an anesthesiologist. That physician delegated their authority to this clinic to order the medication which is administered and to administer it. The challenge was the individual that administered the medications under this law would not be a qualified professional to do that. It has to be an APRN or an MP or as defined by statute.
But right now, given the
Qualified.
delegating authority and the fact that isn't that doctor the one that was at fault? They literally had somebody who was non-medical, and they gave a non-medical person the ability to write prescriptions on their behalf. How is that not the doctor's fault in that case?
It is. The TMB views that as being.
Well, and so, okay, and so we want to make sure that that's the person that's now delegated.
Well,
It's
it's
just,
too.
I'm like, I don't know that this solves that.
Well, what it does,
if
Chair
somebody-
Frank, is it makes sure that that delegation is strengthened. The qualifications of who we can delegate to are better defined in the bill. It has to be a PA or an APRN who has licensure within their own standards. But I think an important piece of the delegation expectation is our supervision involves overseeing protocols. For example, in an emergency situation, we can decide what medications we are willing to delegate and which ones we are not. And by establishing those protocols, you standardize in a way that would enable patient safety, that supervision to enable the best care.
But it's
And then
just
we're
our-
available if there's a problem
It's
also.
just ironic, though, that the delegation that the doctor did to a non-medical person is why we're saying that we got to make sure that doctors are in charge of it. It just
But it was
seems odd
it
to
was a
me.
phlebotomist. It wasn't a licensed professional. That person should
Right,
not have been.
but that doctor is the one that gave him the ability to do that.
Right.
That's where I'm like, I mean, why, that's a abuse of
I think there's
delegation
a certain-
authority.
If I may, there's a certain, I understand your frustration. We are dealing with this frustration as well, because a lot of the issues that we are dealing with as an industry aren't because the rules aren't there, it's because they're not followed. I think what I really appreciate about this bill, though, is because unfortunately, we do need to bring awareness to it. And just the fact of the bill itself, I think, does that. So I understand what you're saying. This is a first step. This is a first step.
If I could add, it's the fact that there is not clarity in the standards right now. It seems very clear when we say that these people, clearly in this case, there are multiple things that went wrong and multiple bad decisions made along the way that were, either malpractice or violated the law. So it is an extreme example that's bringing this to light, but there is so much gray and there's lack of clarity based upon what the minimum standards in the state of Texas are and should be. The minimum standards should be, there should be physicians who are engaged, who set policy, who set protocol, who know what is happening in their clinics, and not just a medical director who's hundreds of miles away who collects a $2,000 a month check. These doctors need to know what's in their protocols. They need to be able to delegate them to advanced practice practitioners and registered nurses who are certified and credentialed by TDLR.
Representative Simmons.
Thank you, Chairman. So just really quick, one in clarification. I know that, does this bill apply to like those mobile kind of pop-up hydration clinics, or is this just, okay, thank you.
Absolutely.
We were talking about it in the back. We were trying to figure out what is this, and I had a scenario where we had attended an event and people were just there injecting people, and I was like, oh, okay.
That's exactly what we're talking about. Yeah.
Representative Alcott.
Yes. Are you all allowed to say in regard to this particular case, like what was the drug that was administered? And I'm still trying to understand, was the physician that was 107 miles away, was he even aware that that drug was ordered in this particular case?
It's my understanding that he was not aware.
And so this gets back to Representative Frank's question.
Right.
How is that, and maybe Dr. Silver, you can help shed light on this. Is this common that we have phlebotomists ordering drugs?
It
I mean,
should not
how is
be.
that even possible?
It's not possible. That's why this was all
So
outside of the law.
How did that even happen? So you're in,
Yeah, we're just as baffled as you guys, and I hear the frustration, and so are we, and that's why I'm.
and that is under current law, even if this bill does not pass, that's illegal for a
Correct.
phlebotomist. Are you allowed to say what this drug was?
I am aware. I don't know if I can talk about
Without,
it.
since we don't.
It's a,
Or not,
I
okay.
can say it. So it's a nutrition substance that's used only in very, very ICU types of patients where they can't even have a gastric tube or any kind of nutrition. And it has a lot of electrolytes, and I believe what happened is this person who owns the clinic thought that, wow, if a little is good, a lot's better. And unfortunately, administered, I don't even know how it was ordered, to be honest with you, and that it has a lot of potassium, and this person had a cardiac event.
So Dr. Silver, I mean, just in more general terms, even outside this bill, what is required for a drug to be ordered? I mean, so it sounds like does a physician actually have to be aware of any drug that's ever ordered? Is that the law?
When we delegate that authority to another professional, part of that is adequate supervision.
Another professional other than a physician?
An APRN or
Okay.
an NP or a physician assistant, not the professional here. This professional, under the current law and as it exists today and going forward, was not a qualified individual. So that is problematic from the beginning. However, going forward, when we delegate that authority, the prescriptive authority, to a PA or an APRN, part of that is us ensuring adequate supervision. It is our responsibility to make sure within sound medical judgment that that is sufficient. And that's going to be informed by a number of factors, not just the clinical circumstance of the patient and the protocol, et cetera, but even our understanding and relationship with that other professional, our understanding of their training, our understanding of their qualifications, of their experience. And we have to be available to them if there is an untoward event like occurred in this case.
Sure, but you're saying that it is not illegal today for a physician to assign that ability to an RN or a PA right now, and they can actually order medication without even notifying the doctor. And the presumption is the doctor has already gone through that training and telling this, in these certain circumstances, I can order this, that you can order this certain drug.
Right.
So that's not, it's not even required. They're not breaking a law if that happens today. If it's done,
You said RN, just to clear, but APRN, an advanced
APRN,
practice
okay.
registered nurse, but just to be clear, those that licensed under that authority, no, that is the nature of delegation of one's prescriptive authority.
I wasn't aware of that.
Those
And with there are requirements for the prescriptive authority agreement where there has to be certain training, there's meeting requirements. It's not just do it, there are requirements to it, but that is true in all areas of
It's in
medicine.
the agreement.
Thank you.
Representative Schaffner.
I might have missed this, but to the current law, are APRNs required to be at these med spas? Or RNs, or?
So typically, at a medical spa should be treated as any other medical practice. So the way it should work is at least there should be some medical professional at the medical spa.
But reality is what?
The reality is oftentimes there is not. It depends. Most are doing very, very good work and are patient-centered. The problems that we tend to see are ones that don't. There's two separate issues there. I mean, one is who's required to be at the medical spa. The other is delegation and supervision are very different things. So when you're delegating a treatment, doing that correctly, doing it under the proper standard of care is one thing. Do you have to actually be physically on site to supervise is a whole other thing. You can, according to the letter of the law in Texas, you can be off-site, but you have to be immediately available to deal with emergencies. You have to have protocols in place that are written. The person doing the treatment has to be trained and qualified. All of those things have to be satisfied.
But each one of these medical spas have some sort of delegating physician attached to them.
They're supposed to have a delegating physician, and at least,
I mean,
and or an
law,
APRN.
but
or a
reality is, so they
Reality
don't
is some
even,
don't,
so then
some
how
don't.
how do they get the treatments? How do they get the,
So, well, typically sometimes what happens is the physician, and I think the point was made about, we call them absentee physicians, where physicians will kind of lease out their
right,
licenses.
no, I understand that they're in
And so
Alaska
what
or
they will
something,
do
but-
is they will lease out their license, and then
Right.
orders will be made for drugs through that physician's license. And then when patients come in, an RN or someone who is not qualified will then just make the order without the physician's knowledge, or the physician's general knowledge, right? So the
Right, right.
physician knows this is going on, but they're not exactly paying as much attention as they should.
Right, but again, today's law says that these medical spas don't have to have an APRN or RN and don't have to have a physician attached to it.
No, that's not exactly true. Any medical spa under today's law needs to have at least an APRN, a PA, and a physician who is doing the actual ordering of medical treatment, right? And an RN in some instances can do treatments, like in this law would be the IV,
Right.
Botox, things like that. But absolutely, there is supposed to be.
By law.
By
there's-
law.
They have,
Correct.
the law states today that they have to have some sort of physician
Correct.
and/or
Correct.
APRN, RN.
Correct.
Representative Schaffner, and I'll be quick. In October 2023, the Texas Medical Board put out a notice regarding this emerging new model. So I think there was some perception that an IV was not considered an invasive medical act. As soon as the medical board made that clarifying decision, it fell under the laws that were just described, where supervision and delegation had to be sufficient. Before that, it was probably a little less unclear. And the important part of this bill is it will strengthen those definitions even further to protect patients.
Thank you.
Okay, members, other questions? Okay, thank you for your testimony.
Thank you.
Thank you for your time.
Chair calls Mary Kelly Green, Brian Cleveland, and Patricia Aranan. show Dr. Mary Kelly Green testifying on behalf of Texas 400 and yourself, and you are for House Bill 3749. Is that correct?
Yes, sir. Thank you, Mr. Chairman, Madam Vice Chair, and committee members for hearing a lot of testimony. I'm an MD eye surgeon here in Texas. Before July 10th, 2023, we physicians knew that we were going to see someone killed at a Texas med spa. It happened that day, sadly, the day Jennifer died. This bill seeks to end the practices that make Texans less safe during an IV infusion. You all have seen these places, essentially non-medical places. I've personally called some of them and discovered their ridiculous practices. There is a group that follows the rodeo circuit, giving prescription medications to the rodeo contestants. No physician is involved in that. There is a person in Llano, Texas, not a nurse or a physician, who told me he will come to my house and give me an IV in his van. What many people do not know is that there is risk to getting an IV. As a physician, I know that very well. For example, the IV that killed Jennifer essentially had the lethal injection ingredient in it, potassium. So she died alone in a room with the lethal injection. The non-medical person who gave the IV is now being investigated by the Attorney General's office for criminal charges. The supervising physician is also being investigated. Folks are even getting IVs at the gym. There are several Texas cases of these infusions causing vitamin toxicity. The patients never even knew what was being infused into their bodies, and in some cases, as in the case with Jennifer, even the person giving the infusion didn't know what they were infusing. I personally disagree and professionally disagree with the use of IVs for elective purposes. But if our society is going to adopt this practice, there must be guardrails in place so that no child will ever hear that her mother was killed at a Texas med spa. Thank you.
Thank you. Chair recognizes Brian Cleveland, testifying on behalf of yourself. You're for House Bill 3749. Is that correct?
Yes, sir.
Please proceed.
I appreciate y'all letting me speak here today. I'm not, just about everybody that's been up here before me has covered just about everything I wrote down I wanted to talk about today. And so I'm just going to leave my piece of paper there in my hat. And I'll just, I'd like to thank Representative Orr for everything that she's done for Jennifer's family. Dr. Kelly Green for everything that she's done for Jennifer's family. Still a little tough for me sometimes, but our family would like to, you know, to ensure that this doesn't happen to anybody else. And, you know, everything I was going to cover here, and I will say, like Dr. Green just said, that the people behind this are the Attorney General's office is investigating them on criminal charges. And that's about as far as I'll go into it. I'm going to shut up right there, but I appreciate it.
Thank you. Thank you for your testimony. Chair recognizes Patricia Aranan. Dr. Patricia Aranan, testifying on behalf of Texas 400 and yourself for House Bill 3749. Is that correct?
That's correct.
Thank you. Proceed.
So I am Dr. Patricia Aronin, a retired physician, as you said, representing myself and Texas 400 in favor of Jennifer's Law. Med spas, as everyone has said, are medical practices. And I hope the legislature will, the committee will understand that over the last decade, the legislature has repeatedly enacted laws that have continued to weaken the whole concept of supervision that you all are asking about. And it's now left us with two really serious problems that we're dealing with med spas and IV hydration centers. There are non-physician health practitioners owning med spas and using sham supervision by physicians who are not trained in what's being done, and yet their licenses are being used to order the drugs and things that are being used. And because you have enacted laws that removed supervision, distance requirements for supervision, you have a situation that happened here with Jennifer, that her supervising physician was nowhere near to be of any help. And then added to that, you have created an environment that lets bad actors win. And so There are lots of people out there owning med spas who have absolutely no healthcare experience. Some of them have sham medical directors, and they order the drugs through those sham medical directors. And others, like the recent arrests that just happened in Houston, you have people who have no medical training at all, and since they don't have a medical director, they order counterfeit drugs and counterfeit IV solutions, and people get hurt. You know, so just because you hire a nurse or hire an EMT to be giving the IV therapy doesn't mean it's safe, because you don't know if the person who's ordering the stuff doesn't know it's being infused. It's not safe, and people will be hurt. So this is a public safety issue, unless you feel that there isn't any reason for a medical practice to order a drug.
Thank you for your testimony. Representative Frank?
You mentioned laws that we have changed on delegating, and the only one that I heard you mention was the distance. Aren't physicians responsible for who they delegate to? I mean, and I'll back that up with the second question is, don't we have an organization called the Texas Medical Board that the legislature has asked this group of doctors to oversee themselves?
Good.
Do the legislature need to take that back from the Texas Medical Board because they're not doing a good job? Because that's where we have put the authority, I believe. Now,
Okay.
whether that's correct or whether that's a good way or not, but you're laying it on us, and I'm happy to take blame for anything that we've done stupid, but we've asked the doctors to regulate themselves. Go ahead.
Okay, so I'm glad you asked the question. So I think the problem is, if you look at it across the board, the majority of doctors are good and supervise appropriately and really believe in appropriate supervision. But with the continued removal of the requirements for supervision, you let bad actors.
You said continual removal, so what, other than the distance, which in some cases in a rural area, you may have 150 miles, it doesn't mean they're not supervising. It certainly doesn't mean they're allowing prescriptions from a phlebotomist.
No, but it went from you were supervising a person who was in your office with you and you knew everything they were doing. Or well, for the 40 years I practiced, all the nurse practitioners I worked with were in the hospital with me. And so it went from that kind of model to, well, they could be across town, to now they could be anywhere. And now you actually have people with a Texas license living in California who are supervising someone who's in Austin, Texas. That's not supervision, that's crazy. The second thing is there's no requirement that the person supervising or delegating actually does what that person who's doing the procedure is doing. So it's created, and so what happens is the scum rises to the top. You have dishonest people who do things like has happened. You have this anesthesiologist supervising someone from a bazillion miles away. You also have a
So
situation.
do we need to have a better, more rigid legal framework for what it means to delegate? If you're going to delegate, do we need a more rigid framework for what that actually means and hold the doctors accountable when they're delegating and not just trust the doctors to be doctors, which is what we're always told, honestly. Hey, let the doctors be doctors. They're smarter than you. And
I mean, I think there's two parts to that. I think that there has to be a better framework. There also has to be, I gave you in that handout there, I'm sorry, it's really tiny print, but just a random selection of med spas across the state. It's several hundred of them, and it's not all of them. It's just random ones that we were able to identify, where the people who own them are not medical doctors.
Let's talk about the delegation.
Okay, but that's what I want to say to you is, okay, the Medical Practice Act says a medical practice has to be owned by a physician. Yet you have all these med spas out there that aren't. Why is that? Because you register a business with the Secretary of State who doesn't know what, La-di-da's, X company is, okay? So there's no one who knows that business is actually a med spa. So there's no way, and the TMB has no way of knowing.
Okay,
The only
that's
way
fair.
they can do and enforce is if people report them. So that's the catch-22 that's been created. It's impossible to enforce something if you don't know they're out there.
Right. Although with the delegating authority, you're not getting prescription drugs without the doctor, right?
You are. Look at the things that are on those IV therapy, that menu of
Prescription
Starbucks
drugs,
stuff.
you-
But no, there's IV therapies that include, you get Zofran, that's a drug. You get Benadryl. That's a drug.
Prescription drugs.
Those are prescription drugs. You cannot get IV Decadron without a prescription. You can't
So
get.
how are they getting it? And I'll
Because what
sorry.
happens is, so.
I mean, how do they get it without a doctor?
I am dishonest doctor, okay? There is a doctor on the list I gave you there who delegates to over 400 hours of delegation. Tell me how he does
So
that.
does the TMB have authority over that doctor, or is that
Yes, and
something that
guy's
we are
already-
supposed to be doing?
That guy has already been, reprimanded twice. Personally, I think
Was
he
he
should
still
lose the
writing? Does he
license.
still have 400? Yeah, I'm sorry, we're getting a little bit away from the bill.
Okay.
I just, so I'll-
It should be, there has to be a way to say, let's rein back in what supervision means. And yes, there has to be all the bills in the world are meaningless if we don't have a way to enforce them.
I
And
agree
right
with that.
now, the problem is there's no enforcement. There's no way to know.
I agree with that, but
these
if at least to the extent that you're doing prescription drugs, I believe it requires a doctor to do a prescription drug in the state of Texas. Prescription.
Correct.
We may argue that some of these things are, a saline drip, you say is the practice of medicine, and so somebody could do that without. But if it's a prescription, it has to have a doctor.
Correct.
So it would seem that if we're going to try to rein this stuff in, we need to focus on actually overseeing doctors, including the delegation practice. That's my opinion. Thank you. Thank you, Chairman.
Thank you. Representative Jones.
Is it Dr. Green, Dr. Kelly Green? Dr. Green? Okay.
Whatever you'd like, ma'am.
So I've got, how does the Texas Medical Board deal with improper supervision/delegation by physicians?
It's the medical board, after, as Dr. Silva mentioned, after Jennifer passed away, the medical board did take a much more active interest in this practice because it was sort of brought to light how it was proliferating, perhaps out of control. And so we did start getting missives from the medical board detailing all the things to us. If you open your email, you read it. You, doctor, must do these things. You may not do these things. And then we also started seeing in our, we get emails after every medical board meeting about how the physicians that are doing improper supervision delegation are being punished. And so I get an email and it says, hey, if you do this, doctor, because you can see someone got punished for it, and then you're going to get this punishment. You're going to get sanctioned. You're going to get fined. It's going to appear, we've talked about how the medical board has it right there for all the world to see. If I get punished, it's a big red button on my med board, profile. And so any patient that wants to come see me and looks it up is going to see I've been punished. And so, that does happen, and it is happening. And I think that the awareness is there, unfortunately, since Jennifer died, at a higher level, at the medical board level.
Another question. So what did the Texas Medical Board do to the physician who was improperly supervising?
So he was a fellowship, I guess he still is a fellowship-trained cardiothoracic anesthesiologist, and he was 109 miles away in Frisco when Jennifer died. So he should have known what she was doing. That's the whole point. He should have known. He should have gone to that place and seen what she was ordering. If any physician had seen that she was ordering total parenteral nutrition to infuse into an outpatient in a peripheral IV, even a psychiatrist, even an ophthalmologist like me knows that's wrong. And so he had no idea. That is also his fault, right? He should have known. It was his duty to not rent out his license, to attend that place and see what that person's ordering. I've had other physicians since all that happened ask me, hey, I was thinking about being medical director of this place. Should I do it? And I'm like, you ask me, so you know what I'm going to say. So, I tell them, you have to go to that place when it's open and see how it's working. You have to go to that place when it's closed and look in all the cabinets and look in the computers and see what are they doing here. If your name is on it, if your license is there, you need to know what's happening, and you also need to be trained in those procedures. I'm an ophthalmologist. I'm not going to do, a bunch of body stuff. That's not my jam. I'm here up. And so, if I were family medicine, I'm not going to have a med spa. That's not my jam. I'm family medicine,
So do you know if the doctor lost his license?
So
Do you know?
his license was severely restricted initially, and he, I'm sure with the help of an attorney, did have it. The punishments were reduced, but initially the restriction was that he couldn't delegate any act, which means if he wanted his patient to get a Tylenol, he had to go get it himself from the Pyxis and hand it to the patient. So that got a lot of people's attention. We all got an e-blast about that when it happened from the medical board.
But he still has his license.
Yes, as far as I know.
That's, oh, well, I will save my opinion about that. Mr. Cleveland,
Yes, ma'am.
if you don't mind me asking, you have the same last name as Jennifer.
Yes, ma'am.
How are you related to
She was
Jennifer?
my wife.
Okay, I'm sorry for your loss.
I appreciate it.
And thank you for coming here and helping us understand what happened to your wife. And so, I guess for the most part, you've turned tragedy into hopefully triumph.
We're working on it. We're
Okay.
trying.
Well, again, thank you for coming.
I appreciate it. Thank you.
Members, other questions? Thank you for your testimony. Mr. Cleveland, thank you for being here. Is there anyone else who wishes to testify on, for, or against House Bill 3749? If not, Chair recognizes Representative Orr to close on her bill.
Thank you. I appreciate your thoughtful questions. And with that, I close.
Okay, members, any questions for Representative Orr? Okay, thank you. Chair withdraws committee substitute. If there's no objection, House Bill 3749 will be left pending. Is there objection? Chair hears none. House Bill 3749 is left pending. Chair lays out House Bill 2806 and recognizes Representative Lujan to explain the bill. Chair lays out a complete committee substitute and recognizes Representative Lujan to explain the bill.
Thank you, Chairman Vandever, Vice Chair Campos, and committee members. Imagine sending your loved one out for a walk and never seeing them come home again. That's what happened to Ramon Nájera, an 81-year-old Air Force veteran mauled to death by loose dogs in San Antonio, in a neighborhood in San Antonio. Just a few months later, a 1-year-old boy in Converse, which is in my district, was killed when a dangerous dog attacked him while he was under babysitter's care. These aren't rare accidents, they're preventable tragedies. Unfortunately, the current law isn't strong enough to stop these deaths. Right now, unless a dog attack causes serious bodily injury or death, owners often face no real consequences. HB 2806 updates the law by creating a tiered penalty system. It's a Class B misdemeanor for bodily injury, a third-degree felony for serious bodily injury, and a second-degree felony if someone is killed. HB 2806 allows animal control officers to issue dangerous dog reports, and we work closely with the City of San Antonio, law enforcement, animal control to strike the right balance. Lastly, HB 2806 strengthens witness protections, making sure that individuals who report attacks are shielded and their identities kept confidential under the law. The committee substitute reflects changes from stockholders making the following changes. Titles the act as the Ramon Nájera Act in naming of the 81-year-old Air Force veteran that passed. Clarifies that animal control services may report dangerous dogs when appropriate rather than mandating investigations, and removes the new restriction prohibiting dog ownership after multiple dangerous dog convictions. Members, HB 2806 is about protecting Texans before the next preventable death. It's about giving cities and counties real tools, not just reactions after the fact. And it's about honoring the lives already lost by making sure the law reflects the seriousness of these attacks. I'm happy to answer any questions and respectfully reserve my right to close.
Okay, thank you. Vice Chair Campos.
Hello, Representative.
How you doing?
Good. Thank you for the bill. I just have a question, though, because I was looking at the committee substitute and wanting to know if maybe we could work on it. I myself have worked with the Nájera family, and As you know, there's been 7 dog attacks in Bexar County within the year, and the one-year-old who passed away, unfortunately, and so many others. And so, I mean, it's happening throughout Texas, but in your committee substitute, it says this section gives no authority to animal control officers to conduct an investigation, issue citations, or make arrests. And I think that that's what the problem is, like, because in the, with Mr. Nahara passing away, there had been so many complaints about the dogs, and nothing had been done because of the affidavit not being filed, so that's an issue too. I think that needs to be eliminated. People are, if they get bit by their neighbor's dog, they don't want to put in an affidavit, so I make sure that's eliminated. But then also, I think that animal control services should be more involved and be held accountable, and I think that they should be able to investigate and distinguish whether or not there's a dangerous dog so they can move forward, because had they done this before, I think Mr. Nahara may still be here, because those dogs that attacked him, it was horrible.
Right.
And we're not going to forget that, and so I just really feel for the family and all the others. So I think that I'd love to work with you on that.
Definitely. In fact, I respect all the work you've already done. And one of the things that I've learned is that these are tough bills.
Oh, yeah.
Because the cities all get involved, everybody gets involved, all kinds of groups and all kinds of people. And that was juggling on that. Yeah, so anything that we can work on to make this better, I'm all in on that.
That'd be great. Thank you.
Thank you.
Members, other questions of Representative Lujan? Okay, we do have a couple of witnesses. We will call those and then give you your right to close. Chair calls Brad Davenport, Raymond Nahara, and Asib Abdullah. Are you Brad Davenport?
Yes, sir.
Okay, I show you registered as Brad Davenport, testifying as the Assistant Director for Animal Care Services on behalf of the City of San Antonio for House Bill 2806. Is that correct?
That is correct.
Thank you. Proceed.
Well, good afternoon, Chairman Vandever, Vice Chair Campos, and committee members. My name is Brad Davenport, and I'm the Assistant Director of Animal Care Services Department for the City of San Antonio. I'm here today to share support for House Bill 2806 by Representative Lujan. The City of San Antonio has experienced multiple dog attacks over the last few years that have resulted in life-altering injuries and, in a couple cases, death. Although the state of Texas has good dangerous dog laws, this bill would help enhance existing law and provide methods to prevent and significantly reduce future attacks. The City of San Antonio has over 2,000 dog bites reported annually. San Antonio currently has 186 deemed dangerous dogs, and we currently receive approximately 35 dangerous dog affidavits monthly. While half of these cases result with an owner surrender, the remaining owners choose to keep the animals while meeting state and local requirements. By letting the owner know that failure to comply with these requirements can result in higher penalties, we believe we can incentivize residents to strictly adhere to the requirements or consider surrendering the dangerous dogs before they hurt an individual. This bill also includes a section that allows for San Antonio Animal Care Services to designate a dog dangerous if appropriate. In the last year, we had a case where a child was playing in her front yard and the neighbor's dog ran out of the house and attacked the child. The bite did not cause severe bodily injury, however, was traumatizing for the child, and she was bit. The parent of the child and the dog owner had been neighbors for some time, and because of that, the parent would not complete an affidavit. As you may already know, we've had 2 tragic deaths over the last 2 years, which initiated our process to seek help from this body to enhance state laws. This bill is a crucial step towards safeguarding our community and holding irresponsible owners more accountable. Thank you for the opportunity to speak and request that you please vote this bill out favorably from this committee, and I'm happy to answer any questions.
Thank you for your testimony. Members, any questions? Vice Chair Campos.
So thank you so much for being here, and I know that y'all have done a lot of work with this issue with the dogs, but, I mean, there's still a lot that needs to be done. And so as I spoke to Representative Lujan, I'd like to, I don't know if you'd be in agreement as well to work on this committee sub, just because I think that ACS just needs to be more involved with these attacks. I initially filed a bill, like when I first got into office, because my neighbor got bit 2 times within 5 years walking to church, you know, and she was elderly. And that's why I filed the first bill, because it was just really sad to see what she was going through, but she didn't want to file the affidavit because it was her neighbor's dog, you know, that bit her. So I just think just ACS being more involved, as y'all have been, would just be really a good thing for everybody and to try to keep our community safe.
Well, thank you. We appreciate all the help and support that we can get. We've done a lot to raise requirements in our city ordinance, but we do want to make impacts in state law as well.
Okay, thank you.
Thank you.
Representative Chairman Frank.
So just real briefly, what does this give you the ability to do that you can't do now, that you're stopping short now, that you'll do after the bill passes that you can't do now?
Two main things in the bill, as it's written now, is we would be able to designate a dog dangerous without having received an affidavit from a witness or victim. Like the example I gave here, there are victims who are either afraid to come forward or don't want to come forward.
Okay.
The other one is we would actually be able to issue Class B citations for repeated recidivism for bites. And currently, right now, there's no law for that.
Okay, thank you. Thank you, Chairman.
And to be clear, this bill is bracketed for San Antonio.
The section on designation with evidence other than affidavit is bracketed to San Antonio. Yes, sir.
Okay, thank you. Members, other questions? Okay. Thank you for your testimony.
Thank y'all.
Is there anyone else who wishes to testify on, for, or against House Bill 2806? If not, the chair recognizes Representative Lujan to close on your bill.
I need to go through those other two. We had two that didn't show up.
Members, I want to take a moment to emphasize how important this legislation is, not only to myself and my district, but also to Vice Chair Campos and the work that you've been doing on this. You don't really feel it that much until you meet the people. Mr. Nahara was here earlier. He could not attend. He was here to speak, and the tragedy and the way it turned their life around. I think of Jariah Johnson. I met his parents, took them to eat. They went to church with me. To lose a 1-year-old child to be mauled to death like that is really devastating. In Bexar County, we simply can't wait another session and risk losing more lives. And with that, I ask for your favorable consideration on HB 2806, and I close.
Okay, thank you. Chair withdraws the committee sub. If there's no objection, House Bill 2806 will be left pending. Is there objection? Chair hears none. House Bill 2806 is left pending.
Thank you.
Thank you. Chair lays out House Bill 4539. Chair lays out a complete committee substitute and recognizes Representative Johnson to explain the bill.
Thank you, Chairman Van Dever, Vice Chair Campos, and the committee members for the opportunity to present the committee substitute for House Bill 4539. Currently, if you have an acute injury to your eye, acute glaucoma, a surgical procedure, or an injury, often it will take a few days to be able to get eye drops from your pharmacy, and you need them every few hours. What this bill would allow is that your ophthalmologist can have some commercially packaged and sealed eye drops and ointments available to give you temporarily in the time that that happens. I do have a witness here to testify on behalf of the bill. Happy to answer any questions. If no questions, I reserve the right to close.
Okay, members, any questions for Representative Johnson? Okay, thank you.
Stay.
Chair calls Sanjeev Kumar. Show you registered as Dr. Sanjeev Kumar. testifying on behalf of the Texas Society of Eye Physicians and Surgeons and yourself, and you are for House Bill 4539, is that correct?
Yes, sir.
Thank you.
Thank you, Chair Van Dever and honorable committee members. My name is Sanjeev Kumar, and I'm a private practice ophthalmologist in Uvalde. I serve on the Executive Council of the Texas Society of Eye Physicians and Surgeons. I'm here to speak on behalf of myself and our society of approximately 800 ophthalmologists in support of HB 4539. The major way eye diseases are medically treated is through the application of eye drops and ointments. Certain conditions like ocular infection, inflammation, and glaucoma demand emergent initiation of treatment. Delay in this treatment, even for a few hours, can put the patient at increased risk. And for example, in the case of a corneal ulcer, this may result in scar formation and require further surgical procedures to rehabilitate the eye. These medications indicated for treatment of the eye diseases are esoteric in nature, meaning that their occasional and unpredictable need leaves them in a category of prescription medications that are not routinely stocked in local retail pharmacies. Commonly, a patient will go with a prescription and will be told by the pharmacy that the medication is not currently available, but will be there in a few days. And the reason given is that it has to come from some central warehouse. This bill would allow physicians specializing in ophthalmology to dispense certain non-systemic dangerous drugs in drop or ointment form directly to the patients without needing a separate pharmacy license and to charge for stocking these ophthalmic drugs. Having medication on hand to begin treatment on the day of diagnosis avoids complications from delay in treatment. This bill is a sensible modification to existing law. Thank you for your consideration, and thank you, Representative Johnson, for authorizing this helpful bill.
Okay, thank you. Members, questions of this witness? So you guys would be allowed to charge a fee for it, but just to cover the stocking fee for?
Correct.
Okay. And it would just be a supply, a very small supply, large enough to fill the need for that patient?
Exactly. Yeah, there is further wording of it being a 30-day supply. Basically enough to get them to be able to then get the pharmacy to give them the rest of it.
Okay, very good. Thank you. Okay, thank you for your testimony. Is there anyone else who wishes to speak on, for, or against House Bill 4539? Hearing none, the chair recognizes Representative Johnson to close on the bill.
Thank you. I close.
Thank you. Chair withdraws committee substitute. If there's no objection, House Bill 4539 will be left pending. Is there objection? Chair hears none. House Bill 4539 is left pending. I'm sorry? Chair lays out House Bill 3811. Chair recognizes Representative Plisa to explain your bill.
Okay, I got some handouts. Thank you so much. Thank you, Chairman Van Dever, Vice Chair Campos, and members of this committee for giving me the opportunity to lay out House Bill 3811. House Bill 3811 addresses a training gap in youth sports by requiring all coaches and athletic staff to complete a Department of State Health Service approved injury prevention course. This bill only applies to those working in state facilities involved in high-risk youth sports. Organized sports plays a major role in a child's physical, social, and emotional development. And being on a team gives children's experience and life lessons that extend far beyond their education. But sports often comes with serious health risks, such as concussions, heat-related emergencies, and sudden cardiac arrests. High school sports participation in Texas has declined over the past decade, in part due to rising parental concerns about injury risks. Some coaches lack formal training in injury prevention and emergency response, increasing the risk of delayed treatment and resulting in prolonged recovery for injured young athletes. This type of training program can reduce non-contact injuries by 51 to 62%, and it's shown in studies publicized by the National Library of Medicine. This training curriculum outlined in this bill focuses on accountability and preventative measures and the proper response to concussion, heat-related incidents, and cardiac emergency, all potential risks of youth sports that can have long-term physical and sociological impacts on young athletes. Coaches and athletic personnel who complete this will receive civil liability protections, shielding them from lawsuits if injuries occurred despite adherence to safety protocols. A similar bill to this passed in Alabama in 2018 designated the Coach Safety Act, which was championed by the group who endorsed this bill. Members, I know you guys had some really long days and nights, so I'm trying to keep my layout brief. I have included written testimonies of letters of support for your consideration in this packet. These letters show support from Coach Safety Foundation, a nonprofit dedicated to reducing youth injuries, Children's Health Andrews Institute for Orthopedic and Sports Medicines in Plano, and the National Council of Youth Sports, as well as Samford University Center for Sports Analytics study and the implementation of this bill. The Samford University study revealed that 96% of youth coaches of all sports who completed the coach safety course reported making at least one practice modification to reduce injuries. One notable result of these modifications, it led to 82% of youth football coaches reporting their modifications effective at reducing head injuries. These are just some of the benefits resulting from injury mitigation training. By providing our coaches with the proper training, we will protect health and safety of our youth in sports. I believe I have one resource witness here to answer any questions. I can try answering any of your questions that you have, and I will reserve my right to close.
Okay, members, any questions of Representative Plessa? Okay, actually, we are not showing any witnesses.
Oh, okay. Well, I can try to answer any questions you
Okay,
guys might have.
Okay, we do have a resource witness from State Health Services. Do we need to call that witness? Okay. All right. Is there anyone else who wishes to testify on, for, or against House Bill 3811? Seeing none, Chair recognizes Representative Plessa to close on the bill.
Well, that was pretty easy, and I'll just close.
Okay. All right, and there was no committee, so, okay. Yeah, if there's no objection, House Bill 3811 will be left pending. Is there objection? Chair hears none. House Bill 3811 is
Thanks,
left pending.
guys. Have a good day.
Thank you. Simmons is not here. Curry. Okay. Do we have a Frank's bill? Do we still have McLaughlin here? McLaughlin's back there. Let's do him. Chair lays out House Bill 4255 and recognizes Representative McLaughlin to explain the bill.
Mr. Chairman, members, thank you for the opportunity to lay out House Bill 4255. Texas is facing a healthcare workforce crisis. Our state, particularly rural Texas, is experiencing a shortage of qualified physicians. According to a 2022 study by the U.S. Department of Health and Human
Hey,
Services.
Representative McLaughlin, can I stop you just a minute?
Yes, sir.
I failed to lay out your sub.
Oh.
So Chair lays out House Bill 4255. Chair lays out a complete committee sub and recognizes Representative McLaughlin to explain the bill. Thank you.
Yes, sir. U.S. Department of Health and Human Services, this shortage is projected to worsen throughout at least 2032. Compounding the issue, current medical education enrollment trends indicate we simply don't have enough future doctors in the pipeline to meet the demand. House Bill 4255 is part of the solution to this problem. This bill amends Chapter 164 of the Occupations Code to allow the Texas Medical Board to consider reissuing a license to individuals who previously held a medical license but who were convicted of a nonviolent felony and have fully completed their sentence. The individual must still meet all other licensing requirements and be deemed fit to practice medicine safely. Let me be clear, this bill does not open the door to violent offenders or serious white-collar criminals. Under this legislation, a nonviolent property felon is strictly defined. It is defined as an offense under Penal Code Chapters 31 through 35A, and only if they don't involve the intentional or known use of force or deadly force against any person. We have a committee substitute to redraft my original bill into Legislative Council draft. Additionally, the committee sub adds a clause that requires the medical board to suspend a license while the individual is completing their conviction of the already mentioned offenses. At a time when our state is struggling to deliver basic medical services in many regions, House Bill 4255 allows us to carefully, responsibly expand this pool of eligible providers without compromising public safety. I'm happy to answer questions, and I reserve the right to close.
Okay, members, any questions for the representative? Representative Schaffner.
Do you know how many are in this bucket?
I do not know how many. I know this particular group that brought it to me, there's 4.
Okay, thank you.
We do have. You want to wait? Okay, we will reserve your right to close. We have some witnesses to call. Chair calls Jose Maldonado, Carlos Ornedo, Margot Martinez, and Marcel Knotson III. Chair recognizes Jose Maldonado Jr., Dr. Jose Maldonado Jr., testifying on behalf of yourself, and you are for House Bill 4255. Is that correct?
That's correct.
Thank you. You may proceed.
All right. Dear members of the Public Health Committee, thank you for allowing me to speak today. My name is Jose R. Maldonado Jr., MD, and I am proud to call Laredo, Texas, my lifelong home. I dedicated myself to fulfilling a childhood dream of becoming a family physician, a 25-year career. During this time frame, 18 years of that time was in solo private practice in Laredo, Texas, serving people I have known all my life. Laredo is a place that has always struggled with too few doctors. It was my dream to make a difference there, and I was blessed to do so. Until recently, I had no criminal history, no any disciplinary record against me. In 2016, I made a grave error in judgment and decided to invest in a physician-owned lab. In 2022, I was indicted and pled guilty to conspiracy to violating the anti-kickback statute. I accepted my responsibility, I served my sentence, I paid my restitution, and completed my supervised release. I lost my medical license, my family's home, and a lifelong career that I love. Since my release, I have worked to rebuild and make amends, but without a path to regain my license, I cannot return to the calling that gave me my life purpose. HB 4255 would give doctors like me, who have served our time for nonviolent mistakes, a chance to prove we have changed and to serve our communities once again. This bill is about redemption and hope. It's about letting doctors who have learned hard life lessons an opportunity, a second chance, to return and care for the people who need them most. My heart aches to return to my patients, my family, and my hometown, and I am humbly asking for your support of House Bill 4255, so deserving doctors can have a chance to make things right and give back to their communities once more. Thank you for considering my testimony.
Thank you, sir. Chair recognizes Carlos Ornedo, physician, testifying on behalf of yourself for House Bill 4255. Is that correct?
That's correct.
Thank you. Proceed.
Chairman Van Dever, Vice Chair Campos, and members of the committee, thank you for allowing me to speak today. My name is Dr. Carlos Ornedo, and I proudly serve the people of Laredo, Texas, as a physician for nearly 30 years. I chose to return to Laredo to practice medicine because I wanted to give back to the community that shaped me, a place where access to medical care has always been a challenge. Years ago, I made a serious mistake and was convicted in a federal healthcare kickback case. I trusted someone I shouldn't have, and the healthcare laws are complex. I take full responsibility for my failures, and I should have known better, but I didn't. I served my time, I paid restitution, every dollar they thought was an issue. But more than anything else, I lived with the weight of knowing I broke the trust of my community, and I deeply care about. But I also want you to know this. Serving others through medicine has always been my life's purpose. Being a physician isn't just what I do, it's who I am. Losing my license didn't just end a career, it took away the work that gave my life meaning. And I've spent every day since learning from my mistakes and preparing to return to medicine with more perspective and a purpose than before. It's important to understand that House Bill 4255 applies only to the nonviolent felony convictions. It does not automatically restore a license. It simply gives the Texas Medical Board the discretion to weigh the full story, the mistake, the consequences. I'm not asking for a pass, I'm asking for a chance. Also may add, many healthcare-related cases like mine are typically handled civilly, not criminally. I take full responsibility, but I believe that someone has served their sentence and demonstrate growth, they should not be permanently barred serving again.
Thank you for your testimony. Chair recognizes Margot Martinez, nurse practitioner, testifying on behalf of yourself for House Bill 4255. Is that correct?
Correct.
Thank you. Proceed.
Good evening, committee members. My name is Margot Martinez. I am a nurse practitioner in Laredo, Texas. I am in strong support of HB 4255. Texas needs more qualified healthcare professionals, and HB 4255 offers a fair, responsible path forward for those who have earned a second chance. I urge you to support this bill to strengthen our healthcare workforce and promote rehabilitation and opportunity. I believe strongly in the values of second chances, and our healthcare system is in urgent need of qualified, compassionate, experienced professionals. By allowing individuals who have paid their debt to society and demonstrated a commitment to rebuilding their lives to enter the medical field, HB 4255 would expand our workforce and reflect the deeply held belief that people can grow beyond their past mistakes. This legislation would maintain public safety and the integrity of the healthcare profession by ensuring that those who have demonstrated fitness to practice would be eligible. It would also help address critical shortages in underserved areas like mine, where we desperately need more skilled providers to meet patient needs. As a nurse practitioner with 16 years experience, I have seen many outside physicians come and go with short-term contracts, many with language barriers, which further complicates our predominantly Spanish-speaking community. I respectfully urge you to support HB 4255 and to stand with those who believe in rehabilitation, opportunity, and a stronger, more inclusive healthcare workforce for Texas. Thank you for your service, your time, and leadership.
Thank you. Chair recognizes Marcel Knotson III, attorney, testifying on behalf of yourself for House Bill 4255. Is that correct?
That's correct.
Thank you.
Chairman.
Proceed.
Chairman Dan Beaver, Vice Chair Campos, respected members of the committee. I'm here in support of this bill. I'm a lifelong resident of Laredo, Texas. I know Dr. Maldonado. He's treated my brother. He's been a well-recognized physician for 25 years. I'm a lifelong friend of Dr. Carlos Ornedo. We were together since kindergarten. We've known each other for like 57 years. He's a very respectable person. He was a team leader for the Acts Retreat for the Catholic Church there in Laredo, and he's donated his time for the Boys Club, for the United High School that we both went to, the football teams free of charge, basketball teams free of charge. So he's given back to our community. He did make a mistake. They both did. They were taking advantage, from my perspective, of an unscrupulous person. Hey, you can invest in this and make money. And but anyway, that was in violation of the law. But they paid their dues. They gave back to the community. And what we have here is a win-win situation. You know, where you have medically underserved areas such as Laredo to help bring qualified doctors. as Representative James Frank mentioned, well, isn't the medical board supposed to regulate this? Yes, they are, but under the current law, their hands are tied. You know, this provides an exception under Section F for people that have been convicted for nonviolent felonies to be able to get their license back under approval of the supervision of the Texas Medical Board. So I would ask respectfully that it be passed.
Thank
and
you.
considered.
Members, Representative Frank, Chairman Frank.
Can y'all, the three of y'all, can you practice medicine at any, sorry, that's a loaded term. Can you use your medical knowledge in any shape or form? Obviously, you don't have the licenses you have, but can you work in medicine in any way right now? Obviously, you can't be a doctor. I know we got doctors and nurses, but you can't be a doctor, but can you work as a lower level person?
So I'm gonna say my case, okay? I was a solo private practice. I run my office. I was my office manager, actually, my own. I hired, I fired, I ordered things, I ordered supplies, I did everything. I paid the bills. I paid the water bill, everything. So the only thing that I can do right now without my medical license, it's either be an office manager or
Okay, but you can't work.
I cannot work as a physician. No, I will have to
You can't
go-
work in medicine anywhere.
No, and here's the problem is that when you have a revoked license, right now we have two problems. We have a conviction and we have a revoked license from Texas. Texas revoked our license. You cannot be in prison and be with license, so we got revoked. What happens is that you follow the procedure. You actually get into the Texas Occupational Code and apply, but then you get denied. You get ineligible for license because you got the House Bill 1998 from last session. But anyway, now going to another state, they don't want to give you a license because they say clearly you have to go and fix this license first and then come back and try and get a license in our state. So that's
Okay, so
where
there's
we at.
nowhere you can practice. And I'll just throw this out maybe to the bill author more than anything. We looked at, because I think we had the felony in there for a reason, right? That's the law. And honestly, the anti-kickback statute is a pretty important one because it's a violation of, I think, while y'all may have been tricked into it, it's a violation of patient trust, right? Like that's the reason the kickback's there, or the reason that's there. But we had another bill earlier that was where you maybe practiced under another physician for a while. I know we have some foreign medical students, and again, that's another bill, but I think it's something that may make this a little bit, maybe it's not exactly what you're asking for, but something that would be more palatable, at least for me. So I just throw that out because we're in the time of session that moves real fast. You don't need to make any comment. Thanks.
Members, other questions for this panel? Representative Collier.
Okay, so I just want to make sure every single one of you were convicted?
No.
No, not you.
No. I'm a nurse practitioner, and I'm here just to support the bill. I know both Dr. Ornedo and Dr. Maldonado. They both have over 20 years medical experience, and I have 16 years experience, and they're part of our medical community, so I came to support them.
But this bill doesn't impact you?
It doesn't
as a
impact
nurse
me at
practitioner?
all.
Okay, so then my question is, when was the conviction at anybody, the two?
The conviction was in 2022.
And then when was the sentence, or were you sentenced, or?
Well, we were sentenced I was sentenced in August of 2022 to 24 months of prison.
Did you do that time?
Yes.
Okay, so when did you get out?
I actually used the First Step Act, and I actually finished the sentence in October of 2023.
Okay, October 2023. Was there a fine associated?
Yes,
with-
I had restitution, and I paid the full restitution. I sold my family's home.
Okay, how much was the restitution?
$427,000.
$427,000. And you paid it all?
I paid it all.
Okay,
I
so
paid
it's-
it before I even got to prison.
Oh, you did?
Yes.
Okay, and then,
I was sentenced May 14th, 2024. I was given a 12-month, 1 day. I served 7 months, and I was released from BOP on January 15th
of this year?
of this year.
And is there a fine?
Yes,
How much was the fine?
restitution was paid at $412,000.
$412,000. And that's already been paid?
Yes, ma'am.
Okay, and, I mean,
That was paid before I was sentenced.
what are the other professions that are where someone that has a former felon that's similar to what you're asking us to do will be eligible for their license to be reinstated?
Can you, I couldn't understand the question very well.
I'm just trying to, yeah, I'm sorry, it was really bad, poorly asked. I'm trying to figure out what other professions have this similar provision in place that would allow someone who has a former, that has been convicted of a felony that has not been expunged or granted clemency, any form of clemency, that would allow them to get their license reinstated? What are the other professions that do what you're asking us to do?
As an attorney, I don't know. Marcel, do you know?
I'm not aware of any, but this is, from my perspective, a bill that's common sense, that's for the benefit of Texans, people that need medical services. And here we have a human resource, doctors that are qualified, and it's up to the Texas Medical Board to hear on a case-by-case basis. So they're gonna look at it, say, yeah, we do need this doctor. Here, the Texas average is 1,604 for every doctor.
See, here's the thing. I'm not buying we have a shortage argument. Because, I mean, there's a lot of things that are unfair in this world, and especially in Texas, that is not addressed in this legislature. So here you are asking us, less than a year, then after you're completed your sentence, to change the law to benefit you, all in the name of bringing care to an underserved area.
Well, we served our time, and, you know.
I understand, but there's a lot of things former felons can't do. And so I'm not inclined to make exceptions because of the
No
exact
patients were
profession.
hurt, in my case, either case. And so, no, I have no lawsuits, nothing, no insurance has given me any type of, review. I mean, it's.
I'm just surprised. I mean, we've
you're
been doing
sidelining
this-
good physicians, good people.
I know, but all this time, you're the first that I've seen anything. I've been on this committee 7 times. I haven't received anything where they've asked us to change the law. And
Well, they
I'm only
still
aware
can't
of you
vote.
2, 3, that this would impact.
No, I'm sure there's
No.
more.
Oh, okay.
I'm sure there's a lot more, but this is, I mean, basically, the statute, I mean, the statistics from 2023, Webb County, where we're from, in Laredo, there's one doctor for every 3,390 population.
Is that where you're going to go back and practice if this bill passes?
No,
That's
no.
where we live. Yes.
I'm an
Okay.
attorney.
Yes, ma'am.
Okay.
Yeah, they're both from Laredo, and so Laredo, without a doubt, is an underserved. You know, the state average is 1,604 for every doctor. You know, so where the U.S. average is 1,310, so Texas is above the U.S. average. I mean, Texas, as great as we are, we should be, below. We should be like 900 or 800 for every doctor, So this is, it's a win-win situation. They still don't have the right to vote. That's been canceled, so the only reason here is it's a benefit. I mean, if you just look at the research, we can provide that to you. Texas is underserved. There's Maverick County, Zapata County, Rio Grande City, Stark County, Hidalgo County, underserved. So basically, this is they get benefited by being able to practice, but the main ones that benefit is community members.
So
and
they don't get the
medical
right to
board.
vote?
What?
You're saying that they don't have the right to
They
vote?
don't have the right to vote.
But
That's not taken away.
they
I mean,
have
that's
the right.
still- No, that's still taken away. That's not given back.
So they don't have the right to vote, but we want to allow them, why wouldn't they have the right to vote? I'm trying to figure out, should we let them practice medicine if they can't even vote?
Well, there's some
Well,
doctors
you're
that
trying to
can't
get
vote.
physicians from another
that are not
country,
US
and we're
citizens
trained here,
that can't
and there's
vote.
good story, you know us.
I'm just saying that the state doesn't allow a former felon to vote.
I don't know about that for sure.
Well, that's what he's saying.
I don't know.
May I say something,
I know,
Ms.
but
Ms.
I'm just
Collier?
letting him testify.
I was in a federal facility that actually had, when I got there were around 17 physicians besides myself. So there's a lot of doctors that actually you might not have seen here, but there's a lot coming. There's been a lot of cases that have been brought against physicians. In this particular situation, my problem is that when I go into another state, they don't have a problem with a conviction. They actually have a reinstatement process and a rehabilitation based on the case by case. So it's not like you're gonna get someone that killed a lot of people or a child molester back in practice. No, what I'm talking about is that every single one of us that had a situation and got a license revoked, like for instance, somebody could be driving, gets a DWI. Somebody has their accountant messes up their taxes and gets something with taxes. You can get your license revoked for many reasons besides medical. Now, that being said, when you have a physician that has a community and they're actually trying to get back to their community, they have tried to get this opportunity here in Laredo here in Texas, so we can get a possibility to see whoever was licensed before in Texas. So if you didn't have a license in Texas before, you can get you have to have a license before in Texas. You have to have a good criminal, no disciplinary action against you. I mean, I've never had any disciplinary action against me. Then besides this, and then you have to have paid everything. You have to have served your time. You have to have finished your supervised release, and you actually can consider to get a hearing. We're not getting licensed. We're getting a hearing in front of the medical board, so they can see the case, go over it, and then make a decision whether yes or no.
So it's like I said, not a pass, it's an opportunity, a chance, you know, for the discretion of the Texas Medical Board to review our case by case.
So it's not automatic.
It's not automatic.
Okay, thank you.
Yeah.
Representative Jones.
Oh, so many questions. So, question, right now, under the existing legal framework, under Texas Occupations Code 164.151, you can try to get your license back. Is that accurate?
You have to wait a year.
Okay.
You have to pay a fee. You have to fill out all the application, say yes to all the things and fill out everything, and then you apply. I did that. I was eligible to apply in October of 2023.
And so I
House
guess my
Bill
question is, and then if you don't get your license back, you have to wait another year. Am I accurate?
Exactly.
Okay, so I guess my question is, why is that law not sufficient? Because you have a path back, is the first question. And the second question, what does this new HB do to change that?
Yes. It's a
good question.
Very good question. We have this, thank you. We have actually I applied, so I finished my sentence in October of 2023, and the first thing I did besides coming back to my family and, getting back with them and trying to work through all of this that happened to us because of my actions, was to get to see what was the next step with my medical license. So they went over all of that, 1 year and everything, and I applied in November of 2023. I got a response saying that due to House Bill 1998 from the 88 legislation, I was ineligible to practice because my license was revoked in Texas. And that's final.
So the
There's
bill
no
is HB,
appeal.
you said HB
1998.
House Bill 1998 from the 88 legislation 2023-2024.
The Dr. Death Bill, I think.
It became effective September 1st of 2023. So before that, I would have applied. I would have gotten a hearing and in front of all the doctors and the medical board, picked everything apart to see if I was eligible or not eligible to try and get my license back. Probably with some conditions, of course, but try and get some my license back, because my medical care has never been an issue.
So can somebody tell me what this bill does to undo House Bill 1998 that took place?
I think it gives the Texas Medical Board discretion that evaluate, per case, knowing that it passed this body, that they see that there's an opportunity for, physicians to get back to work, especially those that have done the things that they needed to do to rehabilitate, to get back to the workforce, and that's deadly needed here in our South Texas.
So I'll just say this: attorneys that are disbarred, I'm a lawyer, by the way. Attorneys that are disbarred due to a felony conviction, there's an extended reinstatement process. You got to wait 5 years after the completion of your sentence. So if you put on parole, then you got to wait until your parole is finished, and then you got to wait 5 years. After you wait 5 years, the attorney must petition in the district court demonstrating present good moral character and fitness. The reinstatement is in the best interest of the public and the profession. A life of exemplary conduct during the 5 years preceding the petition. If the reinstatement is granted, the attorney may be required to pass the Texas bar exam, complete the MPRE, the multi-state professional responsibility examination, and satisfy any continuing legal education requirements. So I guess what I'm saying is, if someone is convicted of a felony, why wouldn't they have to wait some time if you can get your privileges back or get your license back, why would somebody get to practice law like immediately? Like if I have to wait 5 years,
Yes.
right, what's so special about,
Well, you're special.
yeah, but I shouldn't be more special than
Right.
everybody else.
And not to make light of that, but here, I know an attorney that got disbarred for stealing funds from a client. He didn't go to jail. He didn't serve 1 day in jail. He didn't pay any restitution, not 1 penny. 2 of those clients were my clients. 2 other clients were another lawyer's clients in Laredo. He got off with impunity, not 1 day in jail. He lost his license, but he's making $325,000 working for a big transportation company.
But he
So what
lost his
punishment-
license. But he lost his license.
Yeah, but now he's
So he had to go
reapplying.
figure out how to
He
get
did
his
wait
hustle
5
on.
years. He did wait his 5 years, and he's reapplying now, but those people are gonna go testify against it. You
Right,
know?
but you just actually made my argument for me. He didn't get his license back. The fact that he is a hustler and figured out another way to make money why he didn't have his license, I mean, so I guess
Yeah.
my point is that I don't think I have a problem with you being able to get your license back.
Right.
But I do think that I have a problem for the people that work hard to be doctors or lawyers and they don't do anything wrong. I guess I'm curious, what time period do you think a doctor whose license has been revoked should have to wait before they get their medical license back? I'm curious.
It's a year on the Texas application. It's 1 year. You have to reapply after 1 year.
I know what it is now, but how quickly, like, if this bill passes and
It's,
goes into effect on September 1?
I think it's still a year,
It's
right?
still a year. It
It's still-
doesn't change that. It just takes into consideration a non-violent felony, which is a common sense approach. And Texas is an underserved, there's a lot of underserved areas, Region 20, Webb,
I
Jim
know, I
Hog
heard that part.
Mavericks.
I heard Laredo and the numbers that you gave.
Yeah, so.
So you think that if there's not a lot of doctors, then you should get your license back?
Well, even if it
Because
wasn't.
I'm just asking.
I understand, that's a good
Yeah.
question. It's still 1 year that we understand from the Texas Medical Board. But I think it's per case, so, I think they're gonna be the ones to regulate things. Do CME, ethics, do some voluntary service, which I've been doing anyways, things that get you back into the community, back into reentry, as they say.
When did you, I'm sorry, remind me, when did you finish your time? I think you said 12 months and a day.
I was
Right,
given
think is
12
what
months
you
and a
said.
day, yes, ma'am.
So when did your
January 15th.
sentence end?
January 15th, 2025.
Of this year?
Yes, ma'am. My license was officially revoked November of 24.
Right, but January 15th, a year from then would be January 15th of 2026. You think that's too long for you to have to wait?
It's always
This-
too long
the
when you
bill
want to
doesn't change
practice.
I'm sorry, I'm just asking.
Yeah,
But he was talking and you sort of jumped in.
I'm sorry.
I'm sorry.
For
what was
me,
your
it's
answer?
never, I mean, it's always, obviously, you want to practice. That's what you do. That's what you're doing. And so I've done the things that they've asked me to do.
You've done the things that the criminal justice system asked you to do.
Correct.
You-
And so I'm waiting to see what the discretion is from the Texas Medical Board, with you all helping as well, so I can do that. I mean, literally,
All right,
they're neutral right now.
okay, thank you.
Representative Schaffner.
Do you have to be board certified to practice medicine?
No,
You do not.
I don't think so. I'm board certified, but
Well, no, you don't have to be board certified, but it definitely gives you more credibility
Sure.
to be board certified.
It's always a good thing.
When you need to have an active license to have a board certification.
Certification, so license, then board certification afterwards. And the restitution you paid to the county, to the courts?
Federal government.
Okay,
the
thank you.
clerk, yes, sir.
Members, other questions of this panel? Okay, thank you for your testimony.
Thank you. Thank you.
Thank you. Is there anyone else wishes to testify on, for, or against House Bill 4255? If not, the chair recognizes Representative McLaughlin to close on the bill.
Members, I'm not, what these men done, they have served their time. But we do have a shortage of doctors in rural Texas. Like they said, you got one doctor to every 3,309 people in Laredo, Texas. I live in Uvalde, Texas. I can't get a doctor in Uvalde, Texas. My doctor's out of San Antonio, 110 miles away. So this is a problem that we face in rural Texas. I don't condone felons or different things, but if they're supervised by a doctor like Mr. Frank said, or whatever, another deal, or leave it up to the Texas Medical Board for them to review it and let them make that decision, because that's their peers. So I do appreciate your time and appreciate the consideration of the bill. Thank you.
Thank you, Representative. Chair withdraws the committee sub. If there's no objection, House Bill 4255 will be left pending. Is there objection? Chair hears none. House Bill 4255 is left pending. Chair lays out House Bill 5098. Chair lays out a complete committee substitute. Chair recognizes Representative Curry to explain the bill.
Thank you, Chairman. I will try to be as quick as I can on this. I'm happy here today to be laying out 5098, which establishes an electronic health record loan program for certain healthcare facilities across the country. Long-term and post-acute care providers have been left behind in the adoption of electronic health records. While almost 100% of acute and ambulatory care providers use EHRs, recent data from the Office of National Coordinator shows that only 66% of skilled nursing facilities have adopted any form of EHR technology. Even more concerning, among the providers that do have electronic health records, only 18% are able to integrate patient health information received from outside facilities. This lack of interoperability places SNFs and other LTPAC providers outside of the broader health information exchange network. The result is fragmented care, inefficiencies in treatment, and increased strain on a workforce already stretched thin, particularly in rural and medically underserved areas. This digital divide contributes to higher readmission rates, which is a key quality metric used by regulators. Patients served by facilities without EHRs are more likely to experience hospital readmissions, an issue made worse in communities with limited access to providers. 5098 addresses these challenges by creating a low-interest loan program administered by HHSC. The program will provide loans to allow senior care, behavioral health providers, and rural health providers to acquire and implement health information technology such as EHRs or other care coordination technology. The bill prioritizes funding for facilities located in rural and underserved areas. The committee substitute clarifies the eligibility requirements for applicants and ensures that the technology adopted meets interoperability standards so that patient information remains current and accessible across care settings. Mr. Chairman and members, this bill increases access to integral technology that leads directly to improved patient outcomes, higher quality, transparency of care, and increased administrative efficiencies that help rural and underserved communities. I respectfully ask for your favorable consideration of this bill, and I appreciate the opportunity to close if the committee feels so inclined.
All right, thank you, Representative Curry. Members, any questions?
Yes, ma'am.
Representative Schaffner.
I see that you have this fiscal note. So if it's a loan program, why is there a fiscal note?
So it turns out that the department that put in the fiscal note, that I think we're gonna probably work with them to try to fix that.
Okay.
And I'll fix it in another committee substitute and try to get that down to as low as possible, but it should be much, much lower than what it is.
And why is the HHSC the best place for this loan
Well, and that
program?
may be a change. I'm glad you pointed that out, because after reviewing this a little more carefully and working with a couple of different departments, there's probably another agency that would be better at administering a loan program.
Okay.
And I think they could work in conjunction with HHSC to do so without creating such a large cost to the state. So it should pay for itself, and there should be a way for this to pay for itself without it being as what's stated in the fiscal note. We just got the fiscal note, so it kind of surprises us just a little bit. Yeah, I know.
Okay, members, other questions? Okay, we will reserve your opportunity to close and have a witness. Chair calls Nora Cox. Have you registered as Nora Cox, testifying as CEO of Texas eHealth Alliance, and you are testifying for House Bill 5098, is that correct?
Yes, sir, that is correct.
Thank you. Proceed.
Thank you, Chairman Van Dever, Vice Chair Campos, members of the committee, Nora Cox on behalf of the Texas eHealth Alliance. It's been a long day and we're not done, so I'll be brief. There are three things I want you to know about this bill. Number one, the thing that my organization hates even more than clipboards is fax machines. And unfortunately, our long-term care system still has more fax machines than our ambulatory and acute care systems. When you move a patient from one care setting to another, it's 2025. We should not be faxing those documents, but yet we do. So when the federal government did the incentives for electronic health record adoption, they did not fund long-term care. They did not fund mental health. So there are providers that have been left behind. So that, I think, is very important. I think the other thing that I want the committee to know is that 10,000 baby boomers turn 65 every day. And as a Gen Xer, I find that a very sobering thought. We have to have a long-term care system that is ready to interact with hospitals and interact with physician practices, and this bill helps us get there. And then the third thing I'll say is we talk a lot in Medicaid in particular about value-based purchasing, paying for outcomes. We cannot achieve those goals with fax machines and manual data entry and Excel spreadsheets. We really do need to level up the technology infrastructure for these providers that don't have it. This bill does that. I really appreciate Representative Curry's passion for this issue. He's really shown leadership in bringing this forward. And with that, I'm happy to close and answer any questions.
Okay, members, any questions for this witness? Okay, thank you for your testimony.
Thank you all very much.
Is there anyone else who wishes to testify on, for, or against House Bill 5098? If not, the chair recognizes Representative Curry to close.
Thank you very much. I'll be brief and answer any other questions that you have. I will tell you that I come from a rural district. Rural healthcare is a problem. Trying to fund and finance sources to help them do better, be more efficient, and provide better services is always a challenge. I think that we should do whatever we can to do that. And certainly if there's little or no cost to the state, we should always do what we can to support rural health care. So I appreciate your consideration. I would appreciate your favorable vote on this bill. And I look forward to passing this through the Texas House.
Thank you. Members' questions? All right.
With that, I close. Thank you, sir.
All right.
Thank you all.
Chair withdraws committee substitute. If there's no objection, House Bill 5098 will be left pending. Is there objection? Chair hears none. House Bill 5098 is left pending. Chair lays out House Bill 4535, recognizes Mr. McQueenie, Representative McQueenie, to explain the bill.
Good evening. Thank you, Mr. Chairman, committee members. I appreciate the opportunity to lay out House Bill 4535. House Bill 4535 is a common sense measure to restore transparency, protect informed consent, and rebuild public trust in the COVID-19 vaccine administration policies across our state. The COVID-19 pandemic introduced unprecedented challenges for policymakers and health officials. In the early days of the crisis, decisions had to be made very swiftly, often with limited and involving data. However, as the dust has settled, I think we've realized and assessed that outcomes and impacts, one thing was clear: informed consent and medical transparency were too often sacrificed in the name of speed and compliance. House Bill 4535 does not restrict or prohibit COVID-19 vaccines. It does not interfere with provider recommendations. What it does is ensures that Texans who choose to receive the COVID-19 vaccine are given written information in a language that they can understand. This bill directs the Department of State Health Services to create a standardized information sheet that must be provided to patients before they get vaccinated. The information sheet must include known risks and potential side effects, the expedited timeframe of the vaccine development, whether long-term studies have been conducted, whether manufacturers are shielded from liability, and instructions on how to report adverse events through the federal system. This bill also grants licensing boards the authority to discipline providers who violate these informed consent requirements. House Bill 4535 is about transparency and empowerment. Thank you for your time, Mr. Chair and members. I request the right to close and we'll take any questions.
Members, any questions for Representative McQueenie? Okay, we will reserve your opportunity to close. Chair calls Michelle Evans, Dr. Jason Turk, and Jackie Schlegel. Okay, I have registered Michelle Evans with Texans for Vaccine Choice and Self, testifying for House Bill 4535. Is that correct?
That is correct.
Thank you.
Thank you. Good evening, Chairman Van Dever, Vice Chair Campos, committee members. Our mission at TFVC is to protect and advance informed consent, medical privacy, and vaccine choice. HB 4535 is obviously a step in the right direction, but I fear it's too small a step. The bill recognizes the hasty rollout of the COVID vaccine and the inherent lack of robust safety testing resulting from its rush to market, and it requires that information be shared with patients prior to administration of this vaccine. It also mandates that providers inform patients about the fact that vaccine manufacturers enjoy immunity from liability. But this rushed rollout, lack of safety and efficacy testing, and legal immunity don't just apply to the COVID shot. The tenets of informed consent apply to all medical procedures. The absence of rigorous and transparent studies applies to most, if not all, vaccines. The shield of legal immunity applies to the manufacturers of all federally recommended vaccines. This bill, therefore, should apply to all vaccines available for use in the state of Texas. We recognize the significance of passing HB 4535, but I encourage lawmakers to be more forward-thinking and not limit our focus to a vaccine that a vast majority of Americans have already chosen not to take, and that our public health agencies are leaning toward removing from recommendations for most Americans. Thank you.
Thank you. Dr. Jason Turk. Show Dr. Jason Turk. registered against the bill but not testifying. Have Jackie Slagle, registered as Executive Director and testifying on behalf of Texans for Medical Freedom and self, testifying for House Bill 4535. Is that correct?
That is correct.
Thank you.
Thank you, Chairman Van Dever, and I want to thank Representative McQueenie and his numerous joint authors for this common sense legislation. During the COVID-19 pandemic, Texans responded with urgency and trust. They lined up in record numbers, many believing they were helping themselves, their communities, their families. But what they didn't receive, what too many still haven't received, is the full story. These vaccines were developed at unprecedented speed and deployed under emergency use authorization, and most Texans were never told that long-term safety studies hadn't been completed. Most had no idea that manufacturers were shielded from liability, and most importantly, nearly no one knew how or even that they could report an adverse reaction. That's why this bill matters. HB 4535 requires written informed consent before a COVID-19 vaccine is administered. It ensures patients receive standardized state-issued document explaining the risk, legal protections for manufacturers, and instructions for reporting to the Vaccine Adverse Events Reporting System, VAERS. According to a comprehensive study commissioned by the U.S. Department of Health and Human Services, it is estimated that less than 1% of vaccine adverse events are ever reported to the Vaccine Adverse Events Reporting System. This is not just a data problem. This is a trust problem. Informed consent is not a political issue. This is a moral obligation. HB 4535 ensures Texans receive the protections we expect in any medical decision: transparency, accountability, and informed consent. It does not block access. It simply restores trust in our public health system by empowering patients with facts. I would love to answer any questions you have.
Thank you. Members, questions for this panel? Representative Schaffner.
This is for both of you. Can you expand more about the importance of informed consent and as well as the VAERS reporting?
Yes, so patients deserve the opportunity to understand the risks and the benefits of any medical procedure. They need to know what their personal profile, their risk profile would be. So whether it is a necessary procedure for them to undertake in order to prevent or to ensure long-term health for them. But I think in particular for vaccines, I think it's worthwhile for patients to also understand that the safety testing or lack thereof in certain cases, and also that the immunity that we've discussed a lot here, the immunity from liability that the vaccine manufacturers enjoy.
The way I like to describe informed consent is you are giving the risk, the benefits, and the right to choose without consequence. A lot of these basic tenets were broken during the COVID pandemic. I realize we're nearly on the other side of this, but this vaccine is still being given, and it's the least we can do is give full informed consent. I also think one of the most important components of this bill is the understanding how to report a vaccine adverse reaction. Many people are wholly unaware of that and do not know that they can. And I think this statistic of 1% ought to be shocking to all of us. How can we look at patients and say, that we know with full certainty that we are tracking? This is the nation's early warning surveillance system, and yet only 1% ever reported. We've got to raise the bar on vaccine adverse reporting.
All right, thank you.
I'd also like to add that currently in Texas Family Code, the onus is on the parent to ensure informed consent. It is not on the provider. So the provider is not required to ensure that the patient is fully informed, specifically for vaccines.
Great, thank you.
Thank you. Representative Frank.
Is there any other medical procedure other than vaccines where medical providers are not required to tell you the benefits and the costs? Are you aware of those?
My lane is pretty narrow with vaccines. So to my knowledge, with regard to childhood vaccines in particular, the parent is the one that is responsible for ensuring informed consent, not the provider.
Okay, because it seems inconsistent with the rest of medical where we say, hey, here's the pros, here's the cons, and I'm actually, and hopefully this is not bad. I think vaccines are great most of the time. But I also think they're on a spectrum. We had testimony early in the year from one of our state agencies that mentioned this was, and they were talking about a particular vaccine, and they said, this is one of the good ones. And what they were saying was, hey, a lot of great data, not many problems. But it was also comparing it to some of them, are not as good, not as tested, don't have as and have more problems. And that's just information that all of us ought to have, and certainly on this. So thank you.
Thank you.
Members? Okay, thank you for your testimony.
Thank you.
Is there anyone else who wishes to testify on, for, or against House Bill 4535? Members, we do have a resource witness from Health and Human Services if anybody needs that. All right. Chair recognizes Representative McQueenie to close on the bill.
Thank you for your time. I close.
Thank you very much.
That's called being brief. I don't know if
Okay.
Representative
I think
Curry
we do have
understands that.
We do have a question.
I'm going to say yes. This is the freshman from Tarrant County, the newest member, and I see that you really wanted to bring a Harrison bill back, because this is from last session, a Harrison bill. So
I'm unaware of that.
now you are.
Okay. This is common sense disclosure
I'm just teasing you.
legislation that
Thank you. All right, thank you, Representative McQueenie. If there's no objection, House Bill 4535 will be left pending. Is there objection? Chair hears none. House Bill 4535 is left pending. Chair lays out House Bill 1586. Chair recognizes Representative Hull to explain the bill.
Thank you, Chairman, Vice Chair, and members for letting me lay out House Bill 1586. This bill is about government efficiency. I really think of this bill as more of a DOGE type bill. The current procedure for acquiring an immunization exemption form for school enrollment is time-consuming, inconvenient, and often causes a delay in school enrollment. Parents and guardians must request the form from DISHES and wait for the form to arrive in the mail before they can take the affidavit form to be notarized and return it to the school. Currently, DISHES hires 4 FTEs each summer to print and mail these forms to anyone who requests them. School districts and parents have requested that the forms be more readily accessible to the public so that parents or guardians may download and print the forms to complete, notarize, and return to the school before enrollment deadlines, so children are not missing the first days and weeks of school simply because DISHES is behind in mailing the forms. This bill directs DISHES to post the affidavit form on their website in a printable format to remove the delay of sending their request to DISHES and having to wait for the forms to arrive in the mail. Often, parents have to re-request the forms if they are not received or are delayed for some reason. Allowing parents and guardians to download and print their own forms to notarize speeds up the process so that students may be enrolled in a timely manner. This bill promotes government efficiency and will provide tax dollar savings of an estimated $177,000 per year in cost to hire staff to mail a form. I also want to make it clear that making this form available does not in any way change the thoughtful decision-making process that parents go through when they are deciding what is best for their own children, which is also their legal right and responsibility. There may be witnesses that want you to believe that being able to print a form is somehow going to promote lazy, ignorant, or irresponsible parenting decisions. This narrative about parents is frustrating, disrespectful, and inaccurate. I want to assure members and the public that allowing parents to print the affidavit that they have already decided that they want will allow these parents to enroll their children in school more quickly and on time for the school year. It does not change their medical decision-making. While the number of forms mailed is currently tracked, that number is meaningless as it does not show how many forms are actually submitted. Districts will continue to report the number of exemption forms they receive, which is the only accurate data point. This bill does not change any district reporting. Government bureaucracy should not inhibit a child's fundamental right to an education. I'm happy to answer any questions and reserve the right to close.
Okay, thank you, Chair Hull. Any questions of the bill author? Okay, we will reserve your right to close. Chair calls Catherine Troisi, Eloise Sutherland, Michelle Evans, and Heather Lacey Cook. I have Catherine Troisi testifying on behalf of the American Public Health Association and self against House Bill 1586. Is that correct?
That's correct.
Thank you. Proceed.
Chair Van Dever, Vice Chair Campos, sorry, it's been a long day for all of us, I understand. Good morning, or afternoon, evening, yes. I am here, as you said, representing the American Public Health Association, and I just want to make clear, not my employee. I am an infectious disease epidemiologist. I specialize in viral diseases and vaccines, and I've worked in this area for 45 years. Yes, I started as a child. By making it easier for parents to opt out of routine childhood vaccinations required for school entry, this bill threatens the protection of vulnerable children who cannot be vaccinated. Texas has an opt-out program for personal exemptions, which is not onerous. My concern is that parents may use this proposed expedited process not because of personal beliefs, but because of expediency. This would have the effect of leaving children unprotected from diseases that we know how to protect them against. It would also leave children who cannot be immunized at significant risk. Vaccines are one of our top 10 public health achievements of the 20th century. We have eradicated smallpox, we are close to eradicating polio, and measles was supposed to be next, maybe not in the near future. But that is due to vaccination. And the cost effectiveness of vaccine is one of the highest in public health, with each dollar spent on childhood vaccinations saving an average of between $11 to $51, not to mention the morbidity and mortality. A recent CDC report looked at averted illnesses and diseases, and in the written testimony you can see how much money, lives, et cetera, have been saved. Thank you.
Thank you for your testimony. Chair recognizes Eloise Sutherland, testifying on behalf of yourself, and you are against House Bill 1586. Is that correct?
That's correct.
Thank you. You may proceed.
Well, good evening, and thank you all for allowing me to testify today. I am here in opposition to HB 1586. Granting relaxed opt-out choices to parents will prevent establishing herd immunity to many infectious diseases, resulting in more child deaths and more children with disabilities. Back in the late 60s, when the rubella vaccine was newly released, but herd immunity had not been reached, I became pregnant and was infected with rubella. My son was born deaf. He's grown now and is able to support himself, but reaching that level of self-sufficiency, however, has taken years of special education and it was provided by the state, as well as expensive hearing aids that must be replaced every few years. And deafness is not the only birth defect resulting from congenital rubella syndrome. It can also lead to heart defects, cataracts, intellectual disabilities, and growth delays in the baby. One of his classmates had had open heart surgery as an infant due to maternal rubella. While my primary concern is saving families from the heartache and stress of dealing with their child's birth defects, we cannot ignore the cost to governments to care for and educate the children. Being a citizen of this great state brings rights and responsibilities, and none of us should have the right to take actions that can result to harm to many others. And you all have the responsibility as elected state officials to protect us from harm. Please do not vote for this legislation.
Thank you. Thank you for your testimony. Chair recognizes Michelle Evans, testifying on behalf of Texans for Vaccine Choice and yourself, and you are for House Bill 1586. Is that correct?
That is correct.
Thank you.
Thank you. Good evening, Chairman Van Dever, Vice Chair Campos, committee members. Thanks for sticking it out. I'm excited to testify for HB 1586, a long-term TFVC priority. Since our founding in 2015, we've held that the process laid out in state statute for Texans to exempt themselves or their minor children from vaccines required for public schools, institutions of higher education, some daycares, and other settings is not only cumbersome but also irrational. Ultimately, Texans should not have to request to have their vaccine choice rights enumerated on a state-produced document in order to exercise those rights. But we've recently learned through open records requests that the process is also a burden on taxpayers, costing Texans over $500,000 a year in labor, postage, and supplies. Requiring parents and students to go to the DISH's site, fill out a request for a reasons of conscience affidavit, wait for the form to arrive in the mail, fill out and sign the form in front of a notary public, and then submit the form to the school or other entity isn't scientific. There's nothing about this process that is intended to protect public health. It is simply a regulatory burden for those who decline one, some, or all vaccines. It does, however, put children at risk of being denied a public education. Often, busy parents wait until the last minute to request these forms before the start of the school year, and since it can take several weeks to receive the affidavits, their children are excluded from campus until which time the notarized form is received. We urge you to pass HB 1586 with great haste. Our time is running out. Thank you.
Thank you. Chair recognizes Heather Lacey Cook,
Yes.
testifying on behalf of yourself, and you are against House Bill 1586. Is that correct?
Yes, sir. Thank you. Thank you all for seeing me tonight. I'm here on behalf of myself. I'm a mom of 3 boys, a wife of 20 years. I'm also a health lawyer, so I'd love to talk about informed consent, all the Texas codes surrounding that. But I'm asking you to vote against this bill today, and the reason is 3 reasons. I'm asking you to uphold your legal duty to protect children in public school. I'm asking you to uphold your moral duty to protect them. And I'm thirdly asking you to uphold the current Texas law that states that this government will be a partner and an ally in providing immunizations to all children. So Texas has given countless rights and protections to parents who choose not to vaccinate. I'm happy for that. But my rights are dwindling. My children's rights in public school are dwindling day by day. And families like mine have less protections today than they did prior to this legislation. So I'm asking you to consider representing me and my boys today, and not just the parents who choose not to vaccinate. I believe in personal choice, medical freedoms, limited government. I believe in the freedom to worship. But I also believe that if a government mandates a child go to school, then the government has a legal duty to protect that child while under their care. So I'm asking you today, under the Texas Health and Safety Code, Section 161, to vote against this bill. It's very clear on the duty Texas has. Under the same law, Texas promises to be the partner and the ally to give education, fully informed consent, to give provider choice, to give all these things. But guess why we put immunization requirements in place in the first place? To protect our children. That's why y'all did that, and I applaud you. So I know you care about all these children. And why? Because we can't afford to take off work. We can't afford to pay extra medical bills. Thank you.
Thank you for your testimony. Representative Alcott.
Thank you, Mr. Chairman. So, Ms. Cook, are your children vaccinated?
Yes, sir.
But you mentioned that if something like a bill like this was to pass, that we'd be endangering your children.
Yes, sir.
But they're vaccinated.
Yes, sir.
How are they at risk if they're vaccinated?
Well, for certain, not every vaccine is 100% effective. We know that with all medications. We know that with vaccines. They're not all 100% effective. I haven't tested their titers, so I'm not sure. I've done everything I can do to protect my children, and I'm asking you to help me protect the other ones, the kids who can't vaccinate, the neighbors who play basketball down the street. I'm asking for my son's homecoming dates. I'm asking for everyone, not just my children, but the children under your care. So I appreciate the question. And yes, I feel safe and rested at night, but I'm not here to protect just my kids.
But you did imply that if this bill was to pass, that your children would now, for some reason,
Well, absolutely.
unsafe
Yes.
because despite the fact that they're vaccinated,
Yes.
but you believe in the vaccinations.
Absolutely.
But
I
yet you're
also-
worried,
Yes,
you're trying to have it
I'll
both
give you
ways,
all
it seems like.
I understand what you're saying.
Okay.
I apologize. I'll clarify. When you make it easier to opt out, like when I sign my kids up for the Christian T-Bar M camp, they say, will you provide all your vaccinations? I say, no, I'd rather just check this box that says I decline conscientiously because it's easier, right? Well, that's what happens. I live in Fort Bend County. We're international. We're equal parts, all international population. There are people that come from different countries. So it's not just, I'm going to protect my kids and I'm only going to care about my kids. I want to care about her kids and your kids. I want to care about all the kids that I love, not just my kids. So yes, I'm concerned for my kids, especially if some vaccination didn't seroconvert, or if it didn't work for my kids. I would like to protect them all. I know you do too.
Sure, but I also like to respect the rights of the parents to make decisions for their own children.
Absolutely, me too. And I'm asking for my rights to be respected too.
Sure. So just so I understand, this legislation doesn't affect whether kids can opt out of these vaccinations. It just has to do with the expediency of how quickly they can opt out. And so would you agree, Ms. Cook, that if you understand that the parents that are kind of passionate about not vaccinating their children, do you think that they're actually going to just not do it if it's not easy for them?
It's a good question. I live in Katy, Texas, so I live in the country where these are my friends and my political allies. So I understand what you're asking. But yes, when you make it easier, and we're busy. I have 3 sons in sports, all in Katy. We don't have time for all kinds of things. These parents who you say are passionate about not vaccinating, they didn't just figure out by the time they were 5 and registered for kindergarten, oh yeah, I forgot my form. No, they're passionate. They already have it laid out. So we don't need to make it any easier.
Well, Ms. Cook, have you had a chance to talk with some of the ladies?
Yes.
Like, for instance, Ms. Schlegel, that's has
I
a
did.
daughter that was actually injured by vaccine. What
Yes.
about children in those situations?
Yeah,
Do you care about those children?
Absolutely.
Okay.
I care about all the children. I care about her children. I care about Jackie. She told me about this earlier today. Of course I do. I have friends who have kids with autism, not from vaccines, but I myself just got diagnosed with a genetic disorder. Yes, of course I have compassion, but I also care about the duty that you have as my elected representative to represent me too.
And I think that one of our jobs, and it's incumbent upon us, is to make sure that the parents have the liberty to make the decisions that affect their own children.
And I
if
wanna
you're
say thank
concerned
you.
about your own children catching these diseases, they can get the vaccination.
Yeah.
And for those that don't, and this is directed towards the epidemiologists, ma'am. I'm assuming so, and you raise a good point, so like there's some people that the children can't get vaccinated, but do those parents tend to not take them to the zoo or out to the grocery store where they're going to be exposed to the same types of stuff out there?
I am very grateful. I have not been personally in that position. I assume that they are very careful about doing that, but school is different. They go there every day to get an education. And so we rely on community immunity. I'm sorry, I'm losing my voice. We used to call it herd immunity. Community immunity. I'm old. I also need protection. My immune system, just like every other organ in my body, it doesn't work the way that it did. And so I'm relying on people being protected around me as well. Babies can't be immunized, say for measles, under 6 months, and we don't even like to do it between 6 and 12 months, but given the outbreak, we're doing it. We need to protect those children who can't be protected. And it can happen to, in my written testimony, I have 6 grandchildren. They are all healthy. God forbid, one of them should develop cancer. And then they will be susceptible. And we will have to rely on people, children particularly, because that's who they interact with, protecting them by not carrying those diseases.
Okay, so I have one last question for
Yes.
you. In your opinion, if this bill in front of us today passes, do you think that it's going to affect herd immunity in schools? If it's made it a little bit easier for the people that were already going to get the opt-out, or going to get opt-out a little bit quicker, do you think actually would have an effect on the herd immunity in the schools?
Yes, I do. And, it's not like in many schools right now, we've seen the numbers in Gaines County, that, our immunization rates in Texas are not ideal. It's not just Texas. It's the United States, and it's many other countries because of the misinformation that has been spread and, a variety of reasons. In fact, I just had published a policy brief on vaccine hesitancy. I'm happy to share, if you'd like, about some of the reasons besides structural reasons. But yes, I think that every child, every percent we get below 95%. And you can't look at the state as a whole. You can't look at it as a county as a whole because there are pockets of low immunization rates off in schools.
In those situations where we have those sporadic outbreaks, is that typically because we have a cluster of unvaccinated children?
Yes, because
And
the measles outbreaks
so
are totally
so the children in
preventable.
those same areas whose the parents had similar concerns as Ms. Cook, and they vaccinated their children, are those children probably doing pretty well?
Yes, we have
Okay.
seen, I think the number is 7, I forgot from last Friday, of children who have received 2 doses of vaccine, of MMR, speaking specifically about measles, who have gotten measles. They have not died, they have not been hospitalized, and we know measles is one of our best vaccines we have, but still it's 97% effective. So 3% are just for whatever reason, it's often genetic, don't respond.
Okay, thank you.
May I add, we have vaccines required for public
Can you
school
use the
districts.
microphone, please? Thank you.
We have vaccines on the requirement list that tetanus and herd immunity don't go together. You can't have herd immunity from tetanus, but yet it's on the required list. So I understand the arguments for herd immunity and maybe, the misinformation that allowing us to be able to print these exemption forms at home would somehow increase the risk for other students. But we have required vaccines that don't have anything to do with your neighbor. So how do we parse that out? I mean, it's kind of, we're focused on MMR, we're focused on a couple of vaccines that are required per our code, but there are others that we're not even touching here. And that, if I am not vaccinated against tetanus, I'm not a risk to you.
Thank you, Ms. Evans.
Okay, Representative Schaffner.
So we've heard lots of bills just 1 or 2 ago about modernizing everything, but in this situation, you don't want this modernized. You don't want this website just to hit download and print out a piece of paper. Because that's just what the bill does, correctly? Mm-hmm.
Sure. Thank you for asking. I think what the deal is when we talk about new moms who are already hormonal and afraid and sleep deprived.
I'm just talking about modernizing.
Well, I'm talking about giving access easier will also spread that fear. It's not just, let's just make it easier, and what's the harm in that? There is a lot of unintended consequences to making this easier. I don't want to make my neighbor's life harder who don't want to vaccinate. I don't. I think I wanted to give you credit for you give so many freedoms for Texans. I love it. You give us freedom to worship. You don't even have to give a reason to not vaccinate. Texas has given every opportunity to choose to opt out. So it's not about modernizing. It's about, well, let's just continue to spread this, and let's spread the fear, and let's spread some unintended consequences that you don't intend. But being out in the suburbs of Houston, I see. And it affects them not just on paper modernizing, it affects their whole lives. And they go down a deep, dark tunnel, and they're in a vulnerable position. New moms and new dads are in a vulnerable position. We have to protect them too. And making it easier for people to just print out will also make it easier to disseminate. And hey, here's a nurse who's like, oh, you know what? You just came from another country. Let's get you in school. Here's the form. Just check this box. Let's make it easy. It's modern, no harm, no foul. But as a mother, that's just not how simple it is. I know you know that. I know y'all know that. But thank you for providing all the freedoms you do, and I appreciate y'all giving choices.
Right, so this is, back to individual freedom and parents' rights to do what they, just
Absolutely.
like
They
you
have the
do.
right to opt out of
Right,
vaccines.
they have the
Right.
right, you have the right to
Yes.
do what you want with your children and to download whatever forms you want from whatever websites you want.
Right.
And so, if this is just really technology,
The difference is that there's a legal duty to protect the children when you mandate them to go to school. There's the difference. Like, you don't have a legal duty to provide an option to opt out of vaccinations. You don't have that legal duty. You have a legal duty to protect your public schools. That's the difference. There's a difference.
well, as a parent, I have, they're my kids, my husband's kids. That's our legal duty and our right to protect them. It's not the school's job, it's my job,
Yes.
right?
We're partners though, right? We
Well-
partner together. If you're in public school, right?
Your children are none of my business. Do you have
I'm
anything
sorry to
else?
hear that. Sorry to
I
hear
mean,
that.
my job
Y'all are my representatives. You represent me.
Gary Gates does, yes.
Well, yes, but I would hope you do too.
Go ahead.
As far as I understand, this does not take off, I would like to see it take off the requirement for notarization, but it doesn't. So you'd still have to go to somebody to get it notarized. I don't own a printer at my house, so I'd have to find somewhere to print this, go take it to get notarized, turn it into the nurse. And if we're thinking that school nurses are just going to be handing these out like candy, I think that's pretty unrealistic. School nurses are not happy to provide these or to take them either. So I just don't understand the fear surrounding this form. This is a piece of paper.
Thank you.
Thank you.
Okay, Representative Johnson.
Thank you. Want to ask just about the science. What percentage do we need vaccination rates for herd immunity? And I'm going to call it herd immunity if that's okay. You said community immunity.
Herd immunity is what we've known it as for
Right.
decades. It depends on, I'm going to.
Talking to that mic if you don't mind.
It depends on, and I'm going to talk about viruses, but it depends on the pathogen. Measles is one of the most, if not the most infectious virus that we know. Therefore, we need the highest percent, and it's usually said to be 95%. There are other.
Say that again. It's usually meant to be 95%.
For
meaning-
measles.
For measles. But meaning if a community is vaccinated at 95%, you have herd immunity.
There aren't enough susceptible people for the virus to spread.
And by
Yes.
spreading, it means it gets passed on to folks
right,
like
to
Eloise,
infect.
who got congenital rubella, I believe, and her son has felt the consequences of that for his entire life. And I can see the pain in her face. Right? She's giving us a real big warning. And I can see it. And I appreciate you being here to do it. So the math, the science is 95%.
For measles.
For measles.
For measles. For mumps, I don't have the number in my head. It's something like 90%, because mumps is not quite as infectious as measles.
In the concept, I want to talk about the science then, because
Mhm.
the herd scientifically means 95% of our community has to have an obligation to everybody else, right?
That's right, to protect the people who can't be protected themselves.
So the herd means an overwhelming majority of the community needs to say, I will look out for everybody else, right?
Exactly.
It does allow us a lane of, I'm on my own, right? Problem is, in Texas, we're getting close to that point. That
We're
the on
below
their
that
own,
point, yes.
the on their owns are starting to overcome the statistical data of the herd to now make this community less safe in total.
Right.
Right.
And also, as I pointed out, it's not, you can't just look at Texas as a whole, you can't look at a county as a whole, because there are pockets of much lower immunization rates where diseases can spread.
Thank you for sharing that information, and you talked about misinformation or disinformation that's getting out there. We've seen this trend over the last decade.
Yes.
Opt out, opt in. I just want to highlight the hypocrisy. Okay, Michelle, because you say, and I've heard, your children are not my business. You can do what you want as a parent, right? Parents' rights.
I didn't say your children are not my business.
My colleague said, your children are not my business. But when we talk about parents' rights, right, the assumption is that every parent has the right to do whatever they want with their kid, and the state doesn't have the ability to interfere, right?
Okay.
And what we're hearing from the scientists is your decision about your child doesn't affect your child, it affects all the other kids in the school.
Okay.
And so your statement would be that your right to control your child is more important for us as a state than the other 95% of the kids that are doing it right to be able to protect themselves.
If you want to talk about me personally, my oldest was vaccinated fully up until age 4. My middle child was.
I'm happy. If you want to share that, you're welcome to, and I will open up that space. I'm not asking about your personal circumstance. I'm asking about your political stance and legislation.
It's an important part of
Okay,
my
go
story,
ahead.
and it's an important part of many people's story who are opting out of one, some or all. So an exemption can be one, it could be a few, it could be all vaccines that they're opting out of. It doesn't mean that you're fully unvaccinated, right? My middle child was on a delayed selective schedule and suffered adverse events from her routine vaccinations as an infant. We found out later in life that she has a genetic disorder. We don't test for it, so there's no way for me to know. So when we're talking about kids who can't be vaccinated, include my child in that, right? And include my child, the same child, who was required to get vaccinations for bilateral cochlear implants. So I understand. I am not unsympathetic or unempathetic. I get it. My kids have had their own health issues that put them at higher risk of adverse events in the future. So they also cannot be immunized, and I still would not ask somebody else to do something for my particular situation or my child's particular situation. That's my foundation.
I think the frustration here, though, is it's not about your individual right or your medical decision. It's about imposing this obligation on public education where we are asking all other families to send their kids. And so for my family circumstance, I have 2 nephews with severe special needs. So when COVID was raging around here and I wore a mask and people thought it was a political statement, I didn't want to kill my nephews. Not that I was worried about myself, that I was worried about transferring it to them. And they don't get to go to any school because not every school will take them.
There's 2 assumptions that are being made here. One is that when we're talking about kids with cancer or kids that are immunocompromised, that we're not talking about the kids that are exempted, because some of those exempted kids are exempted for those reasons, right? So, and then we're also assuming that this exemption is not let me rephrase this. Not having that exemption or not turning in an exemption means that I've done everything I can to protect my child's health. And that's just not true. We're assuming that getting a vaccine will protect you from everything that's out there. And it's just not the case.
I understand the exemption. My concern is it safe to say that vaccinations have become a political statement?
From all sides, yes.
Okay. It's become politicized, right? Us versus them. And the problem is once we get to 95% and we break that off, if we make this purely Republican or Democrat, right? Guess who suffers? All of us. So All I want to do is have an honest conversation. And I want to have
That's-
an
I'm
honest
trying to do
conversation around the dialogue.
Okay.
Because you've talked about parental choice and the fact that as a government, we can't tell you what to do on this because parents' rights are more important, right?
What I've said is that we have established as a state that parents have vaccine choice rights, and I think that it is unscientific to require parents to go through this onerous process in order to exercise the rights that we've established that they have. I think that it is not intended to protect the public health. I think that there is this process in place for, well, I won't
You
ascribe
don't think
any
school
motivation there.
immunizations are intended to protect the public
I'm
health?
talking about the exemption process, which is what this bill
But
is
the
about.
problem is, the more you change this, as you've been doing for 10 years in this building, the higher the rate of not getting immunized has gone up. So effectively, your advocacy is getting us to the point of losing herd immunity.
Well,
And that seems pretty
tell me
doggone
what the
dangerous.
herd immunity threshold is for tetanus, because tetanus is required for public school entry.
Because if a kid gets cut, if they go by the chain link fence and they get cut, they can die within 72 hours,
But,
right?
my question is about herd immunity. What's the
Well,
herd
the-
immunity threshold for
The
tetanus?
point is creating a public health situation around a circumstance in which you have a responsibility to children. We're not talking about adults. We're talking about a byproduct of this coming onto kids.
We're also talking about adults. Adults also use the exemption form.
I'm talking about kids. We're talking about public education. We're talking about kids.
I'm talking
This
about
is what this bill is about.
and what this bill is about, which is about the process to exempt yourself from requirements for vaccines for public schools, for institutions of higher education, for some hospitals to be employed, and for some daycare settings. So that's what this bill is about.
All potentially hotbeds of immunocompromised individuals that just want the same opportunity that the healthy people get. And that's a concern.
Okay. Well,
Okay.
I mean, we have a fundamental
You have
disagreement.
a fundamental right, right?
No,
'Cause
I said I have a fundamental disagreement with you.
Because we've had these fundamental disagreements about what parents can and cannot do and how they can and cannot support their children across a variety of issues.
We have never said that what our goal is to increase the number of people who forego vaccinations. Our goal is to protect the right that is already in law and to protect or to advance the ability to exercise those rights free of government intrusion.
And I think the warning that is all over Eloise's face is whatever your stated goal is, the reality is we're getting to a point of losing herd immunity.
And I want you to see
people
the
like
warning on
her
my
son,
face, which is that I represent thousands
you
of
represent an
families
organization
with children
that allows you to be here every day at the legislature, right?
I represent thousands of families who have children who have suffered adverse events from their vaccinations. I understand the warning that you're getting from her, and I fully empathize
Look at
with
it.
that. I have a deaf child that was harmed by vaccines. I hope you understand that. I hope
And
you
how do you
understand
know
that
it's
what
by
you
the
are-
vaccine?
What you are saying is that her story does not matter.
No, both of your stories matter. My question is, have you been able to show that it is the vaccine that caused the deafness? You said you had your daughter
No,
has
I
a
didn't say
genetic.
that caused her deafness. She has
I'm
a
sorry,
genetic disorder that caused her deafness.
I thought you said, I have a child that was made deaf by a vaccine.
No, I did not say that.
That's what I heard.
I've never said that in my life.
I apologize. That's what I heard. That's what I heard.
Okay, that's,
That's not what you're saying.
no.
You're saying your child has a genetic disorder.
She has a genetic
And now she can't get vaccinated, but you're not correlating vaccination with her injuries.
No, the genetic disorder is separate from the adverse events that she suffered from her vaccination, right? Her genetic disorder is thought to have put her in a position to be more vulnerable to an adverse event. So, because it affects multiple systems, one of which is her hearing, but that's separate, right?
Not caused by the vaccine.
The
And so I
genetic
would
disorder?
understand,
Correct.
and I want you to get it. I think what these women are saying is that they want to ensure that healthy kids that have the ability to be vaccinated, that can reduce the risk of infection spreading to your daughter, is their stated goal.
I'm not asking for that.
It's what we as a herd are willing to do for society. But if we're all not in on the game of being willing to be together and not individual, the game ends because the diseases win. They will win. Thank you.
Thank you. Representative Frank?
Yeah, thank you. On the folks that are vaccine hesitant, most of them, and this, I don't know if you have data on it, of the folks that you come in contact with, or the folks that don't want to take all the vaccines, do they take none of the vaccines at all? Are they taking some? Or do you have a breakdown of like?
I mean, we don't keep any, we don't house that kind of
Do you
data
have
or
a
anything,
guess
but I
from the
can, I
people
would
that
guess
you
that
deal
it's,
with? Is it like half
for the
the
most
half
part,
the
it's
ones
just
don't take
some.
any?
for the most part, it's just some.
Okay, because that's, I mean, from my experience, the vast majority I've talked to, I know very few people that take no vaccines.
Right.
Very few. There's some, but almost everybody I know says, I'm going to take some vaccines, I'm not going to take others. And I think it's really important because honestly, it has become political. And frankly, the disinformation has come. If people want to know why people are so vaccine hesitant right now, it's because some of the really stupid stuff that came out on the COVID vaccine. Completely, I mean, not understanding her. Yeah, anyway, there's a ton of disinformation. There's on both sides. And it has become political on both sides, okay? But there are some facts that we ought to look at. There's some, you mentioned this, again, it's funny. I said it earlier today, and you said, the measles vaccine is one of the best ones we have, which implies that we have some of the worst. Like some of the vaccines are not as good. There's a significant difference between the measles vaccine that is proven, there's virtually not, would you agree that there's a difference in the quality and the risks in the vaccines?
No, by
No?
the word good, I meant effective.
Okay, so there's
So
no
for the
difference
flu
in the,
vaccine, you
there's
mentioned
no
flu
difference in the
vaccine.
types of vaccines in terms of their
Vax-
quality and effectiveness? None.
Yes, effectiveness.
Okay.
Yes.
Effectiveness matters.
Yes.
Risk matters.
Influenza vaccine, you mentioned it. Some years, I think this year we're seeing it's 50% effective. That means half of the people who are immunized with the influenza vaccine will get influenza, but they will not be hospitalized and they will not die.
Right.
Okay? It doesn't protect you, half of the people, from getting influenza. It protects you from
You're
hospitalizations
talking about the flu, talking
and
about the
death.
flu shot, right?
Flu shot.
But like, okay, so
All vaccines are safety tested for multiple.
Right, but there's some that there's some, to Representative Johnson's point, there's some that are herd immunity sensitive. Measles, pretty important herd immunity. The flu shot, I don't take the flu shot. Why? I don't get the flu much. And it doesn't-
56,000
ma'am,
people
let me
die.
ask a question.
I'm sorry.
Okay? Yeah, I know people die of that, but the people die from the vaccine because you get sick. And there is risk with every vaccine, is there not? Is there some risk with every vaccine?
I get a sore arm every time
Ma'am,
I
is there
get
some
that.
risk with every vaccine,
Of
including
course,
death? Okay?
But you have to weigh the risk of the vaccine versus the risk of the illness.
Absolutely. And there is a spectrum of risk reward of the vaccines. So I'm just going to go through 1975, 24 vaccines. By 1985, 27 vaccines. Then we waived liability for big pharma, right, to produce the drugs. Now there is no liability. Do you know how many are required or on the CDC recommendation for a child under 18? Do you know how many different doses a child under 18 is supposed to take?
Not off the top of my head, but I know it's higher, and I say that's wonderful. We can protect children from diseases like rotavirus and HIV, Haemophilus B influenza that we couldn't before.
No, and I again, I think, like, I feel like we've got these, you know, anti-vaccine, and then every vaccine is good, and there's just no way to go in the middle ground. We've got 86 different shots, more than any other first world country, way more. And it's because our laws are different. I promise you, if the drug companies had to pay for the challenges of those drugs, and most of them are great, but again, to act like there's not a spectrum is a little bit concerning. So that's way beyond the scope of the bill. I'm gonna get off that, but the bill, I think, just makes it a little easier to do something that's already in law.
Yes.
I thought, when we boil it down. But I do believe in vaccine. I just think it's important to understand that the vast majority of people that are vaccine hesitant are not taking any vaccines. And it's certainly, I think the measles, I don't know what the percentage, but yeah.
Thank you, Representative Jones.
was listening to the discussion between the panel and Rep. Johnson, and I will say this, that I'm a relatively new grandmother. My granddaughter is 1 year and 3 months. She has allergies and eczema, so right. Seems like she's allergic to almost everything. And as a grandparent, that concerns me. You know, I don't want her to eat peanuts. You know, I don't want her to die. You know, and it's interesting because my son it's his daughter, and, you know, I'm asking, can she eat eggs? You know, because I don't want to give her something. Found out she's allergic to raspberries. Like, who knew, right? And so with measles, when I learned, you know, because I got vaccinations, my mother vaccinated me. I immediately called my daughter-in-law and my son and said, has she had a vaccine? And they're like, oh, they don't give these vaccines until they're this age. I was like, well, she can get it now. You need to take her, right? Because I think that I'm concerned with sending my granddaughter places where there is not herd immunity, because my granddaughter has a weakened immune system. And as a grandparent, it's really hard to watch her not be able to do what other kids do. And so I talked to my son and my daughter-in-law, and I'd never thought about this, like maybe we shouldn't send her as if she's my child. It takes a village, though, to public school if kids can opt out, because if there's not sufficient herd immunity, my granddaughter could literally get sick at school and die. And when I look at vaccines, whatever they are, polio used to wipe people out. Measles used to wipe, and by wipe them out, I mean kill people. And so I think that for me, it's not political. For as much as people want to say it's political, for me, it's about, does my granddaughter wake up every day and have a good quality of life? And if she can get a vaccine that helps her not get something, or that helps her, if she gets it, to stop her from being hospitalized and dying, that's important to me. That is not political. And so it really breaks my heart to have it be, because everybody, I'm certain, believes from the depths of their souls that they're right about whatever it is they're talking about. But immunocompromised people deserve herd immunity, because they can't protect themselves, not through no fault of their own. I mean, unless they decide not to get a vaccine, and then it's on them because they made a decision. And I think for adults can make a decision whether I want to not take a vaccine and risk the chance that I'll get something and maybe die or be hospitalized. But I think my biggest concern is children who don't get to decide their health care. It's up to their parents. And if they get sent to a school, you know, where there may or may not be herd immunity. So to the extent anybody says, at least for me, this political, is not. It's literally a matter of life and death for something really I didn't even know existed before I got on this committee, you know, last session. Because I tend to be very healthy, and sometimes you just take for granted certain things. But I remember getting vaccinations. I have not that y'all care to know this, but I have a mark on my rear end from when I was little, when I jumped when the doctor put the needle, you know, in me. But you know what? Now that I'm older, I appreciate that needle mark, because I think it probably protected me from some things that maybe got other people. So it's not always political. And I just worry about children who don't have a say about whether they get vaccinated or not, and whether they go to school where the other kids there may be vaccinated or not. And yes, I believe parents have rights. But so it's a tough decision to make. But I'm gonna err on the side, I want my granddaughter to live and not catch something that vaccines have eradicated, but for like herd immunity. And that's what I have to say on that.
Any other questions? Thank you so much. Oh, I'm sorry, Representative Simmons.
Thank you. Thank you for being here. So I know my colleague Representative Frank brought up that we have a lot of vaccinations in this country, but I think maybe that aligns with we're also one of the few first world countries that doesn't have access to health care in the same way that many others do. And so can you talk a little bit about the burden that it's on us as a state when we just have kind of these just uncontrolled viruses and the amount of people getting sick? I think about the district that I represent. We have a pretty high rate of uninsured people and what that looks like when those viruses are just able to spread. And also, too, we're talking about the COVID-19 vaccine. I know that brings up a lot of hesitancy and concern, but I think what helped me make a decision for my children is when I tried to sign my daughter up for the trial at Texas Children's Hospital, and she had to wait, I think, a few months because all of the pediatricians and doctors and nurses had signed their kids up first. And I said, well, if anybody knows and understands how important this is, and I remember asking her doctor, and I was like, well, what is taking so long? She said, well, we have to wait through because all of the medical professionals have their kids in it first. But just talk a little bit about the burden that it puts on us and the strain it puts on us financially.
Yeah, I can talk about the measles, and I think you'll be hearing from some other witnesses, but the measles outbreak that we're seeing, almost 650 kids in Texas. It spread to 30 other jurisdictions. I'm sorry, that is not the right word. 30 other jurisdictions have measles. Not all of them are linked to the Texas outbreak. The estimates are that each case of measles costs between $30,000 and $50,000. Not all of them that much, but if you average it out, that's a whole lot of money. And although the fiscal analysis of this bill showed some savings, it's wiped out by just a couple of hospitalizations. It puts a strain on hospitals. We see that during flu season where ambulances in Houston are on, and other places as well, but are on drive-by status. There's no room in the inn, and you've got a heart attack. All the beds are full with influenza patients, and you have to be driven farther away. That's not great. So yes, it does. By not protecting children and adults from diseases we know how to protect them from, it puts a strain both economically and, on doctors and nurses, other healthcare providers.
Can I answer as well? Thank you. My mother died at 67. She couldn't get the flu vaccine and she had complications of the flu. And during COVID, I had my father living with me. He was in end-stage renal disease, and he had a hard time getting shots, even electricity when Houston was frozen. He couldn't get dialysis. The burden that happens is not just on the government, which you laid out pretty well, but it's also on the families. As a mom of 3 boys, I have to take off work. And if I can't take off work, my husband has to take off work. My kid, who's just started his freshman year of high school, my oldest, he misses school. He's behind instantly. He starts making zeros in all his classes. So we're catching up, he'll miss a football game, a big rivalry Katy game. The cost is not just the government, but it's also on the schools. We've missed a lot of school for sickness, but I can't fathom how much school and work my family would have missed if it was a serious disease that was contagious that we had to quarantine for. I hated COVID. I had a kindergartner, a 2nd grader, and a 4th grader learning how to read in my kitchen while my husband's trying to work in the other room and I'm in law school. So I fully understand what COVID did to this argument and how it totally broke trust with us conservatives. I get it. I'm there. However, when I was in law school and we talk about the cost, the protections of individual rights cannot always just supersede the rights of the governed. So the cost is great. And the cost on me and my family when we're sick, just sick from the cold, is great, much less the measles or the flu, which cost me my mother, and end-stage renal failure, which cost me my father. So yeah, the cost is significant. Thank you for asking.
Thank you for sharing, and I hope to my other colleagues on the dais, y'all are in for a fun week on Twitter once this gets posted, because I got all kinds of death threats last week. It was very interesting, so yeah, good luck.
Any other questions? No.
And Ms. Sutherland, I just want to say thank you so much for being here. And for having the courage to speak up, and just thank you.
You're welcome.
Thank y'all for being here.
Thank you. Thank you.
The chair calls Gordon Madamo, Margarita Gomez, Dr. Jason Turk, and Michelle Gallus. Sir, I show you registered as Gordon Madamo, and you're with the TACCHO, is that correct?
Texas Association of City and County Health Officials.
Okay, and yourself, and you're against the bill, is that correct?
That's correct.
And you're with Andrews County Immunization Coalition?
Coalition, correct.
Is that correct? And yourself, and you're against the bill?
Yes, ma'am.
Correct? Okay, you may proceed.
So I'm Gordon Madamo. I'm testifying on behalf of myself. Texas Association of City and County Health Officials. I've been on their executive leadership team for 2 terms now. Andrews County Immunization Coalition, and I'm testifying in opposition to House Bill 1586. Thank you to the chair and the committee for the opportunity to testify. I'm from Andrews County in West Texas and drove 6 hours to come and testify. I'm the father of a fully vaccinated, thriving 17-year-old, a family nurse practitioner and director of a small local health department dealing with the current measles outbreak. I want to tell you what it's like right now for us in West Texas. Last week, I had to PEP, post-exposure prophylax, a 3-month-old child for measles. The child was not from Andrews. The child had been exposed in a clinic in Lubbock while in the waiting room. It took them some time to get a hold of the mother. It was the last day the child would be eligible for prophylaxis, so we made arrangements. The mother could not get to Lubbock. Lubbock was much further for her to go, so we made arrangements for her to come to Andrews County Health Department where we prophylaxed her. This is the 3rd baby under 6 months of age I've had to give prophylaxis to in the last month. These exposures were all for children with routine visits for family doctors or pediatricians. Making it easier for parents to get exemptions will enable parents who are already burdened by logistical constraints and access issues to opt their children out of vaccines out of convenience. The unintended consequences of this bill passing could be ugly, and I think we're seeing that now in Gaines County. I ask the committee to vote no on House Bill 1586. Thank you.
Thank you, sir. The chair calls Margarita Gomez, and you're also with Andrews County Immunization Coalition, and yourself, and you're against the bill, is that correct?
That's correct.
You may proceed.
Thank you. Good evening. Thank you, Chair and committee members. My name is Margarita Gomez, and I am representing myself first as a mom and second as a nurse. With experience in public health, working as a school nurse for 7 years and in our community health department for 4 years, I am concerned that House Bill 1586 will be the beginning of unraveling, going back on the safety and protection of our school communities. With the advancements of medication and technology, we have children with medical health conditions that previously would not have been able to attend, participate, and enjoy school as their peers do. There are also teachers and staff in supportive roles that are undergoing cancer treatments or other medical conditions that impair their immune systems. By making it easier for exemptions to be obtained will increase the chances of contagious illness spreading, putting those that are most vulnerable at risk. The outbreak currently undergoing in Texas is a testament to that. I understand parents are trying to do their best for their children. I do the best for my own as well. However, my concern is that the bill would leave vulnerable, medically fragile children and staff that might have
like to have gotten vaccines but can't, at a greater risk for serious preventable illnesses.
Thank you, ma'am. Any questions? Representative Johnson?
No, I just want to thank you both for coming and being here all day and the drive that it took to have you here. You can see the strain on your face.
You know, I want to make a statement. In Texas for vaccine, Texas TVFC, Texas Vaccine for Children program, wonderful program. We don't have enough access points in West Texas. 50% of the vaccines, over 50%, 53% of the vaccines we're putting into arms and legs are to patients that are coming from outside of our county. Our county is small, 18,600. We have people coming from Midland, Ector County, Odessa, and 14 other zip codes to get vaccines. There are many barriers to that safety net program. I just fear by making the process that easy, we're going to have parents who just do it for convenience and may intentionally want to vaccinate kids, just not going to get around to it.
And what is the consequence if we continue on this trajectory that we have been on over the last 10 years of seeing an increase in not participating in these programs? What's the public health consequence to all of us if this continues on this trajectory?
I think we're seeing that right now. Gaines County, Seminole, which is the epicenter of the outbreak, is 20 miles from us. We have, I think this week we'll go up to 4 cases. We still have a couple of tests pending, last I heard. Andrews County, our kindergartners and 7th graders, we have about a 97% coverage rate on MMR. We're not going to see huge community spread with a good coverage rate like that. But we're going to see breakthrough cases, and we have.
And you said that you're treating some of these children?
We have lots of folks from Gaines County seeking medical care in Andrews. So we've had over 300 exposures in hospital ER waiting rooms, in the ERs, healthcare workers. We have to follow up on all those. And folks that we don't know their immune status, we have to prophylax them, preferably with the MMR vaccine within 72 hours. Sometimes we don't get names, we can't get a hold of people within that 72 hours to get them prophylaxed. So we have the option of doing immune globulin up to 6 days out. And we've been pretty successful in catching lots of people. So we're doing a lot of post-exposure prophylaxis with the vaccine and plenty with the immune globulin as well. And then we've run into some people who just don't want the post-exposure prophylaxis. So we put them on monitoring for 21 days.
It's kind of like trying to catch an invisible forest fire, isn't it?
Yes.
Okay. Thank you.
Any other questions? Thank you so much for being here.
Thank you.
We showed Dr. Jason Turk as registered but not testifying. Also, the chair calls Michelle Galles. She's registered as testifying. She will not be testifying. Registered but not testifying. Okay. The chair calls Ana Montañez. The chair calls Charles Stern. Chair calls Barbara Radnowski. Chair calls Caroline Green. Ma'am, you are registered as Ana
Montañez.
Montañez. And you are here on behalf of yourself and you're against the bill, is that correct?
Yes, ma'am.
You may proceed.
Thank you. Thank you, Chair and members of the committee, for this opportunity to testify today. My name is Dr. Ana Montañez. I am a general pediatrician in Lubbock, Texas, and a West Texas native. I was born and raised in Presidio County, Texas. I am here to oppose House Bill 1586. I believe House Bill 1586 would limit a parent's decision-making opportunity, and it would limit my opportunity as a provider to have very meaningful and educational discussions with families. I want to share a brief story to illustrate how the pediatrician child-parent encounter is so very important. This starts with a 6-month-old child who comes to see me due for her required 6-month vaccines. She lives in a county that has over 300 confirmed cases of measles, a county that has a 14% exemption rate. Her parents knew that measles was highly contagious. They knew that the vaccine was very protective. They knew that their child was very vulnerable, but they wanted to discuss waiting on administering the measles vaccine. They came to me with fear of not making the right decision for their child. We had very frank and open discussions, and they asked very hard questions. We discussed disease, complications, risk, prevention, vaccine efficacy, and vaccine safety. Then Mom took a deep breath. She glanced at me through tears in her eyes, but a warm smile on her face. "Thank you," she said. "We're ready." In that very moment, fear was overcome, and peace replaced fear, because she knew that she was making the right decision for her family. This pediatrician, child, and parent encounter gives families a safe space to address questions, and it should not be skipped over. House Bill 1586 would make it easy to skip over this opportunity. Please do not eliminate the opportunity for families to ask questions and to empower themselves through knowledge so that they can overcome fear.
Thank you, ma'am, for your testimony. The chair calls Charles Stern.
Yeah,
You're
good
Charles-
evening.
You are
Yes.
Charles Stern, and you're registered, you're with the Texas Medical Association, Texas Pediatric Society. You're against the bill, is that correct?
Yes, I am.
Thank you,
Yes.
so you may proceed.
Thank you for letting me speak this evening. So I'm Dr. Charlie Stern. I'm a family physician of over 38 years. I work in Waco, and I am speaking in opposition of House Bill 1586. In the pre-vaccine era, 40% of childhood deaths were related to infectious diseases, most of which are preventable today. On 1 month in 1984, when I was a medical student, I took care of 4 children ages 6 to 18 months that died of H. flu, either meningitis or sepsis. And those conversations that I had with those parents, having to console them, lives with me today. So I asked, when we think of parents from that era, think about what their moral sentiment was at that time. So vaccines were formulated and administered in response to this blight and led to over 99% reduction in disease rates and mortality rates for many of these diseases. Vaccines have been found to save 154 million lives, including 146 million lives under the age of 5 over the past 50 years, and they've helped contribute to increase in life expectancy of 30 years. The CDC noted from 1994 to 2023, childhood vaccines prevented 507 million illnesses and 32 million hospitalizations, led to direct net saving of medical costs of $540 billion and net societal cost savings of $2.6 trillion. So Texas went above and beyond to enact a bill that allowed people to express conscientious exemption. I'm concerned about this bill accelerating the exemption rate, and I'll be glad to give you data on that and lead to more outbreaks of vaccine-preventable diseases.
Thank you, Doctor.
And thank you for your time.
The chair calls Barbara Radnowski, and you are here on behalf of yourself, and you're against the bill, is that correct?
Yes, I'm against the bill.
Yes, you're against it. You may proceed.
I'm Barbara Radnowski, longtime resident of Chairwoman Hull's District 138. I'm mother to 3 adult children and grandmother to 5. They and the rest of Texas children are why I'm here today. I thank Chairwoman Hull for her service to the community we both call home, but I must oppose her legislation. I was born the year after the Salk polio vaccine was licensed, and when I barely started school, we got the measles vaccine. I grew up in an era where parents were breathing sighs of relief that their children could avoid disabling and fatal diseases. I believe all my children grew to healthy adulthood thanks to the power of immunizations to prevent suffering and death. HB 1586 would turn the non-medical exemption into one of convenience rather than conscience. This can only lead to lower vaccination rates, increasing the risk of disease outbreaks as we sadly see them sweeping our state. You know, Ronald Reagan often said that things resonated to me. He said facts are stubborn things, and sometimes those facts are hard to accept. 18% of Gaines County kindergartners, where this measles outbreak started, are exempt from one or more vaccines. 18%. Having raised 3 kids and as a frequent caregiver to our grandchildren, I believe in parents' rights. All parents have the right, yes, and the duty to protect our children. With all due respect, you all have the duty to protect all children. I think we, as a community, share this responsibility. Our neighborhood is close-knit. Years ago, I was elected president of the Architectural Review Committee. We pay social calls. We buy Girl Scout cookies. We look out for our kids and grandkids playing on the street. We neighbors believe, like most of District 138, in caring for one another. HB 1596 holds potential for truly dangerous, negative, unintended consequences. The decision y'all make about this bill will have life or death consequences for Texas children. Please think about that.
Thank you for
Thank
your
you kindly.
testimony. Okay, Chair recognizes Caroline Green, Dr. Caroline Green, testifying on behalf of self against House Bill 1586. Is that correct?
That's right. Yeah, good evening. So my name is Caroline Green. I'm here. I'm representing myself in opposition of HB 1586. Thank you, committee chair, and thank you, committee members, for the opportunity to testify today. I'm the mother of 4 young children, ages 1 to 6, who are or will be students in Texas public schools. My perspective on this bill is informed by my concern for my daughters, given my background. I'm an internal medicine physician with a public health master's degree and a military veteran. I trusted that professionals giving me vaccines throughout my life had both my and my country's best interests at heart. Now, my children trust me to protect them in a state with an active measles outbreak, complete with child deaths that was entirely preventable. This bill does nothing to protect my children and instead makes it more likely that they will be harmed. My kids are lucky. Their mom is armed with the ability to identify and interpret scientific studies and identify disinformation. What about the others? In what universe are school children protected by forms primed for mass distribution by the wording of this bill that make it easier for them to be denied life-saving vaccines during an outbreak? What happens to my only partially MMR vaccinated 1-year-old twins at public school events, which will soon be the scene of regular measles transmission? This bill makes it easier for people who lack my level of training and access to healthcare to be taken advantage of. I don't know what it will take for Texans to trust science again. Maybe we will reach some critical mass of child deaths that tips the scales back. Or maybe it's too late, which is unfathomable. And I am here because I want my 4 little children to know when they are old enough to understand this era of Texas history that I tried. I tried to use basic reason with their leaders in whom we have entrusted their health. Please vote against this bill. Thank you so much.
Thank you. Chair recognizes Laura Kinchelow. I'm sorry. Chair recognizes. Done with this panel?
Great.
Okay, members, do we have any questions for this panel? Oh, sorry. I'm sorry.
That's okay.
I'm sorry.
That's okay.
You're getting your
Ready to go.
exercise after sitting here all day.
It's all right.
Okay, thank you for testifying.
Okay.
Okay, the chair calls Laura Kinchelow, Eloise Sutherland. Okay, Kenneth Stanley. Rekha Lakshmanan, and Melva Gonzalez. Okay, do I have Laura Kinchelow? Okay. Laura Kinchelow, testifying on behalf of the Texas Nurses Association and self, testifying against House Bill 1586. Is that correct?
That's correct.
Thank you.
Good evening. I've scratched out morning, afternoon, and evening. I think it's officially good night, hopefully soon. Thank you for the opportunity to be here today. I'm Laura Kinchelow. I serve as the Director of Nursing Practice at the Texas Nurses Association. Been a proud registered nurse in Texas for the last 14 years, and I'm here today to testify against HB 1586. One of the first experiences I had in nursing school was the process of medication administration. And within that process, I learned the importance of medication rights and the importance of patient education in everything I did. And we learned about community health and public health. And I was really proud to have that as my first learning experience as a nurse. Not ever anticipating I'd be here to talk about and advocate for public health. But I want to talk about that I'm very concerned that we are asking to loosen our immunization policies amid a very concerning measles outbreak in which we've lost 2 children. We have currently 646 cases confirmed, 64 people hospitalized. The burden of hospitalization alone is extreme. I have two additional concerns around spreading misinformation. Families who are not familiar with the science of vaccines would be misled and would take exemptions out of convenience because they wouldn't have to schedule their routine doctor's appointments for their children. And I want to talk about something that was said earlier about in a previous legislation about the importance of a parent and a patient relationship with their care provider. This is important to have, and those regularly scheduled provider appointments is important to have the ability to provide education. Decisions about healthcare treatments and vaccinations should be made with the patient and family in collaboration with their healthcare provider. We just heard so many examples today, and I hope you understand that what we're doing is loosening a policy that's already working, and I hope that you'll vote against this legislation.
Thank you. Dr. Kenneth Stanley. We'll show Dr. Kenneth Stanley registered against, not testifying. Rekha Lakshmanan, testifying on behalf of the Immunization Partnership against House Bill 1586. Is that correct?
That's correct.
Thank you.
Thank you. My name is Rekha Lakshmanan with the Immunization Partnership, and I'm testifying in opposition to House Bill 1586. We are all aware of the rapidly growing national and international attention our state has received to the largest and possibly the most expensive measles outbreak Texas has seen in 30 years. What started here is now spreading to other states. Thus far, 2 Texas children have died from a disease that is preventable. Our concern is this bill is a distraction. For years, Texas has struck a good balance between parents' rights and public health and safety. Under current law, the parents of almost 120,000 school-aged children have used the existing system to exercise their right to opt their kids out of vaccination. Let's not mess with what's working, especially right now. One thing to note, the outbreak in Gaines County is not a coincidence. The data is clear and common sense. The risk of an outbreak is greatest when under-vaccinated or unvaccinated people cluster together. HB 1586 will significantly increase the likelihood that other, potentially much larger counties will experience comparable outbreaks. Not only is the measles outbreak a growing public health concern, but it is also expensive. Our public health system is stretched, and millions of our tax dollars are being used to pay for a public health response that didn't have to happen. Counties are already crippled by uncompensated healthcare costs, and this bill stands to make that much more costly. Now is not the time to experiment with immunization policies in Texas. Not only will this bill normalize outbreaks, these outbreaks are leading to serious concern that the U.S.'s measles elimination status is at risk. In closing, I urge the committee to vote no on House Bill 1586. This is a case where practical realities can be deadly, and those realities include children falling ill, being hospitalized, and/or dying. This is not theory or conjecture. This is the reality happening in real time in our state. Thank you.
Thank you. Who is our- Chair recognizes Melba Gonzalez, testifying on behalf of self against House Bill 1586. Is that correct?
That is correct. Thank you. Hello, my name is Melva Gonzalez, and I am representing myself. I'm testifying against HB 1586. Thank you, Chair Van Dever, and the committee members for this opportunity to testify. Today, I want to emphasize how HB 1586 threatens to undermine the essential implementations established for controlling diseases and preventing the resurgence. As a parent to two kind and beautiful teenage daughters, I recognize the tough choices we face that can affect our children's health and safety, and nothing is more important than ensuring their well-being. When my eldest daughter was born, I had concerns about vaccinations, and I was inundated with conflicting information from various sources. Luckily, with the support of a knowledgeable and very caring pediatrician and credible resources, I was able to navigate through the noise. I chose a delayed vaccination schedule for both my daughters. And because I chose a delayed schedule, it was necessary to complete and submit the exemptions to their schools. I can tell you that the process was no way burdensome, nor did it delay their start, and it did not infringe on my rights as a parent. It was a very simple process. The mere consideration of this bill is concerning, especially amid the current measles outbreak in Texas. The passing of this bill will open the door to future dire implications, potentially posing a direct threat to our state's health. The viruses responsible for serious illnesses are still out there, poised to spread among unvaccinated individuals, as we are witnessing firsthand. We cannot afford to loosen the preventive measures that safeguard our children and communities. Allowing individuals to bypass a system that enforces our strict health guidelines is nothing short of reckless. We must stand firm in upholding the restrictions currently in place, which were established to help control or eliminate these diseases. In conclusion, I empathize when it comes to a parent's decision to vaccinate. For me, vaccinating my children has been one of the best choices I've made and one of the few aspects over which I have complete control in safeguarding them and our community. With that, I ask that you please do not pass HB 1586.
Thank you for your testimony. Representative Busey.
Thank you, Mr. Chairman. I'm sorry if I missed this. Did one of y'all share a stat on do we know how many families or kids have taken advantage of the process now to get the exemption?
Yeah, so I distributed to everybody a chart that we've been tracking since non-medical exemptions became available in Texas. That's the one. So as of the last school year, we're at about 118,000 plus.
So 118,000 children through their parents have taken advantage of the current system.
That's correct.
But we're having a bill here that acts like the system doesn't work for Texans, even though 118,000 have effectively done it. Seems like the system works, and those that want to balance parental rights, even potentially at the expense of the safety of others, have that option under current law. I mean, based on the testimony you were just sharing, wouldn't you agree?
Yes, absolutely. Like I mentioned, I chose a delayed schedule, which required that I provide an exemption to my daughter's schools. The process was simple. It did not prevent them from starting school. It did not infringe on my rights as a parent. It was a simple process, so just leave well enough alone, in my opinion.
No, I agree with you. Thank you.
You're welcome.
Chairman Frank.
We've had a lot of discussion on vaccines, which is really not in the bill. What the bill does is just change, I think, where you get online and request, and then the agency then mails you a form and changes that to printing out a form. Is that what the bill does? Is that your understanding of what the bill does?
That's my understanding, and
Okay.
it is
'Cause, I mean,
one
we're
of the
talking about-
reasons we have concerns, or that I have concerns.
But I mean, that's what the bill, so instead of a state agency person mailing the form to the person, you just go online and you print it out. That's the bill.
I mean, yes, that's the bill.
Okay.
How,
I was just checking.
But I
Thanks.
would like to say that the current process we have kind of serves as a guardrail because number one, we want to make sure that, parents do have the ability to opt their kids out of, one or more vaccines. But we also want to make sure that parents are well-informed when they're making those decisions. And as you can see through the graph, that it looks like parents have had an easy time getting an exemption. I think there's been a lot of discussion about motivation, why people go and get an exemption. And I think the motivation runs the gamut. It runs from parents who have questions about vaccines, and I respect that. We want to be able to answer questions parents have about vaccines. But we also know that oftentimes access is a big issue. And if families live in rural Texas where they're having to drive hours to go get their kids vaccinated, there may be a decision that they're going to have to make, which is like, well, geez, am I going to go get an exemption because I need to get my kid into school and I'll deal with it later, or not get my kids vaccinated at all? And that's what we're trying to think about. We're trying to think about the consequences. So motivation, I think, is a separate discussion that requires a lot of time. But at the end of the day, we're looking at what the consequence is associated with that exemption. And unfortunately, we're seeing those consequences play out right now in Gaines County and in the surrounding counties.
Thank you. Members, other questions? Okay. Thank you for your testimony.
Thank you.
Chair calls Jackie Schlegel, Tracy Ramsey Abbott, Susan Ronza, and Heather Roll. Okay, I have Jackie Schlegel testifying on behalf of Texans for Medical Freedom and yourself. You're for House Bill 1586, is that correct?
That is correct. Thank you, Chair Van Dever. I am the founder and executive director of Texans for Medical Freedom, but more importantly, I'm the mother of 2 medically complex children, one who has profound special needs. If anyone is qualified to speak on this issue from both a policy and a practical perspective, I do believe that I am. So I want to be abundantly clear about this bill. This bill is not about whether vaccines are good or bad. This bill is about 2 things: government efficiency, keeping kids in school. And for the sake of clarity and honesty, I'm going to be upfront and honest with you and tell you that none of my children are unvaccinated. None of them. Okay? But despite that fact, my families and others like mine are used as political pawns in the debate over vaccine exemptions. So let me be clear. If someone is testifying today that makes this bill about vaccinations themselves, they are not being truthful about what this bill actually does. So let me tell you what this bill actually does. It simply allows a parent to print out the exemption form and exercise their right that's already protected by law. Okay, we already protect that. So right now, you go to a state website, and you request the form. Oftentimes that form can take 3, 4, 5 weeks. Not only can kids not start school, there's been so many phone calls I've gotten where children have been humiliated because they were pulled from the beginning of school. Schools lose money and children lose crucial educational time when they are yanked from class. This is not a public health strategy. This is bureaucratic red tape hurting children. This is about access, consistency, and this is about allowing parents to comply with the law without having to fight the system to do so. Thank you.
Thank you. Chair recognizes Tracy Ramsey Abbott.
Yes.
Okay.
Thank you.
Hang on just a minute. I show you testifying on behalf of Texas Nurses Association and yourself, and you are against House Bill 1586. Is that correct?
Yes, that is correct,
Thank
Chair.
you. Proceed.
Thank you. Good evening, Chair Van Dever, Vice Chair Campos, and members of the committee. I am Tracy. I'm a member of Texas Nurses Association, and I am here to oppose HB 1586. I've been a nurse for 30 years, and vaccines are one of the most powerful tools we have to protect public health. They do prevent dangerous diseases and save lives. And right now, Texas has a process in place for families seeking vaccine exemptions, one that makes sure they fully understand the risks before making the choice. HB 1586, as written, would remove this safeguard, making it far too easy for families to opt out without knowing the consequences. By allowing the unlimited download of exemption forms, it opens the door to misinformation, making exemptions more about convenience than informed decision-making. As nurses, we see firsthand how devastating vaccine-preventable illnesses can be. Higher exemption rates lead to outbreaks, putting infants, the elderly, and those with weakened immune systems in danger. This bill would push exemption rates even higher, putting our communities at unnecessary risk. We urge you to protect Texans by opposing HB 1586. Thank you.
Thank you. Members, questions for this panel? Representative Jones.
This is to you, Nurse Abbott. You talked about, and let me just talk about what HB 1586, what I understand it to do, and then I'm going to ask you about a concern that you raised. Makes it easier for parents to get vaccine exemptions for school children. Requires the state to post blank exemption forms online so people can print them. Removes security seals from exemption forms. Adds a statement that parents acknowledge the risks and benefits of vaccines. People can request a form without giving personal information. That's what it does. You talked about unlimited copying. When you remove the security seal, without the processes that we have now, the security seal, because of how you have to do it, would allow the state to track how many exemptions, which is why we have this form that somebody gave, where we can tell how many exemptions there are.
Mm-hmm.
If the seals are removed and anybody can copy it, then we literally don't know. As a parent, I guess now as a grandparent, do you think it would be helpful for parents who are responsible for the care of their children to be able to tell, for example, how many kids are exempted at a certain school so you can make a decision about whether you want to send your kid to that school? Or in my case, I'm being a nosy grandmother, send my granddaughter, because I'm definitely going to tell my child and my daughter-in-law what I think, especially since I sit on public health. Do you think that would be helpful for parents to be able to know how many exemptions are at the school that your child is at?
I think that anything that a parent can do to understand the situation that they're putting their children in is definitely helpful. This is publicly available information, and if you hinder that, it would make it more opaque. It would muddy the waters on how many people are being exempted, for sure.
I actually would like respectfully disagree with the word opaque, well, unless it was 100. I mean, it was like, because you like literally wouldn't know.
Right.
I mean, you wouldn't know, so it'd be a black, like when you cover your windows. And I think that as a parent, we should at a minimum know about the exemptions so that we can make an informed decision about whether we want our children to go to those schools. So it seems simple, it seems like it's not a big deal, but there's a reason why the security seal, it's called a security seal because it gives us a form of security.
100%.
Right? To remove that, because then you don't know how many are being printed, you don't know what schools are getting them at. The state of Texas can't track it, and it just puts me as a grandparent at a disadvantage. And I think that's what you were saying.
Yes, ma'am. Yes, it is. Yes,
Okay.
Chairwoman.
I do want to clarify that under the current process, the state cannot track those exemption forms. That data is not kept in a system, which I think is a double-edged sword, because I got a lot of phone calls this school year where parents requested the forms and the department has no way to track whether they've been sent or not. I mean, that's really at the heart of this bill, is kids who are utilizing the exemption in the process that they are protected to do are not able to start school on time. And the privacy protections mean we can't track those forms down.
I would imagine if a kid is being pulled out of school, then somebody knows the form isn't filled out, so that is a form of tracking.
Correct, but that's tracked on the school level and not by the department when they mail them out. For instance, I have probably 50 of these forms at home. Never a shortage in my house of the exemption forms because they are used. When you request those from the state does not keep that information or that data. That is tracked on the school when they are used.
So unless I've been misinformed, it's my understanding that the Texas Health and Safety Code, section 161.004E, says DSHS is required to maintain a record of the total number of affidavit forms sent out each year, report that information to the legislature annually, but not maintain a record of the names of the individuals who request the affidavit, which is where I presume this came from. So that is a form of tracking.
I would assume that those are the numbers from the school side, but I could be wrong about that.
DSHS has to report that to us every year.
I just want to clarify that the forms sent out are not necessarily the forms then being used. A family can request up to 5 forms at one time when you request them from the state.
But
if you don't get them in time, you can request them again. You can end up with like 20 or 30 forms.
But at least the state knows they sent that family 20 or 30 forms. With what's suggested now, we have no clue how many forms there are. So it's some information rather than no information.
I understand. I just wanted to be clear on my understanding of how they are tracked.
Okay, and I just wanted to be clear that DSHS has to report all that information to us.
The numbers, yeah.
Right, yeah. Thank you.
Members, other questions for this panel? Okay, thank you for your testimony.
Thank you.
Thank you.
It's Dr. Susanna Carranza. We will show her registered against, but not testifying. Heather Rowell. Show her registered against, but not testifying. Chair calls Patsy Schonbaum, Daniel Bradford, Jolene Pohl, Sheila Hemphill, looks like you're the last one
That's it?
standing.
I'm it.
Okay,
Well, good evening.
Hang on, let me
Okay.
get you registered in. I show you registered as Patsy Schonbaum, testifying on behalf of the Jamie Group and self against House Bill 1586. Is that correct?
Correct.
Thank you.
So, good evening. My name is Patsy Schonbaum. Thank you for this chance to speak. I'm here to oppose House Bill 1586. I come today as a business person, a lifelong Texan, and the mother of a child affected by a vaccine-preventable disease. I'm also grandmother to 6 and proud aunt to Dr. Zeke Silva. So, yeah. Of all my titles, mom is the most important. I have tremendous respect for all the moms on both sides of this issue. I love all my neighbors as my own, and yes, that does include those here today standing in support of this bill that I oppose. My daughter Jamie contracted meningitis and almost died. She was not vaccinated against meningitis, and therefore she was vulnerable to a preventable disease. Her life changed, and my life changed. Today, she is thriving despite her significant injuries. But since the day I learned of her diagnosis, I've dedicated my life to helping other moms avoid learning the same horrible news. I want to tell you why I'm not here at the Capitol. I'm not here to tell other parents how to live their lives and how to care for their children. Current Texas laws allows parents the option to send their children to public schools without a single immunization. I'm not here to make people already busy lives even busier. Access to vaccines should be simple, easy, and cheap. However, I am here today because Texas thrives when Texans love other Texans. And I'm here today because I know all too well what happens when immunizations lose priority. People die, more people suffer, and this is truly a life or death conversation we're having today. So I'm here today to speak for the infants, for the immune-compromised individuals, and for those Texans who medically cannot get immunized and are at greater risk. I want nothing today. I simply ask that you please maintain the current immunization process to ensure the health and safety of Texas communities.
Thank you.
Thank you for your time.
Thank you for your testimony. Members, questions? All right. Thank you for testifying. Is there,
Sheila Hemphill.
okay, I show you registered as Sheila Hempel, testifying on behalf of Texas Right to Know and yourself for House Bill 1586. Is that correct?
Yes, sir.
Okay, go ahead.
Yes, I'm Sheila Hempel with Texas Right to Know, and I've had the privilege of working with functional physicians since 2008 as I went to recover my own health. And with that, I was privileged to do their web development, and many of this had to do with what the vaccination situation. I'm for this bill because it should expedite what is necessary for parents to have easier access to be exempted from vaccines. Now, I know what the bill's talking about, but I've also been listening to what everybody else has been saying all night. So I'm going to pitch in on some of the conversations about the measles. Both of those cases were done a forensic review by Dr. Pierre Corey. And in it, he designated that the types of illness that these children were given the wrong antibiotic set based upon either an acquired, community-acquired bacteria that was a mycoplasma, and that the medication that was given was the wrong protocol on both instances. And I can get this information out to the offices that it was the wrong protocol based upon the bacteria, the infections that they had. One was hospital-acquired and one was community-acquired. That they missed it. One of them was that they submitted urine and blood when they should have submitted sputum. So there was distinct medical situations of poor decisions on the wrong antibiotics. With antibiotics, you have to match them. That's how come if you have a respiratory infection, you get a different antibiotic than if it's in urinary. You have to match the right medication with the right symptomology. And it was a miss. And this is done in a report that I will get out to the committee members. We all want clarity, but we cannot look at 1 in 31 children coming down with autism with the number of viruses that are being exposed on an initial vaccine and not think it doesn't have an effect. So thank you.
Thank you for your testimony. Members, questions? Okay, thank you.
Thank you.
For testifying. Is there anyone else who wishes to testify on, for, or against House Bill 1586?
I'm so sorry. I thought that I had registered for this.
Okay, what is your name?
My name is Becca Harkleroad. I'm with Texas School Nurses Organization. Did I miss the bill number?
Can you repeat your last name, please?
Harkleroad, H-A-R-K.
Yeah, I think I remember calling that. Let Alex get it registered. So, okay, is there anyone else who wishes to testify on, for, or against House Bill 1586? Okay. Chair recognizes Representative Hull to close.
Thank you, members. There's been a lot of testimony on this bill that y'all have very patiently listened to. But I'd say most of that testimony had absolutely not a single thing to do with this bill. This bill is not about the pros or cons about vaccines. It has nothing to do with it. Y'all, this is about printing a form versus having it mailed to you. It is literally that simple. This is just about a form. This does not make it easier to opt out. The process now, it's not that it's hard. You can go online and submit your request online. This is simply about how long it takes and delaying children their fundamental right to an education when they cannot start school on time. These are children, their parents have already made this choice. These children are going to be they're going to school, no matter what. They are going. This is just about them not starting, or this is about them starting on time. And like I said in my opening, it's also about government efficiency. Why are we hiring 4 FTEs every summer to print and mail forms that people can print themselves, go get it notarized themselves, and submit it to the school district themselves? And there is a lot of talk about how it's tracked and the numbers. No matter what, even now, and even with this bill, school districts still report the number of these forms. That is the number that truly matters. School districts have asked for this, so children are not starting, so children are starting on time. I also heard, and I know in my opening I talked about some of the things that I thought witnesses would talk about, and they did. I heard a list of incompetent people that I made list of, that I wrote down. Moms, hormonal moms, immigrant moms, lazy moms, new moms, and rural moms are apparently all incapable of deciding any of these decisions for their children, and apparently being able to print a form somehow makes them incompetent, and it's going to change the decision that they have already made. I want to reiterate that this is about printing a form versus mailing a form, government efficiency, and starting school on time. It is not about anything else. So if anyone has any questions, I'm happy to answer, and I will close.
Okay, members, questions? Okay. Thank you.
Thank you.
If there is no objection, House Bill 1586 will be left pending. Is there objection? Chair hears none. House Bill 1586 is left pending. Chair lays out House Bill 3708. Chair lays out a complete committee substitute. Chair recognizes Representative Oliverson to explain the bill.
Thank you, Mr. Chairman and committee members. I know it's been a long day already, and I know you got more work to do, so I'll try to be expeditious. We're going to shift from talking about vaccines to talking about charity care. House Bill 3708 would create new requirements for charity care screening and billing practices at not-for-profit hospitals. It's important to note that the legislature has not revisited this issue in statute since the mid-90s. Right now, in order for a nonprofit hospital to be in compliance with Section 311 of the Health and Safety Code, they must have signs in their lobby informing patients that they have a charity care policy, and they must post one print ad in their county newspaper. According to WPA Intelligence polling, 87% of Texans are unaware that nonprofit hospitals are obligated to provide charity care to low-income and uninsured patients, even though 30% on average of Texans do qualify for this care. And I think it's important to point out that the why of this is that we, the state, have authorized these facilities to be tax exempt. In exchange for that, the flip side of that is that there's supposed to be a certain amount of charity care that's provided. Recently, the legislature got a $5 million spent, I'm sorry, let me say that again. Recently, the legislature spent $5 million for a report to look at transparency and disclosure requirements for nonprofit hospitals, but we're unable to confirm compliance in most areas, including how many patients applied for charity care, how many patients were rejected, how many rejected patients were sent to debt collections. And so what we're seeking to do with this legislation is to provide better information or a better process so hospitals are informing people that charity care exists and that they may qualify it, and B, that they would be obligated to follow their own charity care guidelines before sending a patient to a debt collector who would otherwise be eligible for charity care. And I think in the interest of time, I'm going to stop there, ask if there are any questions, and I'm going to let my witnesses take it home.
Thank you. Members, any questions for Dr. Alderson? Okay, we will reserve the right to close.
Thank you.
Chair calls John Hawkins, Jared Walker, Zachary Cook, and John Rickert. Okay, I have John Hawkins, registered as President and CEO of Texas Hospital Association, against House Bill 3708. Is that correct?
That is correct.
Thank
Thank you, Mr. Chairman and members. I want to stress that Texas has one of the strongest charity care laws in the nation. It requires nonprofit hospitals to provide a minimum amount of charity care each year. Most non-DSH hospitals do this by providing charity care and community benefits totaling at least 5% of net patient revenue, of which 4% must be charity care and government-sponsored indigent care. In 2023, DSH has reported that all 127 non-for-profit hospitals in Texas met the required charity care minimums, delivering $4.8 billion in charity care after supplemental payments. That exceeded the state's charity care minimum by 139%. Total nonprofit community benefits, including charity care, were $12.9 billion. Charity care policies are not and should not be a one-size-fits-all solution. Current law gives hospitals flexibility to set policies according to their own resources and community needs. However, patients at or below 175% of federal policy limits can receive free care at every single Texas not-for-profit hospital, proving that flexibility does not prevent low-income Texans from receiving meaningful discounts. Texas hospitals already have a strong regulatory and financial incentive to identify charity care eligible patients, and that data overwhelmingly shows that they are doing that. For this reason, we have the following concerns with the bill. The Texas charity law applies only to hospitals. Section 1 of the bill uses the loose term facilities and practices to bring patient revenue from an unclear set of non-hospital entities into the charity care test. This is problematic from an accounting standpoint. 2, requiring non-DSH not-for-profit hospitals to screen all patients, including insured, for financial assistance is an excessive one-size-fits-all process. Thank you.
Thank you for your testimony. Chair recognizes Jared Walker, testifying as the Executive Director for Dollar For and Self. And you are for House Bill 3708, is that correct?
Correct.
Thank you. You may proceed.
Thank you so much. My name is Jared Walker. I'm the founder of Dollar For. We're a nonprofit organization that helps patients reduce their medical debt by enforcing hospital charity care policies. Most people don't know that nonprofit hospitals are required to offer charity care to low-income patients. And on paper, these programs do exist, literally on paper. Like you might see a poster in the ER, maybe. In practice, too many patients never find out about these programs. Most patients leave the hospital without any knowledge of these programs. At Dollar For, we've built a national database of hospital charity care policies. Patients can find out if they qualify within seconds and submit a digital application. We send it to the hospital, and we advocate on their behalf. Since 2021, we've done this over 30,000 times, erasing more than $86 million in medical debt. Now, you are probably wondering, why does Dollar For need to exist? And you are not alone. The truth is, it is not enough to have policies on paper. Patients need real access and real help. Today, you each received a page highlighting a different patient from Texas, someone who faced a massive hospital bill and was forced to make an impossible choice. Do I pay my rent or a medical bill, groceries or hospital payment, continuing my education or bankruptcy? Luckily, these patients found Dollar For, and we were able to do what the hospital should have done. But this should not be the case. Dollar For shouldn't have to force hospitals to extend a program that they are legally required to have. Right now, Texas is where we see the greatest need, the most applications, the biggest bills, the longest wait times. Patients here are fighting not for just their health, but their financial futures. By requiring hospitals to screen patients for charity care before billing them, you can change that. Thank you.
Thank you. Chair recognizes Zachary Cook, testifying on behalf of Self for House Bill 3708. Is that correct?
That's correct.
Thank you.
I'm Zach Cook, live here and work here in Austin. In June 2020, I was run over by a car on 45th Street in Mopac, standing on the sidewalk in the afternoon, and got rushed off to Ascension Seton Hospital. Did really great, get me back together, sat in the hospital for a couple weeks, and got sent home to recover. Kind of thought that was the good side of this. So had insurance, got home, legs broken, neck's broken, and have to figure out what I'm doing next. And all of a sudden, kind of the bills start rolling in. So got surprised by about a $78,000 bill. Because this was COVID, my salary had been cut significantly. That left me in kind of a weird place. How do I pay a $78,000 bill with half a salary? So luckily, my fiance had been scrolling on some social media and found Jared over here at Dollar For. Jared got on the phone with me with these hospitals, advocated for us, helped me through the charity care process, and weeks turned to months trying to get answers. Those answers were slow to come. We reached back out and back out and back out and followed up and kind of had the same responses, just sit and wait. Bills went to collections, and that was kind of it. That was kind of the way it went. So, as far as knowing about charity care, there was nothing ever stated when I was in the hospital to me, and it was just very lucky that we found an organization that could help us out.
Okay, thank you. Chair recognizes John Rickert, testifying. Hang on just a minute. Testifying on behalf of Self for House Bill 3708. Is that correct?
That's correct.
Thank you. You may go now.
Hi, my name is John Rickert. I'm a student here at the University of Texas at Austin. I'm from Cypress, Texas. I am here testifying on behalf of myself in support of House Bill 3708. I support House Bill 3708 because it will give hospital patients the opportunity to be screened for charity care before a bill is sent to collections, saving them the pain and stress of medical debt that they may not even owe in the first place. Since I heard about Dollar For in August of 2024 when I came here to UT, I've gone out to local Austin underserved communities every week to spread awareness about charity care and how $4 can help in the process of applying for it. Out of the hundreds of people I have talked to at these volunteer outings, not once have I heard the words, "I already know about charity care." What I have heard, however, are stories about getting hit by trucks, the death of a sister causing hospitalizations, and food poisoning that would have resulted in death if not for the intervention of EMTs. While all these stories seem tragic but unrelated, they're all connected by one common thread. At the end of each of these stories are large medical bills that victims of tragedy are forced to somehow find a way to pay with little to zero guidance. Although those who are interested in learning about $4 usually approach our table with suspicion, oftentimes, by the time I finish explaining what charity care is and how it can affect their lives, those who are suffering from medical debt have a complete shift in demeanor. Their suspicion turns into cautious optimism, and even the thought of any kind of relief to the burden of medical bills that they carry daily is enough to inject a hopeful look into their eyes. Now, I'm just a volunteer, and I by no means can nor claim to speak for the patient. My account is simply a collection of my observations and the stories that have been shared with me throughout my time volunteering in these communities in Austin.
Thank you for your testimony. Chairman Frank.
Yeah, just got a quick question for THA. The bill only applies to not-for-profit hospitals, is that correct?
That's correct.
Okay, so I've seen a number of studies that show there's very limited difference between the charity work that not-for-profit hospitals do in the state versus for-profit hospitals. And I'm guessing do you agree with that, or is there a place I can go to find the difference between the charity work done at for-profit hospitals versus not-for-profit hospitals in the state?
Yeah, we can provide you that data from a number of sources. The uncompensated care data the state collects, and the Myers and Stauffer report, which was referenced, actually has those calculations as well. So it varies, but the investor-owned public hospitals do a considerable amount of charity care in the state. So we can provide that data.
Wait, say that again. The
investor-owned for-profit.
Okay, yeah, they do. I mean, because it seems like they both operate kind of the same. You have to take all comers if you're a hospital. So the charity work of a not-for-profit doesn't seem significantly different than a for-profit. I'm wondering, what is it, if not this bill, what is it that y'all are doing that for-profit hospitals aren't doing, because other than paying a lot of taxes?
Well, I mean, if you're big in Medicare and Medicaid, both of those payers underpay, so there's
Right,
a shortfall.
But a for-profit hospital operates in the same arena.
Correct.
So there is no difference. I ask, what's the difference between where a not-for-profit, what does a not-for-profit hospital do for its not-for-profit status that a for-profit hospital doesn't do? Because the reports that I've seen show that it pretty much is the same.
Correct. Sorry, Slade.
Okay, so it's correct. So what's the point of having a not-for-profit hospital if they don't operate any different than a for-profit hospital?
I mean, there's a whole variety of reasons. It's mainly the tax status that has an implication on bonds and otherwise, so.
Okay, so basically, I mean, you're the head of THA, and you're telling me really that for-profit hospitals, not-for-profit hospitals, that's kind of crazy. I mean, honestly, you just said the not-for-profit that's not paying taxes, that basically pushing their tax burden to every other member of the community, is doing the exact same thing as an investor-owned hospital. That's kind of enlightening. Like I would think a not-for-profit hospital, and I know most not-for-profits, you're talking tens, $20 million of taxes not paid, and THA is saying they operate basically the same as a for-profit.
I'm not saying they operate the same. I'm saying they all are in the charity care and uncompensated business at the same level. They are
But
structured very
shouldn't a
differently.
not-for-profit be doing something different in order to earn its not-for-profit status?
Well, no, they have to meet the minimum of the charity care statute, the state charity care statute.
Right, but But those could be exactly the same. The for-profit
They-
can be
they
doing that
could
as
be,
well
but
because,
they
yeah, I
could
mean,
be, but they're not.
I think you
not
answered my question. They
always.
operate the same, just one doesn't pay taxes, so, thank you.
But they do have, the not-for-profit hospitals do have to meet the minimum requirements of the state charity care standard.
But wouldn't it be correct to
An
s-
investor-owned hospital does not.
Well, you say they don't have to meet them.
They don't have to.
But since they have to take all comers, there's a really good chance the for-profits would meet those charity standards as well because they're having to take the uncompensated care. They're having to take all
Not
comers as well.
always, depending on where you're located and what your payer mix. I would say, from a system level, probably so, but
I just think
not always.
if people want to continue with the nonprofit status, there should be actions different than investor-owned. If not, it would be better for everybody to have investor-owned hospitals, and that way we can get tax revenue
Well,
from
no,
it.
they,
Thanks.
they very clearly have a higher standard. The state of Texas actually has the most stringent charity care law in the state, the 5%. So not-for-profit hospitals have to meet that minimum standard. Not all hospitals have to meet that standard.
I'm sorry, Chairman, but they don't have to meet it. But I feel like you also said, I'm not trying to be argumentative, but I feel like, well, I guess I am a little bit, but I feel like you said they operate the same way. One has to meet that, the other one does.
I misstated. I meant they are all in the uncompensated care, Medicaid, Medicare shortfall.
Okay.
All hospitals are in that business. Not all of them meet the.
I'll let you stage left because it's 10:30, but if you could provide that information that shows that not-for-profits actually do more community, do stuff for their charity care, I
will
would
do
appreciate
that.
it because it's inconsistent with what I've seen.
Okay, I'll do that.
Representative Alcott.
Thank you, Mr. Chair. Just one quick question for Mr. Cook. Glad to see you're doing a lot better. What hospital were you treated at?
UT.
Is that nonprofit?
Yes, sir.
Okay, thank you.
Chairman.
Representative Johnson.
Thank you. I did want to follow up because even for-profit and nonprofit hospitals, they all provide charity care. Nonprofit hospitals actually provide millions of dollars in
Billions.
charity. Billions?
Yes.
Okay. And so you'll follow up and give us
Yes,
some
I will
information.
provide that data to the committee.
Yeah, thank you.
Okay. All right, thank you for your testimony. Chair calls Guhan Periyasami. Sorry. Elizabeth Colvin. Emilio Das. And Carl Isett. Okay, I have Guhan Periyasami, and I show you testifying on behalf of Let's Crush Medical Debt at UT Austin and yourself, and you're testifying for House Bill 3708. Is that correct?
Yes, that is correct.
Thank you. You may proceed.
Right. Good evening, everyone. My name is Guhan Periyasami. I am a third-year student at the University of Texas at Austin and the co-president of Let's Crush Medical Debt, a college chapter of the national nonprofit $4. I'm here today to voice my strong and urgent support for House Bill 3708. Leading my organization, I've seen up close the devastating toll medical debt takes on people's lives. I've met countless hardworking, honest individuals, people just like you and me, who are doing everything they can to build a future for themselves and their families. Yet, a single medical emergency, a single hospital visit can unravel everything they worked for. Their dreams, their stability, even their dignity, all crushed under the weight of bills they had no way of preparing for. What's even more painful is knowing that help is out there. Charity care programs exist for this very purpose, but too many patients never even hear about them. They slip through the cracks because the system expects them to navigate it while they're at their most vulnerable. This is not just unfair, it is cruel. House Bill 3708 offers a common sense, compassionate solution. Hospitals already screen patients for insurance. Adding one more simple step to screen for charity care eligibility would lift an enormous burden from patients' shoulders without placing significant strain on hospitals. We have the opportunity to do better. We have the opportunity to make the system work for the people it's supposed to serve. I urge you, for the sake of families across Texas, to support Bill 3708.
Thank you for your testimony. Chair recognizes Elizabeth Colvin, Executive Director of Raise Texas, and you're testifying for Raise Texas and yourself for House Bill 3708. Is that correct?
That is correct.
Thank you.
My name is Elizabeth Colvin. I'm the Executive Director of Raise Texas. We are a statewide coalition advancing financial stability for low and moderate income Texans. I am also a community health worker certified by the state of Texas. This bill strengthens the community benefit requirement for nonprofit hospitals and protects vulnerable Texans from unnecessary financial harm. Right now, the burden falls 100% on patients. They must somehow know about charity care, figure out how to apply, and face lasting damage to their credit if they don't succeed. That burden outweighs any administrative effort required of hospitals. This bill offers a simple, targeted solution to fix this imbalance. In my work as a community health worker, I've seen how broken the charity care process is. I remember sitting with a man drowning in hospital bills, talking on the phone with the hospital's patient financial counselor. And she wanted to help the patient, but she needed him to use the right magic words before she could even begin the process. It was like searching for a hidden key to unlock basic help that this patient clearly needed. It should not be that hard. This bill makes a small but vital change, requiring certain nonprofit hospitals to screen patients for charity care before sending their unpaid bills to collections. This means eligible patients won't have to guess magic words or have their credit destroyed. I respectfully urge you to support this bill.
Thank you. Chair recognizes Emil Das.
Yes.
Testifying on behalf of Let's Crush Medical Debt and yourself for House Bill 3708. Is that correct?
Yes, sir.
Okay, you may proceed.
Good evening, everyone. I just really want to thank you guys, Chairman Von Deaver, and all the members here at the committee for the opportunity to testify. I really want to reinforce what my colleagues have already expressed. My name is Amio Das, and I'm a junior at the University of Texas at Austin. I reside in District 136 and am represented by Representative Boucy. I'm here on behalf of the organization Let's Crush Medical Debt to express support for House Bill 3708. Even as my short time as a volunteer at nonprofit organizations such as Sunrise and Micah 6, which really try to help low-income Texans survive, I have seen and personally witnessed how medical debt can impact the lives of these individuals and families. Seeing fellow Texans express concern about and fear about receiving further care or even foregoing personal care for members in order to save money has made me question what we can do to help support these individuals. Too often, I encountered people overwhelmed by confusion and surprise when charity care is even brought up, revealing a troubling lack of transparency in communication by hospitals, something I really believe should be fixed. If hospitals can screen for insurance, then charity care is well within their reason. I truly believe that it is unjust that individuals facing medical crises are further burdened by simply a lack of information, which deserves to be better circulated. Because of this, I urge you and everyone here to be in support of HB 3708. Thank you.
Thank you for your testimony. Members, any questions? Oh, Representative Schofield.
Mr. Periasamy, what part of Texas are you from?
I'm from Katy, Texas.
That's what they tell me. Which county do you live in?
Fort Bend.
Oh! Why did none of my constituents ever come to this committee? Thank you for coming all this way.
Thank you.
Okay, thank you for testifying. Chair calls Eli Rushbanks, Nicholas Armstrong, Tanner Alif, and Shreyas St. Paul. do I have Eli Rushbanks? Here. Okay. Show you registered as Eli Rushbanks, testifying on behalf of Dollar Four and yourself, and you're for House Bill 3708, is that correct?
Yes, sir.
Okay, you may proceed.
As was stated, I'm Eli Rushbanks, General Counsel at Dollar Four. So our research, I guess my device has decided to shut down. Our research has found that only 29% of eligible patients actually receive financial assistance. And I'm probably going to go between the terms financial assistance and charity care. I use them interchangeably. Largest reason is because they just don't know about it, or they confused it with something like a payment plan. When surveyed, 65% of eligible patients found that they we found that 65% of patients who were eligible and didn't apply because they lacked knowledge about charity care. And for patients who do apply, this is often a pretty grueling process. 45% report receiving no help from the hospital. About a quarter report the process as being hard, and 14% of applications are never even responded to. We get more requests for help at Dollar Four by Texas patients than any other state in the country. Our patient advocates go through this process with patients every step of the way, and they log problematic behavior that we see at the hospital. This can be not returning phone calls, not claiming that the hospital didn't receive an application when they did. And again, we have more troubling instances logged in our database from Texas hospitals than in any other state. So to put it bluntly, from our position, Texas hospitals are just not keeping up their end of the social contract. Nonprofit hospitals receive tax exemption to provide a community benefit, which includes financial assistance to low and middle income patients. They've treated this as a compliance checklist and not as like a serious obligation. For the most part, they're technically compliant. They have policies on their website, vague disclosures in the emergency room, but they've built a little bit of friction into every step of the process, which for most patients causes the entire thing to come to a stop. The most frustrating part about all this is that increases in financial assistance do not jeopardize hospital financial viability. By definition, financial assistance only applies to patients who can't afford to pay anyways.
Thank
and
you.
Thank you, sir.
Thank you for your testimony. Chair recognizes Nicholas Armstrong, testifying on behalf of Texas Public Policy Foundation and yourself for House Bill 3708. Is that correct?
Yes, sir, that is correct.
Okay, you may proceed.
Thank you. Good evening, and thank you, Mr. Chairman and members of the committee, for the opportunity to testify today. I'm Nicholas Armstrong with the Texas Public Policy Foundation, and I'm here to testify in support of HB 3708. Nonprofit hospitals play a crucial role in supporting our communities, and many nonprofit hospitals go above and beyond spending for the minimum for the charity care requirements. Texas is one of 5 states with minimum spending requirements, but even with these requirements, Texas still faces significant issues with oversight when it comes to disclosure requirements, according to the recent HHSC report. For example, the HHSC report stated that there is no oversight or procedure in place to monitor compliance for a lot of these disclosure requirements for patients that the report found. HB 3708 would require the nonprofit hospitals to screen patients for its charity care program before sending them to debt collections. Other states have passed similar pre-screening requirements for nonprofit hospitals and saw them update their programs with minimal administrative cost or burden. And some saw that more patients had access to this important financial assistance policy. Other states right now are considering legislation that would create a pre-screening requirement as well. A more proactive charity care screening process would ensure that Texans do not fall through the cracks and have timely access to this important safety net. Thank you for your time and your consideration, and I can answer any questions.
Thank you. Chair recognizes Tanner Olive, testifying on behalf of Paragon Health Institute and self for House Bill 3708. Is that correct?
That is correct, sir.
Thank you.
All right. Chairman, Vice Chair, members of the committee, thank you for allowing me to speak to the issue of statutory ambiguity surrounding charity care that I believe HB 3708 aims to address. So for the record, Texas hospitals do play a vital role in preserving, healing, and at times saving Texans' lives. Hospitals are also some of the most heavily regulated entities in America. Therefore, they've had to become masters of compliance in order to continue their noble work of treating patients. The issue at hand is not a matter of Texas nonprofit hospitals being out of compliance with the law. The issue at hand is that there are thousands of Texans who are eligible for charity care that are not getting it. They're wrongfully getting sent to collections. They're wrongfully getting sued over medical debt, as our charitable hospitals are indeed in compliance in Texas with Texas law. That's the issue. I contend that eligible Texans are struggling to get charity care because current Texas statute is outdated, ripe with perverse incentives, fails to give our agencies the necessary data to provide oversight, and lacks any type of punitive process for any bad actor neglecting their voluntary role in the healthcare safety net. There are many holes in statute I can point to, but one that I think of was actually mentioned. It was created 30 years ago. In 1993, the legislature actually created minimums for expectations for charity care spending for both non-disproportionate share hospitals, think of large metropolitan hospitals, and disproportionate share hospitals, think of critical access hospitals. And then in 1995, there was an amendment that allowed these large non-disproportionate share, these big hospitals, to deduct their bad debt from the minimum of their operating revenue that they were expected to spend. The results of these laws incentivized hospitals who historically spent a lot on charity care to lower their spend to meet the minimum, and the hospitals that were historically spending less got to stay less by deducting the medical debt that they're holding on to, sir.
Thank you. I'm going to butcher your name, and I apologize up front.
No, you're good.
Okay. Shreyas St. Paul?
Yes, sir, that's correct.
All right. I have you testifying on behalf of Let's Crush Medical Debt at UT Austin
Yes,
for House Bill 3708. Is that correct?
Yes, sir.
Thank you. You may proceed.
Hey y'all, my name is Shreyas St. Paul, and I'm a current freshman studying biology here at the University of Texas at Austin, and I'm originally from Fort Worth. I'm here today testifying in support of House Bill 3708. Now, as a volunteer with Let's Crush Medical Debt, the UT Austin chapter for $4, I volunteered at various Austin area food banks and homeless shelters spreading information on how socioeconomically disadvantaged individuals can take advantage of charity care for applicable medical bills. One thing that I've noticed over the past year of volunteering with this organization is that not a single person has actually known of this resource, which is available to them. The stress of a hospital visit alongside existing financial challenges only worsens when medical bills go to collections, which can lead to a cascade of problems. I've connected with many individuals who have shared with me the stress they are under with medical bills coupled with the financial struggles they already face. By supporting House Bill 3708 and requiring hospitals to make the simple change of screening patients for charity care, we can help to make sure that all Texans get the assistance they need before their health crisis turns into a financial one. Thank you.
Thank you. Members' questions of this panel? All right. Thank you for your testimony. Okay, Chair calls Vignesh Kulanthaval, Neha Garlapada, Clifford Porter, and Christy Snodgrass. Okay, I have Vignesh Kulanthaval testifying on behalf of Let's Crush Medical Debt at UT, Austin, and self for House Bill 3708. Is that correct?
Yes, sir, that's correct.
Thank you. You may proceed.
Thank you. Good evening, everyone. My name is Vignesh Kulanthaval. I'm originally from Katy, Texas, and I reside within District 26. I am a sophomore studying biology at the University of Texas at Austin, and I am the Community Partner Coordinator for Let's Crush Medical Debt. I am here in front of you all today to testify on behalf of our organization in support of House Bill 3708. From starting out in my first year, I've had the privilege of volunteering with underserved communities at local sites in Austin and spreading awareness about $4, a nonprofit organization whose mission it is to help eligible patients suffering from hospital debt access charity care. One story that particularly stuck with me was from a year ago when I met a middle-aged man at the Micah 6 food pantry. He told me that he required surgery to treat his chronic sinusitis so that he could breathe soundly and sleep peacefully at night. However, burdensome hospital bills left him helpless, and he eventually became unable to pay his rent and was ultimately evicted from his place of residence. From hearing stories like these, one underlying truth holds constant for all: the fact that many hospitals are not making charity care known and accessible, thereby putting the burden on patients to seek out these services. A health crisis should not translate to a financial crisis, and I support this bill so that people whose livelihoods depend in part on their credit score are screened for charity care before their bills are sent into debt collection. This will ultimately save them from the pain of having to navigate distressing financial circumstances while dealing with their own health situation. Thank you for your time.
Thank you. Chair recognizes Neha Garlapati, testifying on behalf of Let's Crush Medical Debt at UT Austin and self for House Bill 3708. Is that correct?
Yes, sir.
Thank you. You may proceed.
Thank you, members of the committee, for the opportunity to testify today. My name is Neha Garlapati, and I'm here today as a volunteer with Let's Crush Medical Debt at UT Austin in strong support of House Bill 3708. Through my volunteer work, I've met so many people facing heartbreaking medical debt, but one story in particular stays with me. A 32-year-old living here in Travis County was hit by a truck a few years ago. He survived, but the crash left him with over $10,000 in medical debt, even though he had MAP coverage. Every day now, he deals with chronic pain and stress, made worse by the constant fear of going back to the doctor because he's terrified of getting charged even more. His debt has hurt his health, his ability to work, and his sense of stability. Unfortunately, this story is not unique. Across Texas, people who should qualify for charity care have no idea it even exists. Hospitals are quick to screen patients for insurance, but when it comes to charity care, patients are left completely on their own, usually at the worst moments of their lives. The burden is placed 100% on them, and many simply don't have the capacity or the knowledge to navigate them. HB 3708 simply asks hospitals to check for charity care eligibility before sending bills to collections, just like they already check for insurance. It shifts the burden back where it belongs onto the hospitals and not the patients. It gives people a fair opportunity to be screened and avoid the heartache of a ruined credit score and a lifetime of financial damage. If nonprofit hospitals are receiving tax benefits to serve the community, they should also be held accountable for ensuring that help actually reaches the people it's meant for. I urge you to support HB 3708 and protect Texans from unnecessary medical debt. Texans deserve a fair shot at recovery, not a lifetime of debt. Thank you.
Thank you. Chair recognizes Dr. Clifford Porter, testifying on behalf of Texas Public Policy Foundation and self, and you are for House Bill 3708. Is that correct?
Yes, Chair.
Thank you. Proceed.
Yes, yeah, Dr. Cliff Porter in support of House Bill 3708. So I'm the Senior Fellow for Healthcare at the Texas Public Policy Foundation, for whom I represent myself. And I'm a practicing physician using the direct primary care model, Texas Direct Medical Care. So I have many uninsured and low-income patients in my practice because our clinic is the only medical care they can reasonably afford. And they quite often pray not to need major medical care. So many are gig workers, independent contractors like realtors, and so they may or may not necessarily qualify for some traditional programs like Medicaid. So for major medical events, surgeries, accidents, cancers, they rely on charity care and financial assistance programs. So the nonprofit hospitals, have variable financial assistance, the programs and application process that are quite confusing, as many people have said. Yet the charity care and financial assistance programs are an essential part of our social safety net. So I had a case where one of my patients, who's a realtor, had a stomach mass requiring urgent surgery, sent her to the ER and locally, and told her once you're there, ask for an application for financial assistance programs and charity care. Well, she had the tumor removed, so that turned out well. But the social worker told her after the surgery in the hospital, well, you're too late to apply, so you can't apply for it. And so within a couple of weeks, she started getting about $70,000 to $80,000 worth of bills. So she didn't know how to, navigate the system. So I had my staff call around, and my staff had to call around to find the office that handled the charity care. They gave us another phone number for the patient to call, leave a message, leave their address, and they would send a paper application chart. And so now it's been a year, and it's still ongoing with this. We're making little progress, actually, with $4 helping us out. So the clearer standards in this bill will make charity care available. And then one last comment on the community benefits the charity care quite often account in the hospital accounting is quite often just advertising campaigns. So they can do a variety of tricks to, accounting tricks to basically use charity care. So recommend some auditing on that. Thank you, sir.
Thank you. Chair recognizes Christy Snodgrass, testifying on behalf of $4 and self for House Bill 3708. Is that correct?
Yes, sir.
Thank you. See.
My name is Christy Snodgrass, and I'm the Director of Communications at $4. We've helped patients apply for hospital financial assistance programs at almost every hospital in the nation, but before this work, I spent nearly a decade as a nurse. I was born and raised in South Texas, where I worked as a chemotherapy nurse at a large nonprofit hospital system in my area. I loved being a nurse, and I intended on making it my long-term career, but watching patients drown in medical debt wore me down. My pivot point came when I spoke to a patient who was recently retired and was draining his savings account to pay his hospital bill. He said to me, if I had known that I'd lose everything that I ever worked for just by coming to the hospital, I would have stayed home and died. After that, I became a case manager where my job was to help patients navigate financial barriers in that same hospital. But despite all my internal trainings and all my years working in that nonprofit hospital, not one person told me about charity care. It wasn't until years later, after leaving the hospital, that I learned that financial assistance programs for low-income patients exist. And not only do they exist, but federal law actually requires nonprofit hospitals to have these programs in exchange for their tax-exempt status. Unfortunately, the law as it's written requires hospitals to have these programs. It does not require hospitals to apply patients for them. That means that if a patient doesn't know about charity care, they could be sent to collections, sued, garnished, all for a bill that should have never existed. HB 3708 could stop that. It's simply proposing that before hospitals send a patient a bill, they check to see if the patient qualifies for help. I'm asking that this committee protect patients by ensuring that they get the assistance they deserve. Thank you.
Okay, thank you. Members, any questions? Okay, thank you all for your testimony. Okay, the chair calls Noah Valencia, Rishit Yakanath, Shvet Patel, and Rai Mehta. So I have Noah Valencia. Which one is that? You? Okay. Testifying on behalf of Let's Crush Medical Debt and yourself, testifying for House Bill 3708. Is that correct?
Yes, that is correct.
Thank you. You may proceed.
Thank you, Chairman, and thank you, committee members, for allowing me to testify. I'm Noah, a UT student from Houston, Texas, and I'm here to testify in support of House Bill 3708. I'm the volunteer director for Let's Crush Medical Debt, a UT organization part of a larger nonprofit called $4 that tells people about charity care. I volunteered at Sunrise Homeless Navigation Center and a food pantry called Micah 6, and nobody I've talked to has ever heard of charity care. And many people I've talked to who would have qualified for charity care may no longer be able to get it because their bill is over a year old. If House Bill 3708 had been in effect, those people would have been able to get the care that the state had already deemed they deserved. One patient, a 38-year-old man who hadn't sought hospital care since childhood and relied on MAP, fainted from not eating for 2 days. Though he was told at the ER of a nonprofit, Ascension Seton Williamson, that his visit would be covered, he was later billed over $1,500. And unaware of charity care, he was unable to pay rent afterwards. He now avoids all medical care, even telling friends not to take him to the hospital if he's critically injured. With the passing of this bill, we can help ensure that no one else will be overlooked. Thank you.
Thank you. Chair recognizes Rishit Yakanath, testifying on behalf of Let's Crush Medical Debt for House Bill 3708. Is that correct?
Yes, sir, it's correct.
Thank you.
Good evening, everybody. My name is Rashid Yokanand, and I'm testifying in support of House Bill 3708. I'm a junior neuroscience major at UT Austin and originally from Dallas, Texas. I also had the pleasure of serving as the co-president of Let's Crush Medical Debt, a school club that partners with the national nonprofit $4 to crush hospital bills through charity care. I've loved my 3 years as a part of this organization, and it's given me the listening abilities, compassion, and fight for the rights of patients that I hope will make me a great physician in the future. I remember talking with the woman at Micah 6, which is a food pantry our club volunteers at 2 times a week. She had a black widow bite on her face, and she described how part of her face had to be surgically removed, resulting in a bill of $5,000 that she could not pay off. Even though $4's resources were eventually able to help her crush her debt, she was unable to take out a loan for housing because of how the bill tanked her credit score, resulting in a cycle of homelessness for her. And like many of the stories told today, a lot of this could have been avoided if she was aware of charity care. But the problem was she was not. I urge you to support House Bill 3708, because by screening people for charity care before the bill hits collections, the devastating impacts that hospital bills can have on people's credit scores, housing, and stability can be reduced tremendously, thus shifting the burden from vulnerable patients to the hospitals entrusted to serve them. Thank you for your time.
Okay, thank you. Chair recognizes Shivet Patel, testifying on behalf of Let's Crush Medical Debt for House Bill 3708. Is that correct?
Yes, that's correct.
Thank you.
Good evening, everyone. My name is Shweta Patel, and I'm here to testify on behalf of Let's Crush Medical Debt in support of House Bill 3708. Like my colleagues, I too have volunteered with Let's Crush Medical Debt, and I've seen firsthand how people suffer from medical debt from hospital treatment. What's upset me the most is that they don't know about charity care that nonprofit hospitals offer specifically for people in their situations. Supporting this bill means standing up for dignity. It means recognizing that health and financial stability should not be mutually exclusive. Let's make sure that getting better doesn't come with a lifelong penalty. Thank you.
Thank you. Representative Johnson.
Thank you. I'm glad to see you all here from Let's Crush Medical Debt, and appreciative that you're concerned about patient access and expenses. Has your organization taken a position on Medicaid expansion in Texas?
Our organization has not.
You should look at it. Would love to have your advocacy around that important issue.
Thank you.
Thanks.
Representative Jones.
You guys specifically with Let's Crush Medical Debt are really in a unique and awesome position. As I was listening to you, let me make sure I get the right, in the dark suit, what's your name?
Rashid.
If I didn't support this bill, after you, I definitely would have supported this bill. I was
Appreciate it.
so excited at your enthusiasm. And it's just inspiring and motivating to see young people care about public health in Texas and to take a position and take your time and stay here all day so that your voices could be heard. Today's been a long day, right? I could use some adjective to describe it, but I won't. But you definitely made staying here this long absolutely worth staying if I didn't think so before that.
Thank you so much. I
thank
truly
you.
appreciate that.
And yeah, there's not a doubt in my mind that you're going to be a great doctor. Not a doubt in my mind.
Thank you.
And you're not going to overcharge your patients. Okay, all right.
Okay, any other questions for this panel? All right, thank you. Thank you for your testimony. Chair calls Rahi Mehta. Okay, show him registered for the bill but not testifying. Is there anyone else who wishes to testify on, for, or against House Bill 3708? Not. Chair recognizes Dr. Oliverson to close on the bill.
Thank you, Mr. Chairman and committee members, and thank you. Those students were very enthusiastic, and I really appreciate them. they really mean what they say they practice, what they preach. So just to review very quickly, all we're saying with this bill is if you're a hospital and you're a not-for-profit and you're required to provide charity care, you should screen everybody before you send them a bill to make sure that they see if they qualify. And more importantly, before you send them to a debt collector, you absolutely have to make sure that they qualify, and that if before you send out that first bill to them, that you've applied any charity discounts that they may be eligible for. And then on the back side of that, if a hospital wrongly denies charity care or applies the wrong discount, they would be required to refund overpayments and reimburse any reasonable costs that the patient had to incur in order to get that refund. And also notify the collection agency if it goes that far. So in closing, I just want to point out that 66% of all bankruptcy filings in the United States are due to medical debt. It is the leading cause of bankruptcies. And so we want to make sure the system's working as it should, and that's what I believe this bill does. And I ask for your favorable consideration, and I close.
Okay, thank you. Representative Jones.
I wish you'd have filed this bill before. I literally spent my entire retirement and my savings to save my son's foot because I did not have health insurance, and I wonder if I would have qualified for this charity care. But I do know that late in life I had to start over, all because my son broke his foot playing basketball, and then a staph infection took over, and it was terrible. So
I'm sorry.
That's all right. I'm still here.
I'm learning about this session myself, and so I feel like I want to do something about it. Now that I know about it, I know the situation, I feel like we have this opportunity to do something about it, so let's do it.
Two ladies back there with a baby. One of them is named Doug.
Okay.
You may want to call them before. Okay, yeah. So now you're two in the morning.
All right.
Okay. And I
Thank
close.
you.
Thank you, Chairman. Thank you, Vice Chair.
Chair withdraws committee substitute. If there is no objection, House Bill 3708 will be left pending. Is there objection? Chair hears none. House Bill 3708 is left pending. Okay, members, we have a couple of bills to vote out, and then we're going to move on our agenda. I apologize. I know you guys have been here all day, but we need to take care of business. Chair makes a motion to reconsider the manner in which House Bill 2188 was reported from committee. Is there objection? Chair hears none. Motion prevails. Chair lays out House Bill 2188 as pending business. Members, House Bill 2188 is Representative Howard's bill, which would direct the Health and Human Services Commission and the Board of Nursing to create an operational plan to transition the Certified Nurse Aide Certification Program from HHSC to Board of Nursing. Chair lays out a complete committee substitute. Is there objection to the adoption of the committee sub? Chair hears none. The substitute is adopted. Chair moves that House Bill 2188 as substituted, be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk will call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos. Busey. Collier.
Oh, yes.
Cunningham. Frank. Johnson.
Yes.
Jones.
Aye.
Olcott. Pearson. Schofield. Schaffner. Simmons. Wait, how many is that? Yeah. Yep.
There being 13 ayes, 0 nays, motion prevails. Chair lays out House Bill 2747 as pending business. Chair lays out a complete committee substitute. House Bill 2747 is Representative Frank's bill, which would require healthcare entities to give Office of Attorney General advance notice of mergers or acquisitions.
He can explain the committee.
The committee sub, I will let Chairman Frank explain
Yeah,
briefly?
Briefly?
Yes.
Yeah, thank you. It does a couple things. In listening to some of the feedback, we have increased the de minimis amount to 5 million, so people under 5 million in revenue don't have to report it upon material changes. If it helped to go to 10, if that would change your vote, then we can do that on the floor. Second, it clarifies real estate, and that only real estate sales or lease agreements subject to the notification. It specifies that one entity becoming an affiliate of another or the entity becomes under control. So it limits the real estate transactions to only control transactions. It further narrows, some people are concerned about the Office of Attorney General's ability to ask for more information. So it narrows their ability to collect it. They basically need to go through the governing body of the entity to get that information. And it also, lastly, deletes the sentence allowing the OAG to recover attorney's fees. And so we just try to listen to feedback. And so I think with that, it's just really important to get that information if we want to have an actual competitive market in healthcare.
All right. Is there objection to adoption of the committee sub? Chair hears none. Committee sub is adopted. Chair moves that House Bill 2747 as substituted be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk, call the roll.
Chairman Van Dever.
Aye.
Vice Chair Campos.
Aye.
Busey.
No.
Collier.
Nay.
Cunningham. Frank.
Aye.
Johnson.
No.
Jones.
Nay.
Olcott.
Aye.
Pearson.
Aye.
Schofield.
Aye.
Schaffner.
Aye.
Simmons.
Yeah.
So,
She didn't vote.
okay.
Or she was out.
She I don't think she wants to. Does she?
Okay. Good. We're on House Bill 2747. Did you want to cast a vote? Okay.
Okay, just 8-4.
There being 8 ayes, 4 nays, motion prevails.
Thank you, Chairman.
Chair lays out House Bill 4553. Chair recognizes Representative Ordaz to explain the bill.
Good evening, members. Chairman Van Dever, Vice Chair Campos. Members, thank you for allowing me to present this important piece of legislation. House Bill 4553 promotes the health and safety of mothers and babies across Texas by enhancing transparency of birth outcomes outside of hospital settings. Over the past decade, out-of-hospital births have increased by more than 60%, and the number of practicing midwives has grown by over 66%. As more Texas families are welcoming their babies into the world out of a hospital setting, it's critical that we support those choices with the same level of safety, transparency, and care we expect in every birth setting. Today, there is very, very, very little data available in Texas around the hospital of midwife births. Currently, licensed midwives only submit information for birth certificates through the Department of State Health Services Vital Statistics System. But if a complication occurs and a mother or baby is transferred to a hospital, that outcome is only recorded under hospital care. There's no system in place to trace that back to the original provider. This is creating a major gap and is leaving important information uncollected. In practice, this means that we can't fully see where things go right or where care may need improvement. That's not fair to families or to many midwives who are doing excellent work and following best practices every day. House Bill 4553 seeks to close that gap by asking licensed midwives to report basic outcomes data that aligns with what's already expected of hospitals. This small change would make a big difference in how we improve care for mothers and babies. I want to note that we are preparing a committee substitute from the feedback from TDLR. But at its core, House Bill 4553 is about trust. Families trust their providers at some of the most vulnerable moments of their lives. We owe it to them to ensure that trust is supported by clear information, high standards, and a system that works, no matter where they choose to give birth. Thank you again, members, for considering this important piece of legislation. Happy to take questions and reserve the opportunity to close.
Any members, any questions? Okay, we will reserve your right to close. We'll begin public testimony. Chair calls Christina Buchanan, Michelle Gold, Steve Euchre, and Charlotte Melder. Okay, I have Christina Buchanan. Show you testifying you are a certified nurse midwife, testifying on behalf of yourself for House Bill 4553. Is that correct?
That's correct.
Okay, thank you. Proceed.
Hi, my name is Christina Buchanan, and I am in support of Malik's Law. I became a nurse in 2011 and earned my master's degree to become a certified nurse midwife in 2016. I've worked as a labor and delivery nurse in 9 hospitals. I've held midwife privileges at Baylor University Medical Center and spent the last 9 years attending home births in the Rockwell area. While I'm not a licensed midwife, many of my colleagues who have a similar business model are. I believe data collection brings more awareness to the profession, provides guidance to the public to make informed choices about their birth, and it would improve midwifery practice and influence future policy to improve maternity care in Texas. Home birth midwives in Texas face almost no routine oversight. Unless a formal complaint is filed, which may take over a year to investigate, no one is looking at their policies, decisions, safety practices, or birth outcomes. In hospitals, poor outcomes are thoroughly reviewed across departments. They use systems like MIDAS to track incidents and near misses, allowing for continuous quality improvement. These data-driven reviews hold all providers accountable and drive safety reforms. Malik's Law proposes a similar approach for community-based midwifery, requiring the reporting of outcomes like hemorrhage, uterine rupture, transports, and mortality. Right now, if a baby dies after a hospital transfer, it will become hospital data without much context. Malik's Law would provide a more complete picture of care. I believe that implementation of this law will give us evidence that many patterns and processes of licensed midwives are working, while shedding light on areas for improvement. But it's been hard to identify the outliers without the data. While uncommon, I personally have witnessed midwifery mismanagement and patient harm due to insufficient skills in neonatal resuscitation, IV suturing, and risk assessment. Some don't follow evidence-based practices like offering GBS antibiotics. The midwife community is conflicted between calling out the unsafe practices of certain midwives while balancing the professional and personal ties amongst each other and protecting the public image of midwifery. It's a real dilemma.
Thank you for your testimony. Michelle Gold,
Yes, sir.
have you registered as testifying as a licensed midwife on behalf of the Association of Texas Midwives and yourself, testifying against House Bill 4553. Is that correct?
Yes, sir, that's correct.
Thank you. Proceed.
Mr. Chair, Madam Vice Chair, members of the committee, my name is Michelle Gold. I'm a licensed midwife here in the state of Texas. I'm testifying in opposition to House Bill 4553. Thank you for letting me testify. I wish it was under different circumstances that I was here. I want to make this pretty quick because I know we're all here for a long time. I would like to just speak about one part of the bill, and that's the bill's redundant reporting requirements. On the surface, HB 4553 looks like an innocuous statistics bill by requiring reporting statistics to be collected by both TDLR and the Department of State and Health Services. Currently, the Vital Statistics already collects these statistics mentioned in the bill through the filing of birth certificates. To have 2 state agencies develop an already established stats collection process is redundant and creates unnecessary regulatory burden. Birth certificate data is available through a FOIA request and is accessible to anyone. The bill also asks that TDLR oversee the statistics collection from doctors and hospitals, which they do not oversee. Likewise, no other healthcare professional who delivers babies is legally required to provide these redundant stats to a state agency. Supporters of this bill contend additional data will foster relationships with other providers, but tracking statistics is not how relationships within the greater birth community are built. These relationships are built through respectful interaction acceptance of the role that every provider plays within the framework of perinatal care, and good old-fashioned handshakes. It is difficult to legislate how relationships are built. For many Texans, midwifery is their only access to consistent prenatal care, especially in our rural and underserved communities. Almost 50% of Texas counties are considered a medical care desert. Licensed midwives are not a threat to public health. We are part of the solution. Midwifery care in Texas is safe, it is regulated, it is saving lives and supporting families every single day. This bill, unfortunately, would not increase safety. It would increase fear, bureaucracy,
Thank
and
you.
stigma around our profession. Thank you.
Thank you for your testimony. Members, questions of this panel? Okay. I would encourage you to get with the bill author to talk about some of the issues you have.
Yep.
Representative Pearson.
Thank you, Chairman. For, the names went away. Christina.
Yes.
What is the difference between the certified nurse midwife versus the licensed midwives?
It's an important distinction to make. The scope of practice, what they're able to do, their education, their training programs to get that education, and their licensing board, as well as their regulatory board, are completely different. So of course there's overlap. We're all called midwives, but a licensed midwife has a lot of variance in how they can become a midwife, including a portfolio evaluation process, which is an apprenticeship process, which includes self-study followed by one test at the very end. So a midwife can become a midwife by doing complete self-study, checking off all of her skills that are required, getting all of her hours, doing all of the deliveries, having it all signed off, and then one test to become certified. That certification is then showed to the state to become licensed. Another way to become a licensed midwife is going through an Association of Texas Midwives program that has modules, many modules on antepartum, intrapartum, postpartum, things like that. It's around like $11,000 to $14,000 is the last I heard, and it will take about 2 years. And there's tests, papers, quizzes, presentations, skills, competency checkoffs, things like that. Again, they go through the program and then they take the same test that the portfolio evaluation process would do, and then they can become a certified professional midwife. There's also schools of midwifery. They're not as common, and it's not an accredited university. There's no, I don't want to misspeak, but it's not a university level education, like a bachelor's, graduate, or doctorate degree. So that's a certified professional midwife, also known as a licensed midwife. There's some variations in why we call one CPM. A CPM is a national certification, and then different states will either license based on holding that certification or not. In Texas, you can get the certified professional midwife certification and then let that lapse after you get your licensed midwife, and then just hold your licensed midwife license. So that's this category over here. A nurse midwife, conversely, is an advanced practice registered nurse who has been to a school to get their bachelor's degree and then a master's or a doctorate degree. Their scope of practice involves prescribing capabilities delegated from a physician. They also can do well woman care start to finish, from menarche to menopause. They can do birth control, IUDs, sinus infection treatments, UTI prescriptions, things like that. So their scope of practice is very different. Their education is very different. And part of why I'm in support of this bill is because the variance to become a CPM is so wide. And then Texas actually gives them a very wide, it gives them a lot of leeway compared to other states as to the types of patients that they can take on. And I think that adds to the risk of I think it adds to why we need to be looking at their data.
And then you'd mentioned something about Midas. Is that the system that she's saying might be redundant, or what is tell us what the Midas system is that the hospitals use to collect data.
Yes, so Midas is something, I don't know if it's in every single hospital system, but I've worked and walked and been in 11 different hospitals between my training and my nursing background. Midas stands for Misoperation Information Data Analysis System, and it's a portal when something goes wrong in a hospital, whether it's a equipment failure or a near miss. It doesn't even have to go wrong. It could have gone wrong. medication errors, if a patient falls, any incident like that, safety events, Midas is where that's all tracked. So anyone involved in that problem needs to go and report it into the Midas system. And without, it's obvious that that system would then put out quality improvements. It would do trend analysis. It would identify like streamlining provider performance reviews. And it would just overall give you a plan of like what's working and what's not working. So the hospital systems have things like that. The state even goes into birth centers and inspects birth centers, and there are standards in birth centers, but home birth midwives have very little oversight.
And then for Ms. Gold, are you saying that you also report all of these things as well?
So we don't report to the Midas system because that's within the hospitals. What they are asking for in this bill is for reporting of outcomes that we already do when we file a birth certificate. So all that's with the vital statistics already.
But it
for most
includes all of
stuff.
the things that she listed?
What did you list like complications? What the
Like-
bill is requiring is most of the stuff that's already being filed with the birth certificate.
But not what's included in the Midas, what they have to report
As
to
far as like the
hospitals.
plan, well, that's what TDLR is for. And so when there is a complaint made, there is an investigation process, and that's when like a plan of care or, penalties or sanctions, or if somebody needs to be re-educated, that's where all that would be done.
And so do you, are you currently now required to report death or near misses?
If in the birth certificate, it depends on where it's being filed. So if like.
I don't understand that. It's yes or no.
Yeah, so for birth certificates, when we fill out those reports and when we file them, in the event of like a near miss, like you were saying with a newborn, we would file that if the birth happened at home or at the birth center, we would file that birth certificate. But if there was a transport and then there was a maternal death or near miss before the baby's out, that would be filed with the hospital.
Okay, and you're
That birth
opposed to the
certificate.
bill, and how does this bill hurt you?
Yeah, so we feel like the language is not very clear, that there's a lot of room for error for both the midwife reporting the outcomes, the hospitals reporting the outcomes, as well as through TDLR and dishes. Basically, like an example of that would be part of the bill is the requirement to report within 10 days of the birth or of the outcome. Sometimes in the event of a transport, we actually don't know the outcome depending on the midwife and what part of the state of Texas she's in, because she might not get records from the hospital. They might not release those records to her. And so she might not know what the outcome is on the other side, depending on her relationship with that hospital, how long she stayed. And so if she were to go over that 10 days, that's when she would be fined and be in violation. There's nothing in the bill that talks about what the hospitals need to do if the hospitals need to report within that same time frame. They do want the hospitals to report to TDLR, and they want there to be a cross-check in the event of a maternal transport to the hospital. They want TDLR to cross-check the hospital report with the midwife submitted report. And then if there's a violation, then the midwife would be fined or violated. Again, it's not very clear what the hospital side of things is needed. And then the other thing is just creating these new programs, because they also want dishes to also be involved in TDLR to also create this program. It's just very redundant to have all of these different systems that we would be reporting to. And then they also want them to do random audits and then the cross-checking that I just mentioned, which would create just a lot of, would just need a lot of manpower and budgeting to create those systems and to maintain them.
So when you're with a mother who gives birth and the baby dies, you report that every single time?
Yeah, it depends, yes.
Depends on?
Well, it depends on like where the baby was delivered.
Explain that.
I might have to go and actually talk with my colleagues about that and look up. I don't know how to really clarify that
So
for you. But
we don't know, as of right now, you may or may not be reporting if a baby dies.
I don't know the answer to that.
Okay.
Well, we'll get back to you on that.
Okay, thank you. And then, are there unlicensed midwives practicing also as well?
Yes, but that is in violation of the TDLR penalties. It's, I believe, like Class E. And so somebody gets fined for practicing without a license.
Okay, thank you.
Yes, you're welcome.
Representative Jones.
Just want to be clear, you don't know if you report a baby dying?
So this is with the birth certificate filing system. It just depends on where the baby gives birth or where the mother gives birth. So if she gives birth en route to the hospital, that birth certificate, and then I'm assuming the death certificate would be filed by the hospital. But I think I would just need to go back and look at the actual, system for that to make sure, to clarify, to give you an actual answer.
Are you necessarily presuming that a birth certificate equals a death certificate? I mean, my specific question was, you don't know, again.
Right,
So
so in the
you're
birth-
not, hold
Sorry.
on, please, thank you.
Of course.
So you don't know whether you report a baby dying?
No, I misspoke. In the birth certificate, there is a part where it says, is infant living at time of report? So when we're filling out that birth certificate, there is a box to check for that, to say, yes, baby's living at the time of this report, or no, baby's not living at the time of report. And then it also asks us if baby was transferred, where was baby transferred to? So that is also being filed with the birth certificate.
So I guess my question is, what was confusing about the question that Rep. Pearson asked?
Well, it depends on if we're the ones filing the birth certificate. That's the issue. So if we transported a mother in labor and the birth happens at the hospital, we're not the ones filing the birth certificate. The hospital now files that birth certificate.
So would there be an instance where, I guess a woman is in labor and you guys help, and then the baby gets transferred? No one would ever know what you did with the baby before the baby got transferred?
No, we would fill out a birth certificate if we helped with the birth. And then we had to transport baby, we would have to fill out that birth certificate and fill out all those same complications and outcomes, including was the baby transferred, and then put down where the baby was transferred to.
Is there a situation where you would help with delivery or help during labor, for lack of a better word, and the baby is transferred and you don't do anything?
No, we would
Like
file
after, like after that?
Well, we would file the birth certificate and we usually accompany the family to the hospital. Is that what you're?
I mean, I don't know what I'm asking. I mean,
Okay.
because I'm just confused about. I'm just confused about how you wouldn't know something. So what I guess
No,
what I'm trying to figure out is, if something happens and you transfer the baby to the hospital, you're saying to me that you would have gone to the hospital with the baby because you were helping during labor. Is that accurate?
We go as support, but if the baby is born and we transfer, when we file the birth certificate, is the baby living at time of report? And if we transported that baby and we're filling out that birth certificate and that baby is still living, then we check that box. If something happened and that baby is no longer living, then we would check the no box.
So no matter what, you're going to report what you do?
Yes.
Is that accurate?
Yes. Yes, ma'am.
So I guess therein lies my confusion. I'm just trying to figure out why you had a question
I
about
think I
what
just got confused, to be honest.
Okay,
by the whole process.
Okay, thank you.
Members? All right, thank you for your testimony.
You're welcome.
Okay, we had called Steve Euchre. We'll show Steve Euchre, registered neutral, not testifying. Charlotte Melder. We will show Charlotte Melder, registered neutral, not testifying. Okay. The two ladies with the babies, would you guys come forward, please?
They really hung in here.
First of all, let me commend you on your parenting skills. This is amazing. I raised two, and I would not have dared been in this room all day with either of them.
We didn't know. We might have not been so crazy if we had known.
Okay, can you give me your names?
Yes, I'm Kristen Dudley. I'm here with the Association of Texas Midwives and representing myself.
Okay. And your name?
Lisa Brewer, testifying as a mother on
Okay.
midwives.
Yeah, that's fine. Let's do Kristen Dudley first. Yeah, Kristen Dudley.
Okay, Kristen Dudley, I show you registered testifying as a licensed midwife on behalf of the Association of Texas Midwives and yourself, and you're testifying against House Bill 4553. Is that correct?
That is correct.
Thank you.
Yes.
You may proceed.
Thank you so much, Mr. Chair, Madam Vice Chair, and members of the committee. Thank you for having us so late tonight. And as he stated, I'm testifying in opposition to this bill. My aim of my testimony is simply to describe what daily life in the life of a midwife might be, because I know it might be a little confusing. So I'm just going to do that. I'm a licensed midwife here, and I serve families across Texas with safe, intentional home birth care. And a day in my life might start before sunrise, if I'm working, reviewing charts and lab results for clients, patients due any day now. I would check vitals, review fetal positioning, ensure every family has an individualized care plan that aligns with the informed choices they have made to use my services and evidence-based safety standards. I attend prenatal visits in the homes of my patients or in my office, spending an hour or more with each family to assess physical health, but also to build trust. I'm on call for the patients I've agreed to care for 24/7. When labor begins, I arrive with a skilled team of multiple midwives, life-saving equipment, and years of training to monitor both mother and baby throughout the process. As midwives, we are trained to recognize when a transport is necessary, and when it is, we communicate clearly with EMS and hospital staff. For us, transporting to the hospital is not a failure, it is a clinical decision rooted in safety. Yet, under HB 4553, outcomes that occur in the hospital under a physician's care could still be attributed to me as the midwife, as if I were responsible for decisions I did not make. Hospital and midwifery systems both suffer when collaboration is replaced with policing, which is exactly what would result if this bill moves forward. Additionally, I attend midwife meetings, regular peer reviews, and continuing education, and meetings with my local hospital to help me be the best midwife I know I can be. This bill burdens us with duplicative reporting and hostile oversight and ignoring systems already in place. Thank you so much.
Thank you. I show you listed as Lisa Brewer, testifying on behalf of yourself, and you are against House Bill 4553. Is that correct?
Correct.
Thank you. You may proceed.
Thank you. Chairman Van Dever, Vice Chair Campos, and members of the committee, thank you for letting me testify. I'm testifying in opposition to HB 4553. As a mother of 3 in Texas, all of whom were born at home, and a healthcare consumer, I have experienced firsthand the value of midwifery care. I chose midwifery care because I wanted a home birth with the expertise that prioritized informed consent, personalized support, and holistic care. My midwives respected my autonomy, educated me on my options, and provided medical expertise with compassion. That kind of care is not just comforting. It is evidence-based and safe, and it is something that every family should have access to. All of the 7 midwives I have worked with have clearly explained their scope of practice and my rights as a client. HB 4553 threatens that access by creating unnecessary barriers for midwives and families who rely on them. This bill does not improve safety. Instead, it undermines the professional judgment of midwives, increases costs, and limits choices. Families in rural and underserved areas in particular will suffer if we lose access to out-of-hospital birth options. Our system works, and Texas families trust it. That is why so many are choosing it. It's on the rise, 60%, is that what they said? I urge you to listen to the voices of those of us who have benefited from this care. Please do not pass HB 4553. Stand with the families of Texas who deserve the right to choose the birth experience that works best for them. Thank you.
Thank you. And again, I would encourage you to work with the bill author. I know her desire is to pass a good bill and not do anything that would be harmful to the process. And so I know she would welcome your feedback on the bill. Members, any questions? Representative Schofield.
I have to say you two are a great advertisement for midwifery. I think some of the prospective mothers out there are thinking, if I let her deliver my baby, is it gonna be as quiet and well-behaved as these two? So,
I think the answer to that is yes. They really ensure that you have a good handle on breastfeeding before they leave, which is care that is above and beyond. They talk to you about holding your baby and baby wearing, which all lead to happy babies. So
and I
they
would,
really are good about, postpartum depression. So I think yes.
I would definitely echo what the chairman said. I would work with the author and try to, and this is clearly supposed to be a informational, let's make sure we have all the data bill. And I don't think that she intended it as an attack on y'all. And so I've worked with her all the time, and occasionally she destroys one of my bills, but by and large, we work together great. So, but thank you all for coming. I'm sorry it took this long, but thank you for staying the course. And hi, Leaf.
Thank you for having us and welcoming our children.
Yes, thank you. And there are some other children in the back, not as young, but there are some other children back there.
Would be happy to go ahead and take the folks with the children so you can go home before midnight. Barely. So do we have others here to testify that have children with them?
They're going to sit and watch the whole thing anyway. Thank you, though.
Okay. Okay, Chair calls Sabrina Elliott, Sarah Slett, Elizabeth Winfrey Keeling, and Amanda Calicut. Okay, it shows Sabrina Elliott testifying as a midwife on behalf of the Texas Association of Texas Midwives and Self, testifying against House Bill 4553. Is that correct?
Yes.
Okay, proceed.
Hello, my name is Sabrina Elliott. I'm a midwife that lives in Fort Worth, Texas. It's good that we're used to staying up late. Usually it's for births, but today I'll be here testifying in opposition to HB 4553. One of the most concerning aspects of this bill is its reliance on language, definitions, and standards of care drawn from the organizations like ACOG, the CDC, and American Academy of Pediatrics. Groups that do not govern, license, or regulate Texas midwives and whose standards are not written with community birth or with midwifery in mind. Midwives are not physicians. We do not practice medicine. We are licensed to provide skilled, evidence-based care for healthy mothers and babies within a clearly defined scope that is set by TDLR. The majority of midwives and consumers do not want this vision for midwifery. For example, one of those such groups is the International Confederation of Midwives, which is ICM. It has clear requirements that a midwife should provide abortion care, a position that does not align with our scope of practice, the ethical standards of Texas midwifery, or the desires of the Texas legislature. The ICM guidelines state that a woman who seeks or requires abortion-related services is entitled to be provided with such services by midwives. I urge you to oppose HB 4553 and to stand with Texas families in protecting safe, informed, and respectful midwifery care. Thank you for your time and your dedication to public health.
Thank you. Chair recognizes Sarah Slett, President, testifying on behalf of the Association of Texas Midwives and Self against House Bill 4553. Is that correct?
Yes.
Thank you. Proceed.
Mr. Chair, Vice Chair, members of the committee, thank you for letting me testify. My name is Sarah Sletty, and I am a licensed midwife and president of the Association of Texas Midwives. I am here today to speak in opposition of HB 4553. I would like to speak about how the bill applies inappropriate standards to the practice of midwifery. Section 203.352, number 3 of the bill attempts to redefine the scope of practice of midwives, including which procedures they are allowed or prohibited from performing. The Texas legislature and TDLR rules include comprehensive list of standard of cares, protocols that midwives must follow. These rules specifically outline health conditions and emergency situations that would require transfer to an OB or a hospital. HB 4553 attempts to take away the power from legislature and the licensing agency to determine those guidelines and instead uses outside governing bodies such as the International Confederation of Midwives, an organization that states midwives should provide abortion care. That is also included in your packet. ACOG, which governs obstetrics and would make midwives subject to the standard of care of OBs. Midwives do not practice medicine, and it would be inappropriate for midwives to be held to the same standards as doctors. Midwifery care is appropriate for healthy, low-risk moms and babies. It is not appropriate for higher-risk moms or babies. Changing our standards and guidelines to those of ACOG would blur the line between midwifery and obstetrics and create gray areas of confusion. We strongly believe that midwifery practice standards for Texas midwives should be determined by the Texas legislature and TDLR. Texas was the first state in the nation to create midwifery laws, and we think regulation of the profession should remain with Texas leaders and not be outsourced to national and international groups that think abortion is appropriate midwifery care. This legislation does not respect the integrity of the Texas midwifery model or trust families to choose their providers and their birth settings. Thank you very much.
Thank you for your testimony. Chair recognizes Elizabeth Winfrey Keeling, testifying on behalf of yourself for House Bill 4553. Is that correct?
Yes, sir.
Thank you. Proceed.
Thank you, Mr. Chairman and committee members, for allowing me to speak with you today. My name is Elizabeth Winfrey Keeling. I have been a Rusk County resident for 20 years and currently reside in Cherokee County. I'm here in support of Malik's Law. My first 3 children were born in a hospital, and my last 3 were planned home births. When I made this switch, I researched everything home birth. I was unable to find transfer and birth outcome rates. I was reassured that those numbers weren't there because home births don't normally have bad outcomes, and when they do, they are caused by issues that would have been unpreventable in the hospital. The horrific stories told by medical staff were dismissed as being medically biased and bullying against the home birth community. It wasn't until the birth of my 6th child, Emery, did I realize those horror stories were actually true. Emery was born bubbling from the nose and the mouth. 15 minutes after her birth, she turned purple. We were told she was fine and that this was how some babies transition. She fought for almost 30 minutes before her body gave up and started shutting down. Only then were emergency protocols started. When Emery arrived at the hospital, medical staff flooded the halls in the ER room. We all watched in horror as NICU nurses tried to save her lifeless body. She was so far gone, they were unable to read her vitals. Later, the midwife admitted to not repacking the deep suction tubes in her bag and then placed sole blame on my husband and EMTs. While filing the complaint, I realized that our transfer record stated the forgotten tube had been used. Emery was diagnosed with hypoxic ischemic encephalopathy, lack of oxygen to the brain. HIE has a 40% survival rate. Multiple published studies conclude children with HIE were sometimes up to 21% more likely to have been born at a planned home birth. Without Malik's bill, home birth outcomes like Emery's will continue to go undocumented.
Thank you for your testimony.
Yes, sir.
Chair recognizes Amanda Calicut, testifying on behalf of Moms Advocating for Moms Alliance and self for House Bill 4553. Is that correct?
That is correct.
Thank you.
Good morning, committee members. My name is Amanda Calicut, and I represent Moms Advocating for Moms Alliance. When I began researching out of hospital birth in 2022, I didn't realize at the time how much of the data I was seeing came from other countries. These stats can be misleading because midwifery education and standard of care in Texas are vastly different from other countries. Texas has some of the highest maternal and infant mortality and morbidity rates in this country. Many licensed midwives share stats from other countries, creating a false sense of safety about out-of-hospital birth in Texas. The truth is, we don't know how safe it is because the data does not exist. This bill would give families access to reliable state-specific data to make informed decisions about their care. Right now, families can find hospital-related statistics, but there is no transparency for community birth. Licensed midwives champion informed consent, but oppose the very transparency this bill would provide. Association of Texas Midwives highly recommends data collection to further midwifery in Texas according to their standards for midwifery practice, yet they now sit here and oppose this bill. Since at least 2016, the association has not filed any legislation to improve midwifery in Texas, not for families, not for midwives. In July of 23, I labored for 60 hours. My water artificially ruptured for 30+ hours, meconium present for nearly 24 of those hours. I was dilated to 10 centimeters for more than 12 hours. When I got to the hospital, I was septic, severely dehydrated, diagnosed with an infection of my placenta and shoulder dystocia. All of this was reported by the hospital, and none of this was reported by midwives. My midwives told me that everything was normal and delayed the care we needed. We trusted that they would keep us safe, and we were put in a very compromising situation. I urge you to pass Malik's Law so that we can make truly informed decisions for our families. I'd also like to take a moment to acknowledge the life of a perfect baby boy, Wyatt Phillips, who was healthy until February 21st, 23, when he was born and lost his life to preventable causes. His case is still pending with TDLR, and midwife is still practicing today.
Okay, thank you. I guess my question to Ms. Winfrey Keeling,
Yes, sir.
and really both of you, I guess, would your outcomes have been any, in your opinion, would your outcomes have been any different had this bill been in place? Do you think?
Yes, I would not have chosen to birth with licensed midwives in Texas, likely because the statistics would have shown me that it may not be safe. I am pregnant with my second child, and I will be using certified nurse midwives in the hospital. So I do advocate for midwifery care. I just want it to be safe, and I want people to have data to support midwifery, safe or not.
Okay. Would your testimony be any different?
Would my outcome have been any different if this bill was in place? No, because aspiration can happen in the hospital as well. But considering how much I researched home birth before I chose it, moms research everything. We research the kind of shoes we put on their feet, what we feed them, what kind of car seat we put them in. I did my research, and this information was not available to me.
Okay, thank you. Members, any other questions? Representative Pearson.
Thank you, Chairman. For the midwives, I'm having a really hard time of trying to understand why we wouldn't want to have these things reported. I still don't have a clear idea of what the duplications are, so I'm going to ask both of you, do you report every single death?
So yes, we do. So what I think the previous midwife was trying to explain is that depending on the circumstance, if an emergency situation is occurring, the midwife should be transferring that mom and baby to the hospital. And so if that baby dies at the hospital after we have initiated transport, then the hospital would be filing that birth certificate, which means the hospital would be filing the death. If that death occurred during a home birth, that would of course get filed during the birth certificate process. Coroner would also be called to the home.
So your testimony basically is everything that needs to be reported is reported through the birth certificate process.
Yes.
That includes the transfer, the complications, who was or was not a participating midwife. There could be two, right? Are both names included in this report? And where does that get reported to?
So we report that with the vital statistics and when we file the birth certificate. Again, if the baby is born at the hospital during a normal transport, should something be an emergency or the mother herself determine that she wants to go to the hospital for a variety of reasons, and a poor outcome happens at the hospital, that would be reported through the hospital. They would do that when they filed the birth certificate. Anything that happened prior to going to the hospital, the midwife is responsible for filing when she files the birth certificate with vital statistics.
Okay, so just focusing at home, so you're saying that, whether it's sepsis or shoulder issues.
Yes.
All of these things are reported.
Hemorrhage, VBAC, how many VBACs? Yes.
And these are reported all the time.
Yes.
So we should be able to go and pull this data to find this information.
Yes, you can request it. And I can also send y'all an information of like what we fill out and the hospital fills out. It's the exact same form. We both have to fill it out. The birth certificate sheet, worksheet.
And then for
Do you want to add
Calicut?
anything separate?
Yeah, if I could.
What's going on with your case and TDLR? You said you have a case. There's been a complaint.
So the case that I spoke about was a boy who passed away in Georgetown, Texas.
Okay.
His case has been open for over 2 years, and there is no resolution, and that midwife is still practicing today.
What is midwives? What is the typical process when a complaint is made?
So a complaint is made with TDLR. They're going to file a complaint. They're going to fill out all the necessary paperwork, and then TDLR is going to reach out to that mother or to that client or the person filing the complaint, and they're going to start that process. I cannot speak to details because I am not a part of TDLR, and I don't fully know the process because it's not done in a public situation.
Okay, but you are a midwife, correct?
Yes.
So if someone filed a complaint against you, how does that work?
Okay, I've never had a complaint filed against me. Okay.
I have one because of this group, so that's why I can answer.
Okay,
this.
how does that work, please?
So what happens is, once they file a complaint, then there's an investigator that goes around and tries to gather all the information that they can to then present to a prosecutor. So they will ask the midwife to review the chart and then to also make a statement of everything that they can remember about that event. So most of the time, we're taught that if it's not charted, it didn't happen. So we try to stick to the facts that are in the chart. But if there's little things that we remember, we try to add them in. It then is supposed to be brought to the prosecutor. Currently, the one that was brought on me it's supposed to be done within 2 years. It was done took over the 2 years, so they did it at 3 years. And it was last June that I was notified, and I still have not been cleared of that. And it's not because there's anything more to do, it's just sitting on a prosecutor's desk. So that is part of the problem, which isn't necessarily ours. I understand that it's frustrating. It's frustrating for all involved, but that is part of the process.
Okay, thank you.
So whether that means it's something that was simple that could be cleared up, or whether it was a problem, is kind of part of the issue.
Did you want to add to that?
Can I just say that she said that Mama was the reason that she has a complaint, but Mama wasn't formed until November of 2024, and her complaint is now 3 years old, is what you said?
No, it didn't come in until June. This past June.
We weren't even formed in June, so I don't, that's
It seems to me
inappropriate.
that if you guys are reporting the information that this bill is requesting, you guys are searching for it and can't find it. It sounds like there is a breakdown somewhere. If the data is being reported but it's unsearchable, then maybe that is the fix. I don't know.
I would like to add a little bit of input to this. So if a mom, in my case, I was transferred to the hospital in the 53rd hour of labor. My midwife did not report any part of my whole labor delivery experience. The hospital reported that. So nothing is tied back to the birth center or the midwives that I was in care with for the whole 53 hours of labor, and the hospital reported everything else. That's where the disconnect is, because there was no reporting done by midwives, and so it would not be available to the public because no one reported it. They didn't fill out a birth certificate because my baby wasn't born with them.
Right.
There's not going to be two birth certificate forms.
So let me ask the midwives, in a case like that where you do perform the services to the mother and the baby, and then the mother is transported pre-birth, and the baby is delivered at the hospital. You said that then the hospital will file the birth certificate and report the data. So do you guys report anything on
Once
that?
we make that transfer, if the baby is born in the hospital, it is up to the hospital and the staff to report that information on for vital statistics. Now, our job is to take care of low-risk mommies. We are continually assessing that situation throughout the entire labor and birth process. Should that change, our job is to transfer the mom according to our rules and our scope. That is our job. That is how we keep midwifery safe. I can't sit up here and talk for every single midwife and their personal midwives. The midwives that we are talking about today are associated with a birth center that is no longer in practice. They closed both of their locations. They are no longer practicing. They're no longer practicing. So I just want to reiterate that midwives take care of low-risk moms and babies. It is our job to continually assess and then transfer as needed.
And I support what, hang on just a minute, I want to finish up
Okay.
one last question. I support what you guys are doing. I support the whole concept of midwives. I guess my question is, and I get that you guys are taking care of low-risk births.
Right.
But we know that sometimes surprises happen, things happen, and what we thought was going to be a low-risk birth becomes a high risk, and they have to be transported. Is it not fair for you to think that you guys have information that would be very helpful to this whole story
Right.
if you reported what you knew happened prior to the mother and child being transported?
So when I transfer a client, I am transferring to the hospital. I've contacted the hospital, and I have already faxed records before me and my client get there together. That is what I do. So when my providers that I have transferred it to in the hospital, the CNMs or the OB, they're going to have my records in hand by the time we arrive. And I mean, that's how I personally practice. And the midwives that I know are going to practice the exact same way.
Okay,
Go ahead.
I know Representative Johnson had.
Let's stay focused on the bill.
Yes. Okay.
And the bill is about reporting. From what it sounds like good outcomes get associated with the midwives. When things go south, the bad outcome gets associated with the hospital.
I mean,
That is correct.
Okay.
well, even when poor outcomes are happening before we transfer to the hospital, we have to.
But the hospital is taking the hit. The hospital is reporting the negative outcome. They don't throw you under the bus and say this was transferred me by a midwife. That's what it sounds like. So it sounds like your practice is created as a perception of being only positive because you don't have an obligation to report the negative, and I think that's the point of the bill.
There are negative aspects that's happened, and this is clear today. You know, I'm not sitting here
I'm
saying.
asking about the reporting.
Okay.
Because we've all done this and we've all asked you all the same question. How
There
are you
are poor
reporting it? And you're
outcomes
saying a
that
birth
happen.
certificate or a death certificate. And the death certificates are being done by the hospital, right?
Not necessarily.
Are you reporting deaths that happen in your midwife shop?
Yes.
Because Representative Jones asked that question to somebody earlier.
I
We couldn't get a
understand she
straight
did.
answer.
When the death occurs, before we transfer to the hospital, when it is in the midwife's care, we have to report that
And who do you
information.
report it to? The Bureau of Vital Statistics?
Yes.
Is there any reporting that shows your practice and how often you have a death in home or how often you transfer to a hospital as a profession? If the answer is no, that's just all we need to know.
It's
Is the
with
answer
vital
no?
statistics. Every transport we have is
Is
going
there
to be.
any way for a consumer to look up? Is there
They can
any
ask
way?
vital
Do they dig through vital
statistics.
statistics? Is there any way for a consumer of your and aren't y'all paid by insurance?
No, not always. No.
Not always. Well, don't say no and not always. We're
Okay.
trying. I need really honest answers. Are you paid by insurance or not?
Most licensed midwives are not covered under insurance. No.
Are you covered by some insurance?
It just depends. So, like some birth centers are covered by by insurance. It's just going to depend. It depends on if you have a shared insurance. Then sometimes that is covered with home birth. Most of the time, it's not going to be covered. And then it also depends on whether it's a licensed midwife-owned birth center or a C&M ran birth center. C&M ran birth centers are more likely to be covered under insurance.
Do you carry malpractice insurance
No,
for the
we do
deaths of
not.
these children?
No.
So when a baby dies in your custody, that's it? Nothing happens? There's no accountability?
You would file a complaint with the TDLR if you feel like something has been done in error.
And that's the only consequence, is a complaint with TDLR? No lawsuit, no medical liability?
That would be up to the family on whether they would want to hire an attorney.
And you
then-
asked about criminal, so you've got criminal charges potentially pending against you. Because you said statute of limitations is over 3 years, which means it's a
No, I
felony
do not have
offense.
criminal charges against me. I have
You said a DA
complaint.
is reviewing it.
No, there's a prosecutor with the TDLR. They
Okay.
have their own prosecutor. It's a complaint. So actually, it's not even something that I necessarily did wrong. It's not specifically against me. It's that there was a problem with this birth center, that they were filing a complaint against everyone that touched this woman because of a Medicaid fraud complaint.
So insurance.
Well, it was
Okay,
like
just
we've
checking.
already said, it's this one birth center that has kind of caused a lot of the issues.
I have to say, I think the reason I'm getting so hot is it's not normal to talk about babies dying and just dying. It
Actually
just does.
happens a lot in the hospital. I'm not trying to say that it's fun for anybody. We really hate it for everybody. It is not. It is a very sad event in any place that it takes place. It rarely does happen in any kind of midwifery care moment because of the normal.
And a death in a hospital would also be subject to medical malpractice and a lawsuit.
If somebody
and insurance.
had malpractice insurance and took insurance,
Everybody
yes,
in
which
a
they do.
hospital is going to have medical malpractice
Right.
insurance, and they're going to have the law to protect them if there is medical complications where you didn't follow a reasonable standard of care. I think that's what we're asking. I can't even figure out what your reasonable standard of care is, or where it gets reported, or how a consumer would know.
To TDLR. TDLR actually is our governing body. They actually provide all of the regulations for what we can and cannot take. They tell us specifically what has to be referred out, what has to be transferred. They have rules. We also have to set our own policies and procedures and protocols on top of their own regulations. And so anytime there's a complaint, every time we take someone into care, we have to sit down and, not like a doctor hands you a piece of paper and says, can you sign this? We have to sit down and explain to them what the risks, what the benefits are, whether or not, ask them all the different risks. And we have to tell them how to turn us in. We have to tell them that we don't have malpractice insurance. They have to sign understanding that we don't have it.
And they trust you.
Yes.
Okay. Thank you.
I just want to add.
I'm not asking another question.
Okay, thank you. Thank you for your time.
Okay, thank you. Were there any other questions? Okay. Before we take this question, I need to announce that it is now 12:07. We are in a new day, and so the House Committee on Public Health is continuing the meeting in the new day. So I need to get that on the record. Okay, Representative Schaffner.
What would you like to add?
I was going to add that we, upon taking a client into our care, we have to have them sign an informed consent that is put out by TDLR. It's one of our rules. We have to go over that line by line, and they do have to initial that we can collect blood for labs and that we do not have malpractice insurance. And we also have to do that when we have a student, so that the client fully understands that the student has to be fully supervised and be present for all clinical aspects. They have to sign both of those forms.
Thank you very much. We appreciate you all. Thank you for staying for, I don't know, are we way past 12 hours, 14 hours? Thank you for your patience with us too. Thank you.
Thank you.
Can I clarify, there was something
Very,
said.
very quickly, it's late.
It was said that we were part of MAMA. I'm here independently.
Okay.
My birth didn't happen at the same, used a completely different midwife.
Okay.
I do have a TDLR complaint I did file one and it was closed.
Okay, thank you for that clarification. Thank you all for your testimony. Chair calls Kristen Cook, Marquita Cummings, Caden Lopez, Kristen Bowers. Okay, have Kristen Cook registered to testify on behalf of Moms Advocating for Moms Alliance and self for House Bill 4553. Is that correct?
Yes.
Thank you. You may proceed.
Hi there, committee. It's a late night. Thank you for your time. My name is Kristen, co-founder of Moms Advocating for Moms Alliance and a resident of Rockwall County. Thank you for allowing me to speak in support of Malik's Law, HB 4553. In 2022, I chose a birth center after being assured it was as safe as a hospital. During my pregnancy, I showed clear signs of preeclampsia, placental abruption, IUGR, and breech presentation, all high-risk conditions. After 15 hours of labor at home with ruptured membranes, I was sent to an OBGYN office, not a hospital, delaying critical care. I arrived with a prolapsed cord, a true medical emergency. Undergoing an emergency C-section under general anesthesia, I suffered a hyperintensive crisis, an infection, was placed on a ventilator in neurological ICU, and my son was rushed to a high-level NICU. I was sure my son was going to die. I later learned one of my primary midwives was an unlicensed student and that the birth center had a history of poor outcomes. This devastated my family. When I reported my case to TDLR citing criminal acts, I was told they don't report criminal activity. When I questioned the lack of expert review for complaints by neonatologists and pathologists, I was told it would be inappropriate, even though midwives are not trained in high-risk conditions at the center of my case. Because midwives aren't required to self-report morbidity and mortalities, Texas's maternal and infant health data remain incomplete. This bill could give families real access to Texas-specific birth data that extends beyond birth certificates and has never been captured before. More importantly, this bill could give us information needed to save lives. Transparency builds safer options for families and strengthens the future of midwifery in Texas. I am one of many, and my experience is not unique. And I stand here today to speak on behalf of all mothers and babies who cannot speak for themselves. I would like to close by thanking the committee for your service to Texans and your careful consideration of Malik's Law.
Thank you. Chair recognizes Marquita Cummings, testifying on behalf of Moms Advocating for Moms Alliance for House Bill 4553. Is that correct?
Correct.
Thank you. Proceed.
Good morning, Chairperson Van Dever and members of the Public Health Committee. Thank you for giving me this opportunity to speak with you today. My name is Marquita Cummings, co-founder of Moms Advocating for Moms Alliance, and most importantly, loving mother of Malik Elijah Cummings. I'm sure many of you are parents, and you probably remember the overwhelming joy of pregnancy, or standing beside your spouse during that unforgettable moment when your child was born. You remember holding your baby for the first time, seeing their tiny futures come to life, hearing their first cry, watching their first smile. Those beautiful, precious memories that stay with you forever. I never got those moments with Malik. I never heard him cry. I never saw him smile. Malik's death was tragic and preventable. It's a reminder of gaps that are in our maternal health care. Today, Texas has no mandatory statewide system to collect or report critical information from out-of-hospital births. There is no consistent tracking of emergency transfers from birthing centers or home births to hospitals. No reporting on maternal and infant outcomes after transfer, and no record of complications that occurred during out-of-hospital births. Without this data, we cannot fully understand where the risks are, we cannot address the failures in care, or improve safe, competent care for mothers and babies. Families are left vulnerable, and midwives are left without the information they need to improve outcomes. HB 4553 aims to close the gap by creating a system of accountability, transparency, and continuous improvement in out-of-hospital births. This bill carries my son's name because it carries hope that with better data, transparency, and support, no family will endure what mine has. Malik will be turning 2 in July. Please, let's make Malik's life the turning point to make a difference, and let's make Texas a leader in protecting mothers and babies, starting today by passing HB 4553. Thank you. Thank you.
Thank you for your testimony. Chair recognizes Caden Lopez, testifying on behalf of the Texas Family Project and yourself against House Bill 4553. Is that correct?
Correct.
Thank you. Proceed.
Chairman, Vice Chairman, members, my name is Caden Lopez. I'm the Executive Director of Texas Family Project, and I'm against House Bill 4553. House Bill 4553 mandates intrusive government data collection on every non-hospital birth, even without any complications. Birth is a sacred private family event, not the government's business. Families who choose midwives and out-of-hospital births deserve protection from this government intrusion. This bill undermines the right of parents to make medical decisions. This bill creates an unfair targeting of midwives and puts a burden on midwives to report data that they already report. This also allows births that happened in hospital after they were transferred, even if it had nothing to do with the midwife, be reported by the midwife, and a reason to demonize midwives, quite frankly. My wife and I are currently going through this whole process. Our first is on the way. We just hired our midwife. We're really excited about it. We were listed off every single positive and negative. We went through a super long process, interviewed a ton of midwives, and found one we really trusted, and we just trusted that they will be able to deliver. We know the risks. We know exactly what we're getting versus what we would be getting in a hospital, and we chose to go the midwifery route because that gives us more freedom in what we want to do. Births are a sacred time where families are very vulnerable. We don't want to be pressured by hospitals to take vaccines or anything else. So we urge you to oppose House Bill 4553.
Thank you. Thank you. So the chair recognizes Kristen Bowers, testifying on behalf of Greater Houston Midwives Alliance and the Shire Midwifery and Self, and against House Bill 4553. Is that correct?
That's correct, sir.
Thank you. Proceed.
Hi, my name is Kristen Bowers. Thank you for staying up so late with us today. I'm here representing myself as a licensed midwife and also as a representative of the Greater Houston Midwives Alliance, which is made up of more than 75 midwives in the Greater Houston area, both licensed midwives and certified nurse midwives. I am here in opposition of Bill 4553. Our Houston midwives have collectively served thousands of families across Houston. I come today with a deep respect for every family that has experienced the loss of a child. All of us are here today united by the same goal: healthy mothers, healthy babies, and safe birth. Texas midwives are already highly regulated and accountable through TDLR, and this addition of the bill does not improve safety or access for families and imposes punitive and confusing new paperwork requirements where information in the reports overlaps the already reported state birth certificates. Instead of promoting collaboration and quality improvement, this bill sets midwives up for harsh penalties for administrative errors, including serious fines of $1,000 daily, and license revocation. It unfairly treats midwives differently from other licensed healthcare providers who are allowed due process before being judged publicly, as this bill requires midwives to disclose open investigations to clients, even if no wrongdoing has been found. Furthermore, by singling out LMs and exempting CNMs from these requirements, it creates unnecessary division amongst community midwives and causes confusion within integrated practices like my own, where we work with a CNM, Dr. Andy. We also eliminate a large portion of data in the community birth setting by ignoring other midwives besides licensed midwives. At GHMA, we believe in transparency, accountability, and safety. We are not here to avoid oversight. In fact, we welcome thoughtful and collaborative solutions that improve outcomes such as peer review and voluntary coordinated data collection. If this bill passes, it will not make birth safer. It will make midwifery harder to access,
Thank
especially
you.
for rural and families of color.
Thank you for your testimony. Members, any questions? Representative Pearson.
Thank you, Chairman. This is the Public Health Committee, and we need to look out for the public health, for the folks in our state. Morbidity and mortality is a staple in healthcare, and it's important when we're looking at a population across the state. When I hear babies are dying and nobody knows about it, I have a problem with that. Clearly, there are some reporting issues here. I have victims saying that these things aren't being reported, and then I have midwives saying they are, but yet nobody knows where this information is. My question is for Ms. Cook. Tell us the difference of what this data from the bill is from the birth certificate data. I have a hard time believing that all of these indicators are reported just by filing a birth certificate. So there has to be some differences here.
Absolutely. I would like to start by saying that birth certificates are filed where the child was born. So if a child is transferred to a hospital and the child is born at the hospital, the birth certificate is filed at the hospital. And there is no tracking for the transfer, where the transfer came from, and all of those things. And statistically, in speaking, if we're talking about birth certificate data, reliability for birth certificate data to illuminate maternal morbidities and mortalities is unreliable. Birth certificate data is known to be reliable in APGAR scores, place of birth, and birth weight, leaving reasons for maternal and infant mortalities and morbidities kind of up in the air due to underreporting and then who reports and whether or not you have all the information necessary to make those reports accurately. So Malik's Law, the data that it'll capture, it should capture what is happening before, during, and after a transfer. So we are asking for licensed midwives to report any kind of morbidities that are occurring beforehand, what is occurring after, or well, during, and then we're asking hospitals to report two vital statistics, what is happening after and during that transfer. Do you have, like, would you like more specific information on that?
I'd like, they're saying they're reporting these things, even though we can't find them.
Mhm.
So I'm trying to figure out, like, somebody's not telling us the whole story.
Right.
I need to know what this bill is doing that they're not doing, that they're calling duplicative.
Right. So we're not required to report transfers.
Okay.
We're not required to report what is happening before transfer. We're not required to report what is happening after transfer. So whatever happens after a transfer is recorded in hospital statistics, but there's no indication to what happened before. So we would like to see these statistics produced alongside maternal and infant mortality reports as out-of-hospital data. This wouldn't be data just associated with licensed midwives. This would be data associated with out-of-hospital birth outcomes, meaning what is happening before, and then also how are hospitals responding to this? How are hospitals able to recover from transfers? Or are there things that we need to be doing during transfer, different, like educating our EMS systems that may or may not have education in neonatal resuscitation and neonatal like neonatology? That's also an issue county by county. So yes, it is very different than birth certificate data, also considering that birth certificate data is only filed if the birth occurs at home or in a birth center by a licensed midwife.
Okay, thank you.
Members, other questions? Representative Jones.
So, Miss, why don't I see your name?
Cummings?
Oh, I didn't go up high enough. Yes, ma'am. You've heard the people that have said that they're against this bill. What are your thoughts on the reasons that they're against this bill? What do you think?
I think that their reason against the bill is a personal reason. The bill is only to collect data that will be provided to mothers, so we can make an informed decision when we're choosing an out-of-hospital birth. And if their outcomes are so good as they say they are, then there shouldn't be an issue with reporting those outcomes.
So I agree with that, right? I don't understand how or why, if you are helping a woman in labor prior to a transfer, why we, the state, wouldn't know about it. It's an accountability. If you were a midwife and 10 kids died, I might want to know as a pregnant woman if I want to use you, because 10 kids died. But nobody knows. Contrary to that, if every labor you, I guess, performed, I don't know what you call it, that you gave care in, if 100% of the babies lived, then I might want to hire you too. If a baby had complications and was transferred, I mean, I might want to know what, as a doctor, what happened before I got this, what happened before, to help me give the best medical care for whatever is going on. And so when there's no accountability system for whatever service you provide to the public, if there's no accountability system, then we don't know if what you're doing is reliable, if it's scientific, we just don't know. And someone correct me if I'm wrong, one of the reasons why they, I guess, requires one subset of midwives to do this reporting is because they have less formal education, where I guess you have to go to school or something. And the other one is, I've been doing this for a long time, so I'm qualified. And so there's just, and if I'm wrong, correct me, because I do want to make an informed decision on this bill.
Right. In the testimony you've heard earlier about the differences in education between certified nurse midwives and licensed midwives is correct. However, I would also like to state that certified nurse midwives mostly work in hospital settings. It's a very small percentage that actually work in out-of-hospital settings. Licensed midwives or CPMs primarily attend out-of-hospital births.
So question for you.
Yes, ma'am.
Are certified midwives, if they work in hospital settings, are they supervised by doctors or nurses or something? I'm curious.
Yes, so certified nurse midwives are the only type of midwives who have hospital privileges. They usually have delegation agreements with doctors, meaning they're checking in with their doctors and also going to them for like referrals or they have close collaborations with doctors. So if a woman steps out of that low risk mode and starts creeping into being high risk, that midwife has someone that she's collaborating with, that she respects, and they respect her as a provider and steps in to take over that higher risk care that is meant to be overseen by obstetricians.
So all midwives aren't created equal.
No, ma'am.
I see one has some sort of oversight in a hospital. I would imagine if an emergency happens in a hospital, there's machines and stuff there and experts there that can try to help because it's a hospital setting, as opposed to if something goes off, bad at home, there's just not the equipment there, there's not the expertise there to be able to like save a baby, save a mom, or what have you. You're grabbing the microphone. Do you?
I was just going to agree with you and just make a key point in the difference between the licensed midwives and the certified nurse midwives, which is what part of the issue was, for example, in my birth, I feel like. Licensed midwives, the education is you can just have a high school diploma and attend a apprenticeship type of midwifery school or this 2-year program that the Association of Texas Midwives have and become a midwife versus the certified nurses midwife is you're actually a registered nurse and then you get your bachelor's and a graduate degree. In my case, I had a licensed midwife who I feel like was not competent enough and lacked the judgment and the knowledge to transfer me to the hospital whenever I showed blatant signs of complications and fetal distress in my pregnancy. And she waited to transfer me, and she practiced outside of her scope, which ultimately led to my son's heart rate dropping and him not having oxygen to his brain for an extended amount of time.
So when you say she practiced outside of her scope, what do you mean?
So I was already labored for approximately 69 hours, and I was at a birthing center, and my contractions were completely abnormal. They were just completely abnormal. My labor had stopped progressing, and I was also leaking meconium, and she assisted me whenever a contraction came by inserting 4 fingers to help, I guess, get the baby out. And this is when my son's heart rate dropped.
I'm so sorry.
He was a healthy baby boy.
I'm so sorry about what happened, but I definitely believe that there's a reasonable basis for why there's a difference in requirements under this bill, and I don't see where it's picking on a group because you're asked to report things that's in the best interest of public health. But thank you for sharing. I really appreciate it, and thank you for helping me have a better understanding of the meaningful differences and distinctions between a licensed midwife and a certified nurse midwife. One is an RN, one isn't. One has way more training. Makes sense to me. Thank you.
Thank you.
Thank you, members. All right, thank you for your testimony.
Thank you very much.
Chair calls Joan Doglio Smith, Claire Newmeyer, Morgan Miles, Monica Stone.
Do I give these to you?
Joan Doglio Smith?
Yes.
Okay. I show you registered to testify on behalf of Coalition of Texas Birth Centers and yourself, and you are against House Bill 4553, is that correct?
That's correct.
Thank you. Proceed.
So, good evening. My name is Joan Dolio Smith. I'm a CNM, and I am representing myself as well as the Coalition of Texas Birth Centers, and I oppose HB 4553. You might wonder why a CNM is here to testify on a bill about licensed midwives. Well, I have been a CNM here in Texas since 1996. Since 2002, I've been here in Austin working alongside licensed midwives in 4 of our nearby birthing centers and attending home births. As the clinical director and staff developer of 2 of those birthing centers here in Austin for 19 years, I have become very familiar with the DSHS, TDLR, and the HHSC rules and regulations. I've also been an OB hospitalist with privileges at 2 of our Austin hospitals, and I accept the LM clients when they transfer them in for the hospital births since 2017. As the president of the Texas chapter of the American Association of Birth Centers, I represent the birth centers and midwives that own and operate these birth centers. We have 91 in the state, the largest by far of any other state. We have the largest number of birth centers, but also we have 52 of these are owned by licensed midwives. And many more, even if they're owned by CNMs, they are employing licensed midwives. So I am very certain that LMs are already highly regulated and licensed by the TDLR and are already required to follow clinical guidelines based on the TDLR rules, as well as report all their birth data to the DSHS. By law, they have a very delineated scope of practice and are the only healthcare providers that are required to do a written informed consent, which I have for you all to see. And that's done before the beginning of care. According to birth certificates data in the CDC natality database, which I did not provide that, but I just have one example of it here. So what I did is I went to the CDC database, which is based on birth certificates, and I looked up LMs.
Okay,
Okay.
I'm sorry. Thank you for your testimony. Chair recognizes Claire Newmeyer, testifying on behalf of self against House Bill 4553. Is that correct?
That is correct. Thank you
Thank
so
you.
much. I am coming into this as a neutral party. I just learned about this bill yesterday, so I have actually spent a decent amount of time looking up some of these statistics that are supposedly so hard to find. I'm coming here as a health and wellness professional. I work with pre- and postnatal women. I also have experience working in the PBM space. For 3 years, I worked for one of the largest PBMs in the country. So I have extensive experience working with hospital legislation and administrative issues. So I can give you some statistics here. I have a lot of information and I don't want to waste your time. But for example, Texas Home Birth Association has collected statewide data that indicates that interpartum during labor hospital transfer rates for planned out-of-hospital births in Texas range from 23 to 37% for first-time mothers and 4 to 9% for those who have previously given birth. Individual statistics for midwife practices can be disclosed upon asking those particular practices. As far as infant death rates, traditional providers such as MDs are not legally mandated to disclose the number of infant deaths that have occurred under their care. Therefore, neither should midwives have to. Births attended by midwives in Texas have statistically better outcomes than traditional provider settings. According to the CDC, only 2% of midwife-attended births in hospitals resulted in NICU admittance. So this is when a baby is transferred to the hospital and the midwife comes with her. So they report all of that data. In contrast, 10% of all births in Texas in all hospitals by doctors result in NICU transfers. So that rate is lower for midwives. I am, not aware of what has gone on between these two groups, but I am aware that the penalties for midwives are very strong, and there are a lot of very strong feelings around some of the instances that have happened where babies have suffered and women have gone through traumatic experiences. However, that data is there if you look for it.
Testimony.
Thank you.
Members, any questions of this panel? Okay. Thank you. Thank you for testifying.
Thank you.
Can I speak to the paperwork that I passed out?
I would ask, okay, Representative Schaffner.
Speak quickly. Okay, I was. Okay, so this one is the data that if someone really wants to learn what you see, you go to this. This is available to anyone who wants it. This is through the Perinatal Data Registry, okay? That shows you from 2013 to 2024 what happened in 9,000 women's births attended by licensed midwives, nurse midwives, and birthing centers. And I have a lot of problems with this bill. I would love to tell you all the problems with the bill, because I feel like we've spent all this time with other things, not talking about the bill.
We all have offices. We would welcome you
I
to
know.
come and visit.
Oh, I will.
Thank you. Thank you. Just real quickly.
A lot of the issues in reporting come on the birth certificates in the hospitals. They don't have fields to say if it's the CNM or an LM. So this is something I saw all the time working in hospitals. The reporting problems come from the hospital side, not from the midwife side. So I would encourage you to look into that further.
Thank you.
Thank you. I'm sorry.
Chair calls Lavondria Williams. Ruth Bailey. Laurie Fremgen. Okay, I have Lavondria Williams, a student midwife, testifying on behalf of self against House Bill 4553. Is that correct?
Yes.
Okay, you may proceed.
Good morning again. My name is Lavondria Williams. I am a student midwife, a current doula, and a childbirth educator with 6 years of experience walking with families through some of the most sacred moments of their lives. I have attended almost 100 births in hospital, birth centers, and homes. I also have given birth to both of my children safely at home, attended by a midwife. As a proud African American woman in Texas, I am here today to strongly oppose House Bill 4553, Malik's Law. I have seen what happens when families are given true respect, true choice, and true care, and it happens far more often outside of the hospital. Out of hospital births are more patient-centered. They are led by trust, education, and honoring the mother's voice, not by fear, pressure, or unnecessary interventions. This bill threatens to strip away the very heart of what makes midwifery care so powerful: trust, respect, and access. It places even more burdens on midwives who are already caring so much. It risks making out-of-hospital birth less available, less accessible, especially for Black families and families of color who already struggle to find safe spaces in our healthcare system. We do not need more barriers, we need more bridges. We need more access to birth centers, home birth, and skilled midwives, not more red tape. Birth is not one size fits all. Every family deserves the right to choose the kind of care that honors their body, their baby, and their values. House Bill 4553 puts that at risk by placing redundant reporting requirements on midwives that are already in place, taking invaluable time away from a mother's care and using it instead to completely duplicate paperwork. I am asking you today to please listen to families, the midwives, the community standing here. Protect our rights, protect our choices, protect safe, respectful, out-of-hospital birth. Thank you.
Thank you. Chair recognizes Ruth Bailey, midwife, testifying on behalf of self against House Bill 4553. Is that correct?
Yes, that's correct.
Thank you.
Thank you all so much for hanging with us. It's really appreciated. I just want to talk about two things. One, I want to address the reporting. I'm happy to actually, in Vital Statistics, read off what we do check and report and how the hospitals can go in and put the midwife's name and the reporting, the transferring midwife, her name, credentials, the date of prenatal care that she started, how many prenatal visits, what was tested. That can all be done. I'm happy to do that if you want more details. But my biggest concern is the dangers this does create for rural families. There's about 46% of counties. There's about 46% of counties in Texas that are rural that don't have access to labor and delivery hospitals, and that's where midwives come in to screen for blood pressure, gestational diabetes, other complications, and get them to a high-risk facility if they need that. What happens with this reporting that is redundant, if I have to do this when I transfer a client to the hospital, I don't get the data from the hospital to actually make that report. And we're not making a ton of money here in our gig. And so 1-2 fines of this, and that puts that midwife completely out of business. Now, all these rural counties that are relying on midwives to screen and take care of them in their lowest pregnancies and get them to a high-risk facility now are no longer in business. So there's no health care, which makes maternal death be a lot more significant. And as of latest statistics, we are now ranked number 50 for the safest state to have a baby and for maternal mortality. So that's specific to BIPOC families, that's specific to rural families, and again, happy to go into other details if needed.
Okay, thank you. Chair recognizes Laurie Fremgen, testifying on behalf of the Association of Texas Midwives and Self against House Bill 4553. Is that correct?
That's correct. Thank
you.
you. Thank you. Members of the committee, thank you so much for still being here. Y'all have some stamina. I want to start by saying that this bill is much more than just a reporting bill. There are other aspects to this bill that are concerning. Section 203-351F requires that it requires that a midwife disclose when a complaint is filed against them to clients before the complaint is completed. So unfortunately, there are still many frivolous complaints filed against midwives in this state, many of which are dismissed. As a matter of fact, in 2024, 60 cases were reviewed by TDLR's enforcement team, and none of them resulted in disciplinary action. I should also state that I've been on the midwifery board for 25 years and served as chair for the last 6. Requiring a midwife to disclose an incomplete complaint violates a midwife's due process. Once the complaint is completed, then it's public information. Anybody can get that information. But not even TDLR can disclose this information before it's complete. Additionally, no other healthcare provider is required to disclose open complaints to their patients or clients. Another section 203-351B5, this is an additional requirement, making the midwife disclose whether or not she's certified in intermittent auscultation. This is automatically included with our license renewal. And then I just want to point out again the standards that the other midwives had talked about with
thank you.
ACOG and ICNM.
Thank you.
Okay.
Members' questions?
Thank you.
Okay, thank you all for
Okay,
your testimony.
thank you so much.
Is there anyone else who wishes to testify on, for, or against House Bill 4553? If not, Chair recognizes Representative Bordas to close.
Good morning, members. Thank you, really, for giving me the opportunity to lay this bill out. I've had several conversations with many of you. It was heartbreaking to hear a lot of these stories, and it was just something that we really wanted to do something to help, right? And we know just even from the testimony today that there's issues with the data reporting. Even when me and my team started delving into this, we had a hard time finding consistent data, where the data is. So as I mentioned before, we're working with TDLR and DISHES on a committee substitute that streamlines a lot of that reporting, that actually addresses a lot of the concerns that were relayed today. And thank you so much for those who came out today. Happy to sit down with you. We want to present a good bill that's good for Texas, and especially good for moms and babies. So thank you all again for hearing this tonight. I appreciate it.
Absolutely.
I'll have some cookies and coffee waiting for you all tomorrow. So
Thank you. Members, any questions?
Thank you, guys. I close.
Thank you. If there's no objection, House Bill 4553 will be left pending. Is there objection? Chair hears none. House Bill 4553 is left pending. Chair lays out House Bill 4051. Chair recognizes Chairman Frank to explain the bill.
I can clear a room. Thought I'd come up here just to make sure I could catch any of y'all if you're sleeping. The good news is this is not a vaccine bill. The bad news is it is a scope bill. I just want to give a little background on scope bills and then talk specifically about this. I've been involved in scope battles, if you will, for 13 years in the ledge, and really what seems to happen is the same every time. One group says they want to provide a service that they feel like they're qualified for. The other group that might be losing business comes in and tells you that it's dangerous. And then we have these big battles, and then we never end up doing anything. But because we never end up doing anything, basically it limits customer choice. I tend to be kind of pretty open-minded on the scope. I kind of like all of them. I think the customer should end up deciding, but we obviously have to have. So I was not actually planning on filing a scope of practice bill and said, but you did. You did. Why did you? Actually, I was, what's that? But I was approached to file the bill on allowing pharmacists to test and treat, which I think is a good idea. It gives people another option to go to. But I told him, I said I wouldn't do that unless we actually give physicians the ability to dispense in their offices, because that is another thing that is, I think, provides convenience and access to health care. And so really what you have before you is a combination of those two things. And there has been a lot of negotiation on behalf, because basically if these were completely standalone bills, or it is a standalone bill, it's just one bill, it's not two subjects, it's just one subject, or to check that. Basically, it authorizes physicians to store and dispense medication, which, by the way, is done in over 40 states. It is kind of silly when you think about it. You can go to a doctor, the doctor can know what's wrong with you, and yet can't give you antibiotics. You have to go somewhere else, which means you've got to take another 30 minutes out of your day to go take it. And one of the problems we have with physicians is people not taking their drugs, because they go to the physician, but then they don't end up going to the pharmacy. So this authorizes physicians. It excludes the dangerous drugs listed in Schedules 2 through 5. It does include requirements for packaging, storage, training, and record retention, which I'd be happy for you to ask questions, and there are groups working on both sides on this. It then also authorized pharmacists to test and treat for certain basic illnesses, including flu, strep, throat, and COVID. If you think about the way people get, when you have a sore throat, when you're going to call your doctor, but if your doctor's not available, what do? Right? Yeah, you go to urgent care, so you go to somebody probably that you've never met. They write you a script in 5 minutes that they spend with you, and then you go to the pharmacist. Okay, this allows you on certain types of very limited things to go actually and get test and treat at the drugstore. And again, this is done in over 20 states. So this is not cutting edge stuff that we're dealing with here. I know it's important that we are safe, but this is not cutting edge stuff. This is done a lot of places. And I think at the end of the day, it gives access, better access to care, and certainly much more convenient care than what we have now. Hopefully putting them together means we actually have people on both sides that will agree. There's certainly some that still don't like it. So anyway, I think it's an important issue to talk about. I will leave it at that. I'm happy to answer any questions, and there are some witnesses that will be short but can answer some of your specific questions, and certainly we can answer some of those later. But I really do think, I do think it's an important topic. I think it's the only thing we're probably going to do, well, not the only thing, but I think it's something important, and it's measured that we can do to improve access to care for people. So with that, I'd be happy to answer any questions, and happier not to.
Representative Schofield.
Mr. Frank, I think one of the things that we've been concerned about over the years is if doctors own a lot of equipment, they buy a nice new sonogram machine, they're going to want to use it, so they're going to overprescribe its use. And it would seem like if you got doctors into the dispensing business, they would start overprescribing because they get to sell you the drugs. Isn't that part of the reason why we separate those two functions when it comes to pharmacy?
I think theoretically, I think more than that, it is that there's a strong contingent of pharmacies that have convinced us not to. And again, this is practice is done in over, I think it's actually over 45 states. I'll say over 40 states for clarity. And I believe, and I don't know whether it's in this, I know there's still some negotiations going on. In some of the states, they limit it to you can do a $5 dispensing fee, cost plus $5 or that kind of stuff. It is not, I think in most cases, it is convenience for the patient. But I don't think there's a big revenue generator for most of them, and because some of it is they're not going to be allowed to do the higher end, opioids and those kind of things, which I'm not sure people should be prescribing much opioids anyway. But it's a limited amount of drugs that they can do, and I think they're not going to. Most physicians are not going to want to stock and store anything other than the basic drug.
And then sort of on the other side of your bill, I'm always concerned when we start having people get over their skis and get past their capabilities.
Right.
And yes, a pharmacist might be able to tell if I have strep throat, but he's not going to see anything else. Whereas my doctor might say, you might have strep throat, but you also might have this, and I'm seeing this, and that could be an indicator of that. I'm just tell you right off the bat,
Sure.
it's an uphill climb for me
Sure.
to have people start practicing outside their scope.
Okay.
Because I don't think they're capable, and I don't think you get good health care that way.
Well, and I would just say, I think you have to compare this to what most people's reality is of how they get their health care. Most doctors can spend less than 7 minutes on an office visit, and if you go a sick call, how much time did you get on the last sick call that you went into a doctor? Because I got less than 3 minutes. Literally, it was a script. I mean, it was here's a script. And I think that's what the vast majority of our patients deal with.
So it seems like what you're telling me
It is
is
test and treat.
the practice of medicine has gotten so bad that we might as well just let the pharmacists do it because the doctors aren't doing a good job now anyway.
No, I'm saying on very specific things, and this is very specific. You know, I would ask you to look at, I know you're a detail guy, I would ask you to look at very specific things where essentially what the doctor is always going to do is do a standard test, and that's what, and there's a standard protocol that on those things, we shouldn't overcomplicate it. But, yeah, we're not, so anyway, that's my feeling. But I will have you as an uphill climb note. Noted.
All right, members, other questions?
Witnesses noted that too, right? Uphill climb over there.
Okay.
All right,
Thank you. We
and
will
I
reserve
would,
your right, and we will have some witnesses to call.
Thank you. Try to make you laugh. It's after midnight.
Chair calls Dr. Zeke Silva, Carl Isett, Kelly Cox, and Dr. Clifford Porter. Show you registered as Dr. Zeke Silva on behalf of Texas Medical Association and yourself, and you are neutral on House Bill 4051, is that correct?
Correct. We're on the bill, and I am speaking. I'm Zeke Silva. I'm an interventional radiologist. I am speaking on behalf of the Texas Medical Association on this bill. We thank Chair Frank for bringing this forward. We welcome the opportunity to work with him to improve this bill. From our perspective, it is our understanding that there is a committee substitute being discussed, and that the committee substitute will require that when pharmacists order and provide a treatment, that would be under the delegation and supervision authority of a physician. That would be the first improvement. That once that does occur, we would like to see further detail to make that consistent with other delegation and supervision. For example, for APRNs and NPs, we think we can strengthen that language as well. You know, we think this is a patient safety matter, and to Chair Frank's point and to Representative Schofield's point, you know, we think that physicians need to be engaged in these discussions and these determinations. Pharmacists, give them full respect. They have 4 years of training. It's just their training is not the same as ours. It's not in diagnosing disease, it's not in differential diagnoses, and it's not in the therapeutic realm that we have that training as physicians. The last piece I'll add is there is language in the bill that says furnish. We would like the language to be more consistent with administer and dispense. Furnish may go beyond just oral medications and into nebulizers or even intravenous therapy, and we think it should be tighter than that. And we welcome the opportunity to work with Chair Frank and his staff and our team to improve this bill in a way that may make it acceptable. For that reason, we are on House Bill 4051. Thank you.
Thank you. Chair recognizes Kelly Cox, testifying on behalf of Walmart for House Bill 4051. Is that correct?
Yes, sir.
Okay, you may proceed.
Well, good morning, Chairman.
Please pull the microphone down just a little. Thank you.
All right, there we go. Good morning, Chairman Van Deaver and distinguished members of the Texas House Public Health Committee. My name is Kelly Cox, and I manage 13 pharmacies in East Central Texas. I'm here to speak in support of House Bill 4051. As Texas, we're experiencing a real challenge. Too many of our communities face a shortage of healthcare providers, leaving our families, essentially seniors, the uninsured, and rural residents waiting too long for care. According to a report by the Texas Conservative Coalition Research Institute, more than 7 million Texans already live in a federally designated health professional shortage area. House Bill 4051 offers a thoughtful, patient-centered solution by allowing pharmacists to test and treat common conditions and allowing physicians to dispense medications directly from their offices. This bill will give Texans more timely access to care where and when they need it most. Pharmacists are among the most highly trained and trusted professionals in healthcare in our communities. They are accessible after hours on weekends, which means families won't have to wait days or even weeks for a doctor's appointment to start feeling better. When it comes to conditions, getting prompt treatment isn't just more convenient, it can lead to faster recovery and better health outcomes. Importantly, care delivered through pharmacies and direct physician dispensing is often significantly more affordable. In many uninsured Texans, a pharmacy visit can mean the difference between getting care or going without care. House Bill 4051 ensures that care is available, accessible, and affordable for more families across Texas. In a time of stubborn inflation and continued economic uncertainty, improving access to prompt, affordable care is more important than ever. I respectfully urge you to support House Bill 4051 to help Texans get the care they need when and where they need it.
Thank you. Thank you for your testimony. Chair recognizes Dr. Clifford Porter, testifying on behalf of the Texas Public Policy Foundation and self for House Bill 4051. Is that correct?
Yes, Chair. Yeah, so I'm Dr. Cliff Porter, so I'm the Senior Fellow for Healthcare at Texas Public Policy Foundation, whom I represent myself. So many of my patients cannot afford the exploitive high drug prices, and there's just a cloud over medicine. A handful of middlemen are taking advantage of illnesses to basically charge high prices. So drug costs are a barrier to care, which causes harm. So however, physicians directly dispensing the medications we prescribe can cut drug costs up to 95%, which is currently allowed in, I think it's 46 states, and safely and without harming independent pharmacies' financial viability. So some specific examples. EpiPens, a pair of EpiPens costs $150 to $300, something about $120. But I can do an EpiPen equivalent for $5. So, and I can't do that under current law. So retail chains charged one of my patients $287 for a $3 supply of Zofran, an anti-nausea medicine. Other things, as Representative Frank says, I can provide immediate antibiotics, UTIs, ear infections, skin infections, and so forth. I'm also allowed to bypass prior authorization, so you can get people immediate treatment, so it's quite valuable. Now, independent pharmacies lose money on generics because of PBMs and insurance reimbursements are so low. That's where they're actually being squeezed. It's not from the threat from direct dispense. The opponents also falsely claim that direct dispense is unsafe, but again, the research from all these other states show this isn't true. In fact, the research shows that high-volume pharmacies, high-volume clinics, corporate clinics, they're the ones doing the drug errors because they're going too fast. That's a safety problem. Walgreens has actually been fined for safety violations in a couple different places. So moving a little over test and treat, as a physician, I think this can be done properly with flu and strep. It can be done safely with proper medical standing orders. Early and cheaper is better. Now, yeah, there's some clarifications of the bill we need to work on, but I think independent physicians, independent pharmacists, I think we can actually come up with something really good that can directly lower costs immediately. And like the only argument against physicians directing dispense, I think, is financial, but.
Thank you. Members, any questions for this panel? Representative Schofield.
Dr. Silva, I was somewhat heartened to hear you talk about pharmacists acting under delegation, but you've been around this committee enough this session to know that we have our concerns with how delegation is working in this state. And a lot of times the physician isn't really paying any attention at all and is just using the excuse to charge. It wouldn't do us much good if all we had was a doctor charging the pharmacist a fee to use his license, or to have Walmart have to hire a doctor to do what they want to do, which is clearly have their pharmacist practice limited medicine. What can you recommend to the author that would make the delegation a real delegation where we know that there's a doctor with his at least some attention being paid to what the pharmacist's doing?
When I said delegation, I probably should have also said delegation and supervision. So once we delegate that prescriptive authority to the pharmacist, and they are practicing medicine at that point, they are acting under the delegation authority, there is a supervision component, and the Medical Practice Act requires that supervision take place before any patients are even seen, establishing protocols, communications, what medications can be prescribed, which ones cannot, based on the physician's experience, the relationship with the pharmacist, and frankly, the pharmacist's experience and training as well. There's quality assurance that's part of that supervision requirement, not currently in this state, but where we would want to see this evolve into. And then there's the ability for the pharmacist to communicate regularly with the physician to ensure that there is periodic oversight. But I think importantly, to have that physician as a safety net. If there is an occurrence where there is a poor outcome or an acute condition, to have that safety net of that clinical expertise to inform that clinical situation. Yeah, thank you.
Representative Pearson.
Thank you. Dr. Porter, you mentioned flu and strep in this. My question is actually for Ms. Cox. But since you brought it up, you know, physicians treat to the patients, not to the test. Pharmacists are going to be treating to a test. And we know with flu and strep, there's a lot of false negatives there. So my question for Ms. Cox is, what does a pharmacist do with a false negative?
Well, the bill's going to ensure that we've got proper training of our pharmacists. Intake forms will be filled out by the patients. Proper protocols will be followed, and we'll follow up with the physician within 3 days.
I don't know why you wouldn't just go to the physician first. You see, it sounds like this is more fragmenting and not doing what I think the intention is here. So thank you for the answer.
Members, other questions?
Oh, may I just make a comment? I think the challenge with it, from my standpoint on these basic things, is sometimes it takes 1, 2, 3 days to get into the physician when you could have already, on a strep, flu, that kind of thing, you could have already gotten taken care of, because a lot of people can't get into the physician the same day. I don't know about you. I usually can, but most of the guys that work for me can't. That's not the reality most people live in, and to be able to get into their doctor and get medicine that quick. It's just not. And to me, this, at least in a 2 or 3 day situation, says I go in, get it taken care of, and then if the information then gets to the doctor, then you can have that doctor, but you've at least gotten the medicine started, as opposed to having to wait 2 or 3 days before you get the medicine started, is my belief. I think it's the best of both worlds, I feel like.
Representative Pearson.
No, I understand what you're saying, but in most clinical practices that I've worked in myself, if a patient calls in, they have a sore throat, maybe it's strep or something else, they usually schedule a nurse visit. You don't have to see the doctor in the doctor's office to have one of these tests done. Is that right?
That is correct. And in fact, many of the medical standing orders in urgent care, which I've worked quite extensively, is if someone's coming in flu season, fever, muscle aches, chills, they do a flu test immediately, and sometimes a strep test as well.
Sure.
So that medical assistant's doing that already.
Right.
Now, the 4 or 5 years ago, the flu point-of-care testing had a 60% accuracy. That was useless. Now they're required to have it much higher, to 80+%. And then also with false negatives, people can actually have strep tests that are positive because they're just colonized, and they get repeatedly treated. So what you do in a medical standing order is you prepare for those exceptions. If someone keeps coming back for a strep throat, then, and that happens with any urgent care and other primary care places too, that's a reason to defer. Now, with the delay in care, this is where it's a bit of a compromise with safety and so forth. So 20, 30, 40, 50-year-old person with the flu, you want to treat them pretty quickly to prevent complications within a couple of days, 48 to 72 hours. Well, what if they're 65 years old with emphysema or have heart disease? Then that person actually needs a whole different type of requirement. That you can put in a medical standing order so you get that safety. Now, it isn't the same training I have, but you're able to do it faster. Now, are we doing a bit of a compromise because our medical care system, like I said, we have the best medical care in the world. We have a terrible healthcare system. And so we're sometimes trying to make a compromise in order to lower the barriers of care to prevent treatment. So flu, aside from COVID, flu I've seen, destroy hearts in the 25-year-old. So you want to treat early. So this is where developing some of these safety protocols and having the co-liability of the physician. So I would do this. Now I'm going to be more active as a supervisor than some of the course cases I've heard today. But shared liability with just the physician and the pharmacist, I think is a reasonable guardrail. But I think we need to talk about this and perhaps do we want to do some with the Texas Medical Board, or we come up with a standard medical standing order which establishes good protocols? That's actually, I think, a really reasonable idea that we want to continue in these negotiations.
But even with a false positive for strep, are you concerned at all with the overprescribing of antibiotics?
I am, but the amount of time that occurs when you start seeing the pattern, you're going to see that in our pediatrician's clinic as well. So then you start seeing that, then you want to defer it. So I think a pharmacist and a pediatrician would see those both. Now, one problem that occurs even with urgent care is a lot of people view their primary care as whatever urgent care they're closest to, and that problem exists in that situation too. So if someone's bouncing around from pharmacies and urgent cares with their kids getting multiple antibiotics, that's a risk regardless right now. So to try and educate, and that's where you just educate the parents. If this is recurrent, please go see a pediatrician or a family physician like myself.
Okay, thank you.
All right. All right, thank you for your testimony. Is there anyone else who wishes to testify on, for, or against House Bill 4051? Not, Chair recognizes Chairman Frank to close on the bill.
Members, I appreciate any feedback that you have that you hadn't already given. I would appreciate it and appreciate your favorable consideration as we move forward. Thanks. Bye.
Thank you. If there's no objection,
Did I just say bye? I closed. Sorry. But I am going to leave now. Just kidding.
No, you're not.
No, I'm not. No, I'm not. There ain't no way I'm leaving.
all right, if there's no objection, House Bill 4051 will be left pending. Is there objection? Chair hears none. House Bill 4051 is left pending. Chair lays out House Bill 3554. Chair recognizes Representative Simmons to explain the bill.
Okay. I have good morning and good afternoon here. I had no idea. Well, technically it is good morning.
It's back to morning.
Good morning, Chairman Mendeever, Vice Chair Campos, and members. It is my honor to lay out HB 3554 before you today, which would establish the Texas Rare Disease Advisory Council, RDAC. In the United States, the CDC, NIH, and FDA all define a rare disease as one that affects fewer than 200,000 Americans each year. The National Organization for Rare Disorders recognizes and promotes the RDAC model as an advisory body that gives the rare disease community a stronger voice in the state government. These councils are established through state law, driven by the advocacy of the rare disease community, and bring together a diverse group of stakeholders on a regular basis to discuss and develop solutions to issues impacting a state's rare disease community. The first RDAC was created in North Carolina in 2015 by advocates and families who were driven to make a difference, and has since inspired the creation of councils in 29 additional states. With the support of NORD, various patient organizations and stakeholders in the rare disease community, RDACs are enabling states to strategically identify and address barriers that prevent individuals living with rare diseases from accessing adequate and effective treatment and care for their condition. HB 3554 would create the first ever Texas RDAC using a model similar to the Texas Mortality and Morbidity Review Committee. This bill has no fiscal note. I repeat, this bill has no fiscal note, and Texans living with these conditions have been overlooked for too long. I believe we have a resource witness here, as well as a few others that would like to talk about the importance of this bill. And with that, Mr. Chairman and members, I'd like to reserve the right to close, and I'm happy to answer any questions that you may have, hopefully not too many because it's 1:12 a.m.
Thank you. Members, any questions for Representative Simmons? Representative Schofield.
I just have one question. Does the bill have a fiscal note?
It does not have a fiscal note, and I was thinking of you in mind. I was like, let me find something that he can say yes to, so.
Okay, we will reserve your right to close. Chair calls Andrea Abramowitz and Jordana Koch. Show you registered as Andrea Abramowitz, testifying on behalf of yourself for House Bill 3554. Is that correct?
Yes.
Okay, proceed.
Hello, my name is Andrea Abramowitz. I'm from Frisco, Texas, and I'm here today to ask for your support for HB 3554 to establish a Texas Rare Disease Advisory Council. I'm a nonprofit leader, a health advocate, and most importantly, a mom. I've spent the last 16 years navigating the world of rare diseases for all three of my children and myself. Rare diseases affect approximately 1 in 10 Americans, which means they affect more than 3.1 million Texans. Our journey started in 2008 when my daughter Kayla became severely ill at the age of 6. She was in constant pain, but the answers didn't come. Years went by without a diagnosis. We were told it might be growing pains, anxiety, or something she would outgrow, but we knew something was seriously wrong. Eventually, she was diagnosed with pediatric Crohn's disease, eosinophilic colitis, and juvenile arthritis. During this time, my son Ethan started showing symptoms. He had trouble eating and wasn't growing. For 6 years, we were told he was just a picky eater. When he finally got an endoscopy, we learned that his esophagus was so inflamed he couldn't physically swallow food. He had to be fed by a machine through a GJ tube for 6 years to survive. His diagnosis was eosinophilic esophagitis and juvenile arthritis. We had to travel across the country to find many doctors to help us. Our middle child also struggled. Years of unexplained abdominal pain led to a diagnosis of CSID, a condition so rare that we as parents often had to educate the providers that we were meeting with. It can be overwhelming as a patient and caregiver to be navigating the complex world of rare diseases, one with few specialists, treatment plans that feel like guesswork, and little support.
Thank you.
Establishing.
Thank you, I'm sorry. Thank you for your testimony.
Thank you.
Chair recognizes Jordana.
Jordana Koch.
Thank you.
I
Jordana,
just wanted to
let
say,
me, let me get your information in. You're testifying on behalf of KMT2C Foundation and yourself and your FAR House Bill 3554, is that correct?
yes, sir,
Thank you.
thank you.
Proceed.
I want to say thank you for everything our representatives do for the incredible state of Texas. I had a very different understanding before 1 a.m. this morning. Whole new appreciation. I'm from Manhattan, so I'm working off bullet points and going from the heart. I'm going to start with the end in mind. My son, it took 108 medical appointments. It took $13,604 of copays and medical bills, and 29 days of my husband to take off from work, not counting the 108 that I eventually had to leave my position. My son has an incredibly rare chromosomal abnormality, and I started noticing signs at 6 months old. However, the doctors were more interested in talking about my postpartum hormones. We actually left most appointments. We left 3 pediatric appointments from 3 different pediatricians in one specific hospital. One tried to give me a script for anxiety medicine or a referral to see a psychologist. They said, postpartum is hitting you very hard. You fast forward to today, I represent a PAG that has over 300 children globally, 12 in the state of Texas, 70 in the United States, all that have my son's condition. This council offers an opportunity for collaboration, not a threat. My husband is a molecular biophysicist from Princeton. I have a venture capital, private equity, and private finance background. We love research and spreadsheets. We didn't know how to navigate the system. And if you have 2 educated people who still have room to learn, I'm scared for the other families.
Thank you. Members, questions of this panel? Okay. Thank you so much for being here and for sticking with us. Okay. Is there anyone else who wishes to testify on, for, or against House Bill 3554? If not, Chair recognizes Representative Simmons to close.
Thank you. Members, HB 3554 will improve access to high-quality, evidence-based health care for Texans living with the rare disease. And again, Rep. Schofield, it has no fiscal note. I ask for your favorable consideration, and with that, I close. Thank you.
Okay. If there's no objection, House Bill 3554 will be left pending. Is there objection? Chair hears none. House Bill 3554 is left pending. Chair lays out House Bill 5274. Chair recognizes Representative Cunningham to explain the bill.
And it's just one more after this,
Thank you, Chairman Van Dever, Vice Chair Campos, committee members, for this opportunity to lay out House Bill 5274, which establishes licensure for certified anesthesiologist assistants, or better known as CAAs. CAAs are not new or experimental. They have been safely practicing in Texas since 1997. After earning a bachelor's degree, CAAs complete a rigorous 24 to 28 month specialized graduate program, including over 2,000 clinical hours across all major anesthesia specialties. CNAs must pass a national certification exam, meet recertification requirements, and maintain ongoing continuing medical education. To be clear, the education and training of a CAA is parallel and analogous to that of a certified registered nurse anesthetist. This legislation directly addresses the persistent and growing threat to the healthcare access across Texas. The shortage of a qualified anesthesiologist providers and the shortage and delays in surgery disrupt hospital operations, compromise patient outcomes, and is a barrier to the employment for credentialed and qualified professionals. CNAs are the only providers in the operating room who are not licensed. Despite completing rigorous training, earning national certifications, and working under supervision of anesthesiologists, and even though there are many anesthesiologists ready and willing to hire them, because they're not licensed, some hospitals do not credential CAAs due to bylaws that prohibit the use of unlicensed personnel. As a result, a highly qualified CAA may be fully utilized in one facility and a block away from the other facility is not accepted. This inconsistency creates staffing headaches for hospitals and ultimately limits care for patients. So, let me be clear. Where CAAs are practicing in Texas today under delegatory authority, they are already integrated into an anesthesia care team, often rotating shifts alongside certified registered nurse anesthesists. The collaboration is seamless. There is no disruption to workflow, no degradation in care. HB 5274 would bring order and transparency to the system. It creates a pathway for licensures under the Texas Medical Board and establishes a dedicated advisory board to guide implementation. It ensures CNAs meet high educational, ethical, and continued education standards and confirms that their roles are always under the supervision of a licensed anesthesiologist. Thank you, Mr. Chairman and members. I believe I might have some witnesses that stayed with me, and I'll reserve my right to close.
All right, thank you, Representative Cunningham. Members, any questions for Representative? Okay, we will reserve that right. We will proceed with public testimony. Chair calls Dr. Zeke Silva, Brian Cornelius, Stephanie Williams, and Alan Rivera. Okay, I have Dr. Zeke Silva testifying on behalf of the Medical Association and yourself, and you are for House Bill 5274, is that correct?
Correct. Yeah.
Thank you.
Zeke Silva, Chair TMA Council on Legislation, in support of House Bill 5274. Representative Cunningham's layout was excellent. You're going to hear from a number of anesthesia colleagues who can give you more of a clinical perspective. But for all of the positives and benefits to this bill, the TMA is proud to stand in support. Thank you.
Thank you. Chair recognizes Brian Cornelius, testifying on behalf of the Texas Association of Nurse Anesthetists. I give up. And self, hopefully. Testifying against House Bill 5274, is that correct?
That's correct, sir. Thank you.
Thank you.
Thank you, Chair Van Dever, Vice Chair Campos, and the rest of the committee for sticking with us at this late hour. My name is Dr. Brian Cornelius. I'm a certified registered nurse anesthetist, CRNA, practicing in Fort Worth, Texas. I'm an associate professor at the largest nurse anesthesia program in the country, and my practice clinically at a level 1 trauma center in Tarrant County consists primarily of pain management, trauma, and emergency anesthesia. I'm here today on behalf of the Texas Association of Nurse Anesthetists and myself to respectfully oppose House Bill 5274. Unlike anesthesia assistants, CRNAs are licensed independent professionals with critical care nursing backgrounds. They bring years of hands-on experience managing complex patients even before beginning their specialized anesthesia training. Their education and clinical rigor prepare them to think critically, act swiftly, and care for patients at every level of complexity, from routine surgeries to life-threatening emergencies. On the other hand, anesthesia assistants have no independent nursing experience and operate solely under the direction of an anesthesiologist. They are not trained for independent practice, and licensing them would not expand access to care. It would simply create a second-tier provider class with limited utility and greater dependency on physician supervision. While I was in residency in Florida, we competed our pediatric rotations with physician residents, nurse anesthesia residents, and anesthesiologist assistant students. The physician and nurse anesthesia residents were used interchangeably on the case schedule and call rosters. The AA students were assigned to the minor procedure rooms where they were closely supervised and struggled with basic clinical skills, such as medication administration and intravenous access. We actually felt sorry for them as it wasn't their fault. Most were in non-healthcare related fields prior to school, and they weren't prepared when they entered clinicals. Texas should invest in proven solutions. We should be empowering CRNAs to practice to the full extent of their training, not confusing the public and complicating care delivery with a new, less experienced provider group. Let's protect the high standards Texans deserve. Let's support CRNAs and reject the licensing of anesthesia assistants. Thank you.
Thank you. Chair recognizes Stephanie Williams, a CRNA, testifying on behalf of self against House Bill 5274. Is that correct?
Yes.
Thank you. Proceed.
Thank you, Public Health Committee Chair and members. My name is Stephanie Williams. I'm a certified registered nurse anesthetist, and I am here in opposition to House Bill 5274. I recognize that there is a shortage of anesthesia providers in Texas. However, licensing anesthesiologist assistants will not improve access to care. AAs must be supervised by a physician anesthesiologist in order to provide anesthesia. This staffing model limits where AAs can work only to locations where physician anesthesiologists practice, which is typically in urban areas, as shown on a map here I have for you guys. Any rural hospital, community clinic, or critical access hospital that does not have a physician anesthesiologist will not benefit from AA licensure because it does not increase the number of providers available in these underserved areas. Currently, there are only 335 AAs in Texas. They have been permitted to practice in Texas for some time now, and their numbers have only marginally increased. AAs are not required to have healthcare experience prior to applying for their master's program and do not have the training required to function independently. AAs are trained to assist the anesthesia team, just as their title implies. Every patient served by an AA is served by 2 providers who both require payment for those services. This model can be less efficient and flexible, and most importantly, places a heavy financial burden on Texans and facilities with limited resources. Conversely, CRNAs are already the primary anesthesia providers via delegation in rural Texas, where populations are largely underserved. CRNAs can practice autonomously and under current CMS regulations can bill for anesthesia services as the sole provider with the modifier QZ. This is the model that I practice under in Fort West San Antonio. CRNAs do not require costly supervision or duplicative staffing. While the intent of this legislation is to increase jobs and improve access, it does neither. Please oppose House Bill 5274. Thank you for your time.
Thank you. Chair recognizes Alan Rivera, CAA, testifying on behalf of Texas Academy of Anesthesiologist Assistants and self for House Bill 5274. Is that correct?
Sir.
Thank you.
Chairman and committee members, my name is Alan Rivera. I'm a certified anesthesiologist assistant, or CAA. As a delegatory state here in Texas, I get the privilege to do regional anesthesia as well as cardiac anesthesia at a level 1 trauma center. This bill bolsters and solidifies the accountability that is warranted to do this job. Living in rural West Texas, we experience firsthand the access to care is a significant issue, and licensure for AAs stands to help. Currently, at smaller hospitals, there are bylaws that disallow them to hire a provider without a license. In general, at larger hospitals, they are more likely to have recognized that the education and training of AAs warrants our hiring and have updated their bylaws to allow that. Even still, we are having issues applying for anesthesia care team models and beginning credentialing process without a license. This delays start dates and thus care. This is a vicious cycle that occurs for no valid reason and it's one that's simple existence of a license that recognizes the validity of our education and treating remedies. Rural health is important to me, and while I cannot yet work at hospitals like my hometown in Plainview, Texas, we need to accommodate a pathway providing better access to high-quality care in rural Texas. The lack of AA licensure is an unnecessary impediment to this goal, and it's also a barrier to employment for folks like me who do not wish to always live in the urban areas. It's the reality for us that we go where the jobs are, but as a lifelong resident of West Texas, I do not want to be forced to live everywhere, and I do not want the community to face any further deprivation of care. This law alleviates both of these burdens. Please support House Bill 5274.
Thank you. Members' questions? Representative Schofield.
Hi, to the CRNAs. In the same session where y'all are flooding my inbox with don't let the AAs get licensed, they're not capable, don't let them go past their ability, at the same time, you're trying to get to practice without the delegation of a doctor and get to set up a doctor's office. So when it's them, you don't want somebody to practice their full capabilities. You want them to stay in their box. But when it's you, you want to get out of your box and be a doctor. Y'all got to pick one. I mean, I think you've done yourselves a tremendous amount of damage when you come in and try to argue both of those two things at once. So I think that y'all need to pick what your strategy is. Do we want to get to be a doctor and open a practice without any supervision, or do we want to keep the AAs from getting licensed? But when you go, when it's me, I want all of it, but when it's them, I don't want any, your credibility, to me anyway, is shot. So please pick what you want, decide what how you want to do this. Should everybody get to practice to the full extent of their capabilities, or should everybody stay in their lane? And please come back and tell us which it is. Thank you.
Okay, Representative Jones.
Your aunt. I think we all met your aunt. You're now famous for your aunt.
I'm
Tell
very
me what
proud.
the difference is between a CAA and a CRNA, education-wise.
Yeah, Representatives, it's an important question. I understand Dr. Scott Kirchabel, who's an anesthesiologist, is on the slate to testify. Given
Is
his
he
clinical he is here. I just
Okay, I
glanced
see his
over.
hand
And
raised. How's about I'll just wait for him?
I'm glad to answer the question. I just want to make sure that the most credible expert is the one answering
I'll
it.
use
and it
him.
is on the-
I'm not trying to keep us here
No,
longer
it's
than we
okay.
need to be.
Thank you for
Thank you.
understanding.
Representative Schaffner.
What is the difference in training with CRNAs versus AAs?
CRNAs completed a 36-month curriculum in graduate school that builds on the 4 years of nursing education, which is then followed by 1 to 2 years at a minimum of clinical practice in a high acute setting. After that, to go on and do the regional anesthesia, as our AA colleague pointed out, they complete postgraduate fellowships in things like non-surgical pain management, adding another year of education. AAs, I believe, are 24 months to 28 months of training.
Is that correct?
Yes, it is. After a 4-year bachelor's degree, that can be in any degree as long as you do the prerequisites, same as med school, biology, biochemistry, physics, organic chemistry, things like that, statistics, calculus.
And so how long after the 4-year degree?
We do a 4-year bachelor's degree, and then you can apply for the master's degree, which is 24 to 28 months.
And then, Ms. Williams, you talked about the rural and underserved communities. So I'm looking just in mine, and 4 of my 6 counties have 0 anesthesiologists or CRNAs, and the other 2 have just CRNAs only. So are you saying that this probably, or how can it help or not help rural or underserved communities?
Right, so part of the reason that we oppose the bill is that the way that we are trained to practice independently. And since we can bill through that CMS regulation and modifier with QZ, we are able to do that via delegation from any physician. So it does not have to be a physician anesthesiologist. It could be the general surgeon that's there, the OBGYN. Any physician can delegate anesthesia to us. So we're able to effectively work in those rural areas, which as you can see on the map, we often do, and fulfill those needs. Somebody that is reliant on a physician anesthesiologist, as the CAAs are, cannot do that because the anesthesiologists have to be in that area in order to do that, delegate to them.
Okay.
So they won't help solve that problem.
Right. Is that correct, that you have to have an anesthesiologist specifically?
Yes, we've always followed an anesthesiologist, but we do practice 4-to-1 in hospitals where we practice same as CRNAs under delegation.
I was just going to specifically address East Texas since you brought that up. I practice as a solo provider in Crockett at the small hospital there, doing everything from obstetrics to general surgery. And kind of go back to what Representative Schofield was talking about as far as delegation. It was essentially an administrative function that the surgeon delegated the anesthesia to us at that point. They were not responsible for providing the anesthetic, just determined their patient for surgery or obstetrical needs required that anesthesia service to be provided by the CRNA. And as we tried to pursue independent practice, that's really what we were trying to accomplish there. More
Right,
of an
because
administrative-
an OB-GYN or something, they don't have the anesthesia background.
That's
et
correct.
cetera. Right. All right, thank you very much.
Yes, ma'am.
Representative Simmons.
Thank you, Mr. Chairman. Just to clarify, so CNRAs, y'all testified that the CAAs don't have to have a healthcare background before CAA school. And I guess, just for my lack of understanding, doctors need medical experience before they go to medical school, or do they just need to do their prerequisite courses and then apply?
Physicians just complete the prerequisite courses, essentially as he described for the CAAs, whereas nursings have a nursing background, so they complete a 4-year bachelor's degree in nursing, then practice clinically into the intensive care, critical care units, and then they go back to CRNA school for an additional 3 years after that.
Thank you so much.
Yes, ma'am.
Okay, thank you for your testimony.
Thank you, sir. Y'all have a good night. Morning, yeah. Sorry.
Chair calls Jana McAllister, Scott Kirchville, Shannon Paquetti, Israel Coronado. Show Jana McAllister testifying on behalf of self for House Bill 5274. Is that correct?
That's correct.
Thank you. Proceed.
Good morning, Chairman Van Dever, Vice Chairman Campos, and members. My name is Jana McAllister, and I'm testifying for House Bill 5274 on behalf of myself. I am a certified anesthesiologist assistant who has been serving patients in Texas since 2000. I currently practice at a major academic institution, and my primary specialty is pediatric anesthesia. I'm the current practice management chair of our national organization, the American Academy of Anesthesiologist Assistants. This bill is critically important because it establishes a formal licensure process for CAAs in Texas, aligning this state with many others that have already taken this important step to ensure provider accountability and workforce integrity in the operating room. Currently, Texas licenses every other provider in the operating room except for CAAs. This inconsistency not only puts patients at risk, but it hinders Texas' ability to address the growing provider shortage. The need for anesthesia providers is well documented, as you already heard. In 2002 alone, approximately 2,000 anesthesiologists and 2,200 anesthetists joined the workforce, and over 7,000 left. This shortage is not unique to Texas, but the impact here is real and growing. Other states are already acting. In the past 4 years, 5 states have added CAA licensure as a way to help meet the growing demand. A recent Joint Commission study in Virginia found that passing licensure for CAAs would help with their workforce shortage, and last month they passed a bill to license CAAs. Tennessee is close behind. Their bill is currently sitting on the governor's desk at this point. Texas has the opportunity to do the same thing, not only fill the critical gaps, but to help create a healthcare environment that values accountability, oversight, and professionalism. As a CAA who has devoted my career to the health and well-being of Texans, I urge you to support this House bill.
Thank you. Chair recognizes Scott Kirchhoff. Dr. Scott Kirchhoff, testifying on behalf of the Texas Association of Anesthesiologists and self for House Bill 5274. Is that correct?
Yes, sir.
Thank you. Proceed.
Good morning, Chairman Van Dever and Vice Chair Campos and distinguished committee members. My name is Scott Kirchhoff, and I'm honored to represent both myself and the Texas Society of Anesthesiologists in strong support of HB 5274. I'm a retired anesthesiologist with over 35 years' experience, spanning private practice in San Antonio and academic roles at the UT Health Science Center. I've dedicated my career to patient safety and anesthesia care, and I've personally delivered anesthesia, supervised residents, and directed nurse anesthetists. I have held board certifications in both adult and pediatric anesthesiology and served as president of the Texas Society of Anesthesiologists. Texas faces a severe shortage of healthcare providers, particularly in anesthesia. This crisis has led to delayed surgeries, canceled procedures, and even shuttered facilities statewide. While anesthesiologist-led care remains the gold standard, the reality is we lack enough physicians to meet demand, which is why the care team model, led by an anesthesiologist who is accompanied by a certified anesthesiologist assistant and by nurse anesthetists, works and is proved invaluable. That is why we must further integrate AAs into our care team. AAs are not newcomers. An estimated 330 currently practice in Texas, some for over 2 decades. Yet without licensure, their contributions remain undervalued and underutilized, and we can't even know how many there are. HB 5274 fixes this, ensuring proper oversight while expanding access to safe anesthesia care. In closing, as anesthesiologists, we highly regard both CRNAs and CAAs, and as the person who directs the care team, we need access to both types of professionals, and we would never put our patients at risk by recommending the licensure of ill-prepared professionals. I urge your support for this bill to strengthen Texas healthcare workforce. Thank you.
Thank you. Chair recognizes Dr. Shannon Paquette.
Yeah. You got it right the first time
Okay.
this time, sir, yeah.
Testifying on behalf of Texas Society of Anesthesiologists and yourself for House Bill 5274. Is that correct?
That is correct.
Thank you.
Good early morning, Chairman Van Dever and the rest of the committee. Thank you for having me, and thank you to Representative Cunningham for filing this bill. CAAs, as we've mentioned, an important member of the anesthesia care team. They are recognized by CMS as qualified anesthesia providers. The handout I'm giving you right now just shows the relevant CMS rules that outline that. I think what we should all recognize is that any healthcare professional who provides direct patient care and puts their hands on patients should be licensed for transparency and for accountability. In Texas, we require licensure for physician assistants, which are analogous to an anesthesiologist assistant, but in different specialties. We require licensure for registered nurses, for physical therapists, respiratory therapists, and a myriad of other healthcare professionals. AAs should belong to that group as well. I work with both CAAs and CRNAs in the hospital, and I've helped teach AA students who are very capable, despite some of the testimony I heard earlier. They are very ambitious and hardworking. We are already teaching AA students here in Texas, including a program that is affiliated with the UT system. And if we want to keep them here when they graduate from those programs, then we need to provide them job opportunities through licensure. We do have them working in some of our major institutions, MD Anderson, UT Health, Texas Children's Dallas. But as other people have testified, and as Representative Cunningham outlined, not all hospitals have bylaws that can allow for them to be hired because of the undue burden that comes with credentialing somebody who is not licensed, because we don't have that additional vetting process in place for those hospitals. So we would like to remove that burden by establishing licensure for CAAs. And just one more point of clarification about the differing training or education. So CRNAs do require a DNP now. That was as of January of 2025 that they require the DNP. However, that is not a universal requirement in the workforce. So there are plenty of CRNAs in the workforce who are master's trained and doctoral trained.
Thank you. Thank you. Chair recognizes Israel Coronado, a CRNA, testifying on behalf of self against House Bill 5274. Is that correct?
That is correct.
Thank you.
Chairman and members of the committee, good morning for the second time today. My name is Israel Coronado, and I'm a certified registered nurse anesthetist, and I respectfully urge you to oppose this bill. While anesthesia has become a divisive topic, and there seems to be some confusion of what anesthesia providers do or what we are categorized as, I believe it is important to understand the difference. Now, these two things are clear to me. This bill will not create new jobs, and this bill will not increase access to care. Allow me to offer some critical perspective. To become a CRNA, candidates must complete years of critical care experience before they set foot in anesthesia school. That background is not just a checkbox. It is where we master the management of life-threatening situations. This is not theoretical knowledge. It is direct involvement in patient care. The individuals this bill seeks to license, AAs, are not required to have this critical foundation. That gap is not just academic, but a real risk to patient safety. The Epstein study in front of you reveals a unique risk to the AA model, which relies on supervision, which showed how doctors failed at said supervision. This bill is about preserving control at the expense of patient safety by attempting to make a provider autonomous during emergency situations without the proper background to respond to life and death scenarios. In addition, this bill does not address the shortage of access to anesthesia providers as it continues to promote a wasteful anesthesia model. Thank you, and I welcome any questions you may have.
Thank you. Chair recognizes Representative Jones.
Thank you, Mr. Chair. I believe it was you who said you had the answers. What's the difference between a CAA and CRNA education?
Okay. As anesthesiologists, we consider them essentially equivalent providers. Their education are somewhat different in how they get to the final stage, but they both finished with roughly 2,000 clinical hours of training in anesthesia. The CRNAs go through nursing school to get their bachelor's degree. The AA students get a bachelor's degree in a variety of things, but they do essentially the same pre-med requirements, say 4 semesters of biology, 4 semesters of chemistry, 2 of physics, 2 of math, things like that. And they have to take the MCAT. But ultimately, both prior to entering professional school, have a bachelor's degree. And then they go through a program. The CRNAs, currently their program is about 36 months. The AA program is 24 to 28, but both have roughly 2,000 clinical hours in anesthesia training. Does that help you?
So you said the CRNAs have 36 to how many months?
About, I think, I'm just quoting what they've been saying this evening, 36 months in CRNA school.
In AA school?
24 to 28. And the programs around the country vary in both of the professions.
And both have Bachelor of Sciences?
Both have bachelor's degrees.
Bachelor's, okay.
The nurses have Bachelor of Nursing Science usually, and the AAs have bachelors in a variety of topics. But all the pre-science prerequisites.
Okay, so how do CAAs and CRNAs job responsibilities differ in the hospitals?
In the places that I'm familiar, where they have both, we use them interchangeably, and what might be delegated to them might vary from institution to institution. In some places, in a residency training program, they might be used for more of the routine cases, and the anesthesia residents who are training to graduate would get maybe the greater variety of cases. The CRNAs might be used, or the A's, just to basically keep the operating room, the throughput.
Then another question, are CAAs are they a less expensive alternative to CRNAs?
One of our friends earlier made that thing. Payment in anesthesia is based on the complexity of the procedure, the duration, and certain modifiers like age and illness. But the payments come from the payers, and they pay the same for a given procedure regardless of who does it. How that money is split varies within the organization. In some organizations where you have AAs and anesthesiologists working together, or anesthesiologists and CRNAs working together, the payer may take that money and split it in half, but it's the same amount of money. And then it goes to to whatever corporation employs those providers.
Is it, last question,
Yes, ma'am.
do anesthesiologists support the licensure of CAAs, and if so, why?
Well, we support them because we think they're qualified providers and we're comfortable working with them. But principally at this moment, why we support them is because there's an acute shortage of anesthesia providers in the state of Texas, and anything that will help us get more patients through the operating room would help. And if they're not available to go to various locales, that sort of heightens the crisis.
So your answer just made me have this
Okay?
question. So you say that there's a shortage of a shortage
Of all providers
of all providers.
in anesthesia.
And so I guess, does that necessarily imply that there aren't enough CRNAs or, and,
I won't answer for them.
why don't I ask you?
Okay, so I pointed out a model, and the problem is not that there's not enough providers, is that in the ACT model that is being mentioned, it's a doubling of the provider. That means that one patient has two providers for that particular case. In rural areas, that patient only has one anesthesia provider. So one of the things that I would like to add is in the education part of a CRNA, you're overlooking the autonomy part that we get to experience. In the nursing practice, one ICU nurse in the most complex of scenarios for the sickest of the patients, that ICU nurse can work anywhere between 3,300 to 6,000 hours if they work 1 or 2 years during that ICU training. So that is education that is hands-on experience. It's lived experience. It's not just theoretical. You're at the bedside taking care of very complex patients that are very sick, and that is something that our counterparts of the CAAs do not come with to the table. So there is a big difference on that as far as education. And when it comes to the model, the issue is the doubling of the provider. We do have a shortage, and the way to answer that is by allowing every anesthesia provider to be giving anesthesia at the head of the bed.
You're shaking your head no. What are you shaking your head
Because
no to?
both
Doc?
of these providers are physician extenders. The anesthesiologists who work in the anesthesia care team model will be medically directing 1, 2, 3, or 4 rooms. And 4 is what we consider the limit for patient safety. So we can put either one of those providers, or we can actually have a resident in one of those rooms in certain scenarios. And the physician anesthesiologist will be medically directing and intervening in the care in each one of those rooms as appropriate at the various necessary stages. So when it says that we're doubling the providers, actually we're extending the providers. You can do, with 5 providers, you can do 4 rooms.
So I don't know who all the speakers are, but does TMA have a position on this?
Dr. Silva was here.
Is that
and
what
he
you
was-
said? Okay, I didn't,
Mhm, mhm.
I'm somehow missed that.
No, he was sitting right there. Dr. Silva was.
Okay, let me go back and look at my notes real quick, hold on. Oh, you sure did say that.
He
Okay,
introduced
I'm
me.
sorry. I was so caught up with the whole Zeke thing in your
Mhm.
hand that I got distracted.
Mhm.
Okay, all right, thank you.
You're very welcome.
Members, other questions of this panel? Representative Pearson.
Thank you. I'll try to make this quick since we're almost at 2 o'clock in the morning. Mr. Coronado, you brought up education, and I can't believe what I'm hearing. We sat here not too long ago and heard a lot of the nurses tell us they didn't want their delegation anymore. They wanted independent practice. They wanted to expand their prescribing for scheduled drugs, but you didn't go to medical school. So my question for you is, why can't she get a license?
Are you referring to the CAAs
Yeah.
as far as getting a license? So the question, you're asking me about my education or about their
you
reasoning
brought
for
up
the
their
license?
education, their qualifications for doing what they do, which they're doing, apparently. They just want to be licensed to do it. That they're not expanding their scope, they're not asking for more. They just want to be licensed to do it. Whereas on the flip side, as Representative Schofield brought up, I mean, this is the complete inverse of what your testimony was not too long ago.
As I understand it, and pardon my approach to this, but this bill is seeking, if you look at page 8, line 8, okay, it's got a very specific line there that talks about autonomy and looking at how the CAA will operate in a setting where there is no anesthesiologist present. By definition, the CAA has to operate under an anesthesiologist. Now, that carries a question of education and training when it comes to CRNAs, because we, in our entire practice, even before we step into anesthesia school, we practice to be autonomous. So there is a big difference in the approach. If you look at that page and that line in that bill, it brings that question. And it is a question of safety because it deals with life and death situations in the immediacy of the case.
But autonomy and independent, I mean, it's the same when I'm hearing this. Go ahead.
I just want to provide some clarification about that. This bill does not change the scope of practice of CAAs at all whatsoever. All it does is provide licensure for them to work with us in the same capacity that they currently do, which follows the 1-to-4 ratio max that is established by CMS. And I also would just, on that related note, I just want to clarify as well that the Epstein study apparently was handed out to y'all. That is a study from 2012 that was done in Pennsylvania. Sometimes used to pose this argument that we are potentially committing some sort of CMS fraud. AAs do not practice in Pennsylvania. That study doesn't even include AAs, so I don't really know why we're bringing it up. But also, that study doesn't make any evident suggestive claim that the 1-to-4 ratio would be outside the safety norms of CMS. That study uses very, very tight parameters that are far more strict than what CMS requires for supervision that hospital chose to use for that, just to see to meet their standard within their hospital, what ideal ratios would be. The anesthesia providers in that study, it doesn't specify what they are, but they would have to be CRNAs and anesthesia residents. So AAs are not even a part of that study. So I just don't want that to come into the picture at all or have any confusion that CAAs would be doing anything other than working under an anesthesiologist in a max of a 1-to-4 ratio.
Well, I'm looking at page 8, and the way the bill says that an anesthesiologist assistant can only assist an anesthesiologist who is physically present in the facility where the anesthesiologist assistant is performing the medical task delegated by the anesthesiologist.
And the
where,
issue,
so where are you saying that they can just go autonomously? What page?
The
what
issue,
line?
it was on, I believe, on line 8 and page 8, if I'm not mistaken, but I don't have it in
No.
front of me. Well,
Yeah.
well, one of the things that she brought up was the model, right? And one of the issues that the Epstein study brought, even though it's not specific to Texas, is the setup is the same in Texas facilities, where you have a model where at 7:30 a.m., 4 cases are scheduled to start. And it is an impossibility for one anesthesiologist to be in 4 places at the same time. So when it comes to staggering cases, it would be ideal, but in the reality that we live in, and cases get started at the same time, you're gonna have lapses of time. And that study points out that when you have a supervision of 1 to 3, 99% of the time there were lapses of coverage.
So basically, you just don't want them to have a license.
I am pointing out
But that's what I'm getting.
Sure,
'cause
sure.
The page that you mentioned on the bill does not exist. I don't see anything about autonomy. In fact, it says the exact opposite.
I can go back and I'll be glad to look for that line and revisit it. But there was a point I read where it talks about the action of an AA in the event of a life-threatening situation.
Okay, thank you.
Sure.
Do you mind if I add one thing? We're basically asking to have a regulating body to make sure that everyone is doing what they're supposed to do, that we're following all the rules and guidelines. We're asking to pay the state money to regulate us. That is all we're asking.
That's what it sounds like. Okay, yes, sir.
One of the things, the most basic thing that having the TMB over, we would actually know how many licensed providers in that profession we actually have. The only way we can know, we go to their national organization and we look up their addresses and we hope they still live in Texas. That's the only way we even know if they're potentially here.
Okay, thank you.
Thank you. Members, any other questions for this panel? Okay, thank you for your testimony.
Thank you.
Chair calls Brian Walford, Dr. Haley Jordan, Douglas Massey and James Stockman. Show Brian Walford, CRNA, testifying on behalf of self against House Bill 5274. Is that correct?
That is correct.
Thank you. You may proceed.
Thank you very much, and good morning, Chairman, Vice Chair, esteemed members. Thank you for sticking with us for so long on a topic that you may be sick of hearing of already. But I am Brian Walford. I'm a CRNA practicing in Lavaca, DeWitt, and Victoria counties, and I strongly oppose HB 5274. The facilities where I work, we have 2 critical access hospitals, a small rural hospital, and an ambulatory surgery center. None of them have a physician anesthesiologist on staff that provides anesthesia. 2 of these facilities offer 24/7 coverage, including obstetrical coverage and response to emergencies across the hospital. Financially, these facilities cannot afford a redundant physician anesthesiologist system along with an AA. AAs by training and by law require direct supervision by physician anesthesiologist. This practice model is unsustainable for most community and rural hospitals. Also, this bill does allow AAs to independently manage emergencies. In critical moments when seconds count, the necessity of waiting for a supervising physician anesthesiologist, or more even alarmingly, relying on a provider not trained in autonomous action nor independent thinking can and will cost lives, Texans' lives. I've been a CRNA for over 2 decades, in the last 10 years in CRNA-only settings. I've witnessed CRNA's rigorous trainings for swift, independent response, ensuring rural patient safety. Licensing AAs will not improve rural access to healthcare, but introduces risk by inappropriate expanding their practice beyond their education and training. Therefore, I respectfully and ardently urge you to oppose HB 5274. Texans deserve better. I would be happy to quickly answer any questions if I can. Thank you very much.
Thank you. Chair recognizes Dr. Haley Jordan, Texas Association of Nurse Anesthetists and Self, testifying against House Bill 5274. Is that correct?
That's correct.
Thank you. Proceed.
Committee members, thank you for the opportunity to speak. My name is Haley Jordan. I am a CRNA. I'm here to voice strong opposition to the licensure of anesthesiologist assistants. With this bill, you will likely hear that AAs are just like CRNAs, and so they deserve to have a license. But that could not be farther from the truth. CRNAs are autonomous providers who enter anesthesia school with thousands of hours of experience caring for the sickest of the sick in critical care. They train exclusively in anesthesia for 3 full years and graduate with over 9,000 hours of clinical experience. In contrast, AAs are not required to have any clinical background. They spend 2 years learning basics like how to start an IV alongside anesthesia, graduating with about 2,000 hours of clinical experience. They are trained solely to support physician anesthesiologists, not to be an autonomous provider. With a projected shortage of almost 13,000 physician anesthesiologists in Texas by 2033, licensure of AAs is a gateway to expanding their scope of practice without the training to provide that safe care. AA licensure does not address the access to care issue we face today. At my hospital, we often call the physician anesthesiologist by cell phone. But if the signal fails, which happens, there's no time to wait. The CRNAs are trained to act autonomously without needing permission, unlike AAs. When seconds count, a physician anesthesiologist might still be on the way, but a CRNA is already there, already treating. Protect Texans, protect your family. Vote no to House Bill 5274. Thank you.
Thank you. Chair recognizes Douglas Massey with the Texas Association of Nurse Anesthetists and Self, testifying against House Bill 5274. Is that correct?
That's correct.
Thank you. Proceed.
Good morning. My name is Douglas Massey II, and I am a certified registered nurse anesthetist, CRNA, practicing in San Antonio, Texas. I'm here today to respectfully oppose the licensure of anesthesiologist assistants, AAs, in Texas. AAs are most often individuals who have a bachelor's degree and have completed several prerequisite classes in basic sciences. The Case Western Reserve University class of 2026 consists of 111 students, only 22% of whom have any education related to healthcare, but no hands-on healthcare experience. They also make mention of their students' experience in industry, meaning professions such as finance, computer science, and anthropology, not healthcare. While you may hear from AAs who were previously ICU nurses or pre-med, this is not the typical background for an AA. They are not required to have any direct patient care experience. They do not know how to operate ventilators, start IVs, or even prepare medication safely. Their education lasts only 2 years and requires constant supervision by a physician anesthesiologist. This limited training is insufficient to learn how to provide safe, high-quality anesthesia care. Moreover, the University of Texas Houston permits both first and second-year students to repeat the entire curriculum. Yes, repeat their entire curriculum if they perform inadequately. When someone's family member is in the operating room under anesthesia, there are no repeats. Every second counts. This is not an argument against interdisciplinary collaboration. It is a call for responsible policy to protect patients. Extending licensure to a group of poorly trained anesthesia providers does not benefit Texans. It harms them. It adds confusion, medical risk, and increased cost by paying both a physician anesthesiologist and AA to care for the exact same patient. In closing, I urge you to oppose this legislation.
Thank you. Chair recognizes James Stockman, CRNA, testifying on behalf of yourself against House Bill 5274. Is that correct?
That's correct, sir.
Thank you. Proceed.
Good morning, Mr. Chairman, members of the committee. My name is James Stockman. I'm a CRNA from Nacogdoches, Texas, and I'm testifying today against House Bill 5274. I own and manage an anesthesia group that has approximately 18 locations across Texas. This bill is about job security for anesthesiologists in large metro hospitals. AAs will do nothing to increase the access to care at the majority of these facilities across the state, particularly in rural facilities where my company operates. They are required to work with an anesthesiologist and receive direction from them in no more than a 1-to-4 setting. The previously mentioned Epstein study that has been attacked actually is very relevant to these proceedings because it does look at the exact model that an AA would always be required to perform in, and that is a medically directed model. That study did indeed show that there's a 1-to-3 ratio that in a 1-to-3 ratio with anesthesiologists, they had lapses of medical direction and their requirement for medical direction in 99% of the days surveyed and 35% of the days surveyed in a 1-to-2 ratio. As AAs are not trained to operate independently, this is a very dangerous situation. I've heard it asked, why licensure? Well, licensure drives up costs, reduces competition, and it should be reserved, or its application should be reserved for providers that are trained to function independently, such as CRNAs. Oftentimes, when AAs are introduced to a facility that already has CRNAs in place, scope is dropped and reduced to accommodate the AA's decreased scope. I've seen this and can provide personal examples where I've had colleagues where this has occurred. Finally, undoubtedly there is, as has been stated, safety has been brought up regarding this bill. Consistently, my company has credentialed providers across the state, and in each of those indications, we have always looked at background checks, primary source verification, references, national practitioner data bank. There are multiple ways in which we check the background of providers. Thank you.
Representative Frank.
Yeah, thank you, Chairman. I'll try to be brief. I was inclined against the bill until, honestly, those who are against the bill testified. Can you point to anything in the bill that expands the scope of what the AAs are doing now in the bill? I mean, y'all have done a great job of saying why you're not the same, and I don't think, because y'all have more independence. I understand that. Y'all can operate in a separate facility from a doctor, right? Y'all can operate, and that's because you have more training, and you can operate separately, still under delegation, but you can operate separately, and AA cannot. right? AA has to have a doctor right there. Show me in the bill where they're trying to be. I know somebody said something about this might happen later, or it opens the door, but show me in the bill where it is.
Page 8, line 8.
Page 8, line 8, all right. So page 8, line 8 says,
They are trained basically to function as a direct,
able to respond to a medically emergent issue arising from a delicate Does it
They're-
not also in the same bill say that the doctor has to be right there on site, or does it not?
I believe it does, but if
Okay,
you're
so if they
operating
have-
if you're operating as a direct extension to them, they should be following his orders directly, not, in this.
Does that
in
change
this-
what it is now? That's what I'm asking.
Yes,
That's what I
sir.
asked.
Yes, sir, it does.
Right now, you've
Because-
got one doctor and 3 or 4 AAs,
Right.
right?
Yes,
That's
sir.
the way it works right now.
That's correct, yes, sir.
And is the doctor always right there, or do they
No,
sometimes
sir.
have?
He's
right,
not
they-
always right
So
there.
they do have to operate sometimes.
Yes, without the doctor right there. I mean, I've said you can look at the
So that
study.
doesn't change what it is.
Well, it's saying now
Okay.
that
It's
without the
but-
doctor right there, they're having, they're.
I would just advise y'all, if you have issues, show exactly where in the bill it's actually different than they are operating today. We all have offices, but I'm much more on the other side now.
I would love to,
Yeah.
I would love to
In writing, 'cause
follow
that's-
up with your
that's
office.
the same as is currently being done, I believe.
Representative Schaffner.
Is the biggest complaint the education or the operating room?
Would
The
you define
educational
operating room?
differences, or within the operating room, well, independently versus supervised?
I would say they're equally a large complaint. We do not feel that they are educated to our standard as a nurse anesthetist. We also do not believe that they're trained to function independently. And given that the anesthesiologist, and we've provided a study whether or not it has AAs or not, but there is a Pennsylvania Academy of Anesthesiologist Assistants, so I would say there's some form of AAs in Pennsylvania. The reality is the physician, the anesthesiologist, is not going to be able to be right there, and there is a lapse in coverage of meeting their medical direction model. So they're going to have to function, independently, and they're not trained to do so.
Okay, anyone else? Thank you.
Representative Schofield.
Hi, a couple of quick notes. Mr. Walford, you said that the rural hospitals wouldn't be able to afford this 2-provider model, in which case they wouldn't do it. We're not foisting it on them. If you license 1 million AAs and they can't afford to have an anesthesiologist and an AA, they'll just hire you. So it doesn't change that.
May I respond? I was actually refuting some of the testimony saying that this is drastically going to help all aspects of anesthesia care throughout the state that I've heard other witnesses talk about. It doesn't do anything for rural, and that was my main point. Speaking on as a rural practitioner, it's not a sustainable model because we'd have to bring an anesthesiologist in just to have this follow the law that's set.
And it won't affect you.
Okay.
And Ms. Jordan, as I was listening to your testimony, I was getting a tremendous sense of deja vu because everything you were saying about the AAs having less training than you and less clinical experience than you is almost word for word what the physicians said about y'all when y'all were trying to get a bill to let you practice, basically play doctor and practice medicine without them. I mean, it's almost like you stole their testimony. And again, y'all need to pick one. Either come in and tell us no one should expand their scope of practice, they should stay in their lane and do what they're trained to do, or say everybody should go past their current scope to their best of their abilities of what they can do. But don't say, I should get to expand and go be a doctor, but the AAs shouldn't be able to work under a doctor. That dog won't hunt. I mean, this committee, and this committee's dealt with, for as long as I've been in this building, which is a quarter century, with scope of practice fights that are mostly about business, keep my competition down and let me thrive. And you guys are asking for both at the same time. It would be bad enough if I had to say, just last session you can, no, just last week. So pick one. Tell us, should we keep everybody to what their level of training is and what their traditional licensure and scope has been, or do we let people expand because we think that will fill the needs of Texas? But don't say, I get to do it, but my competition's got to stay down. Come on, guys.
May I respond to
May-
that?
I was gonna say, can I respond?
So I believe, and I apologize if
And I don't think you guys are listening, because we've been saying it all day, and you came and gave the same testimony that we refuted before you gave it.
So I believe Dr. Kirchville, and I apologize if I butchered your last name, but said that anything that will get more patients through the operating room will help. And yet it's the physicians, the ones who say that anything that can get more patients through the operating room will help, that are fighting CRNAs from getting full practice authority. CRNAs getting full practice authority is not an expansion of scope. It's removal of a regulatory barrier in the form of a delegation order.
It is an expansion of scope, because while y'all in the real world may be just paying for a piece of paper, folks over here that make the rules have made the rules that say that you're supposed to be getting a physician supervising you. We don't just have delegation rules so that you can pay somebody. We have delegation rules so that there's a physician monitoring what you're doing. And if they're not, that's something we need to look into. But that's, again, when you come in and say, I should get to expand, but the other guy shouldn't, your credibility goes right down the John. And, pick which one it is and come back to us with that and go, either we should all expand or no, we should stay in our lanes. But don't say, I should get more business and the other guy should get held down. That doesn't even make sense. It's just inconsistent. But it's very consistent in that I want what's best for me, and we all want what's best for us. But when we're making public policy, you got to come in and pick which one you want. And I know it's after 2 in the morning, I wouldn't be so sharp about it, but come on, guys.
Representative Pearson.
Thank you, Chairman. I believe it was Mr. Massey?
No, that's Massey. I'm Stockman.
Okay, yes. I heard you mention safety a number of times, your concerns about safety. I've heard several people mention their concerns about safety. So my curiosity revolves around the fact that the Texas Medical Association supports this bill. The doctors who went to medical school support this bill. The anesthesiologists support this bill. Is it your testimony that the doctors are wanting to put patients at risk?
It's my testimony that the doctors, as Representative Schofield pointed out, have more than just the interest of patients in mind with this, because an AA can only work with an anesthesiologist, there is an incentive there to hire an AA. So yes, it is my testimony that there's more to it than just expanding care, because if it was just about expanding care, then we would be doing it for something that would be better for all of Texas and not just that's going to affect urban areas.
Well, I'm not convinced that the bill was brought to expand care. My understanding is the bill was brought to have accountability and reporting for licensure for people to assist the anesthesiologists in the operating room. So if you're telling me that you feel like it's more about the physicians and their bottom line, that they're willing to compromise patient safety for that, that's a different discussion.
Well, I'm just responding to their own testimony where they said that it would expand operating rooms and things like that. That's specifically what I'm talking about. But in regards to, as far as the safety and things, and as far as licensure, like I stated in my testimony, we reserve licensure for, for more independent providers that are trained to think and practice independently. It's going to increase, the burden on the state already, even though, you're creating a new board under the Texas Medical Board. They're already practicing in the state by delegation, the general delegation statute by the physician. Leave it there, because that requires then that the physician has some stake in the game. In my view, they're trying to create this licensure to split and mitigate some of their own liability in the process. They introduced them to the state. They should remain responsible under delegation as it is now.
Okay, thank you.
Representative Jones.
So, some questions. I don't care which one of you answer it. Why does licensing CAAs put patients in danger when they will literally be doing the exact same thing? The only difference is they'll have a license.
So your question is how would licensure make it more dangerous? I think it would
No, that's not my question.
I'm sorry, repeat it. I apologize. It is 2 in the morning. I'm
I
sorry.
understand,
So-
but me too. Literally, the only thing that'll be different from what's going on right now is they will have a license. They will still have to be supervised by a doctor. How does that translate into just, again, the only difference is they have a license. How does that somehow make patient
Well, I think-
care?
Sorry.
Why does that make it less safe for patients?
Because I think within that, it's expanding their scope from what they're doing now.
I'm
as
not
they
asking
try-
about expanding
Well,
scope.
you-
I'm saying if the only difference, because all I see is that they now, under this bill would have to have a license. Nothing else has changed. So.
But I
how-
would say
how-
that
how-
there is more that's changed because, I mean, we're pointing to where now they're, making independent decisions essentially, independent from the
That's
physician
not,
itself.
but the bill says that they still have to be supervised by a physician. It's like you're reading that out of it.
Correct, but we're all,
So I'm
I've
correct.
also what I'm saying is we've also
I'm not
provided
correct.
data, that the physician cannot always be right there.
Right, but the
directing them.
sufficient, but I think the mere requirement to have a license doesn't directly affect the quality of patient care. I'll just leave that there. I have another question. Are CAAs in direct competition with CRNAs? That's a yes or no question. It's so easy. And you thinking about it, it's killing you, I know it is.
Not
anywhere I work.
Not in my facilities typically, no. I have 18 locations that we manage and I practice clinically as well, so no.
So
not
your
that.
testimony is CAAs right now are not in direct competition with you, and if they get
Not
licensed?
me personally, no.
Okay, but
So-
but I said CRNAs, I ain't say you.
Well, I can't speak for the entire profession. I mean,
But aren't you here speaking for the entire
I'm speaking for
profession?
myself as
As a representative of the entire profession.
No, as a representative for myself, like as a CRNA, yes, but when I signed up, I was testifying on my own behalf.
If CAAs, what's your name again?
James Stockman.
James Stockman, okay. If CAAs get licensed, will they be in direct competition with you?
No, ma'am. Not me personally, no, ma'am.
Thank you.
Yes.
Okay, thank you for your testimony. Thank you. Chair calls Melissa Limmer-Riola and Tiffany Thomas. Show Tiffany Thomas registered against the bill, not testifying. Show, what was the other name? Melissa Limmer-Riola, registered against the bill, not testifying. Is there anyone else who wishes to speak on, for, or against House Bill 5274? Did you register?
I did, yeah.
What's his name?
What is your name?
My name is Richard Evans. I registered, I wasn't going to testify, but there are a couple of things that I just wanted to clarify really quickly.
Richard Evans.
Yeah, for the Texas Society of Anesthesiologists. I'm way past my bedtime, so I'll be very brief. I know, but I'm old.
Chair calls Richard Evans, Director of Governmental Affairs with Texas Society of Anesthesiologists for House Bill 5274. Is that correct?
Yes.
Okay.
All right, thank you, Mr. Chairman. Before I was Director of Government Affairs for TSA, I was Director of Government Affairs for the American Academy of Anesthesiologist Assistants. So I've heard these arguments from the CRNAs from coast to coast. There are 21 states now where CAAs practice or have delegatory authority like we do here in Texas. The CMS rules that Dr. Paquette handed out to you show that CMS, the Medicare system, considers CRNAs and CAAs to both be non-physician anesthetists. That's how they classify them. They're both able to operate in the Medicare system. Both can be medically directed by a physician anesthesiologist in the anesthesia care team model. When you have a hospital that has both CRNAs and CAAs working there. I heard this testimony in many different states from anesthesiologists, from academic schools across the country. A lot of the times those delineation of privileges, which is how the hospital defines what services CRNA or CAA can provide, are the same. They may be on the same form. They're advanced practice providers. That's how hospitals deal with that classification of mid-level provider. They have they're getting paid the same benefits. They perform the same services in the operating room. The American Society of Anesthesiologists put out a statement a few years ago, and they've updated it a couple of times, basically saying, look, CRNAs, CAAs, there are different pathways that they get their education and training. One's through nursing school, one's through a medical pathway, like a physician's assistant. At the end of the day, they both perform the same tasks. One last point I'll make, Stanford did a study back in 2018. They looked at about 448,000 claims and determined, based on that study, that there was no difference between the length of stay, the cost, or mortality between CAAs and CRNAs.
Sir.
Yeah, I'm done.
Please. It's 2:30.
Yes, sir, I'm done. Yeah.
Thank you. Representative Jones.
I have a quick question for you. If CAAs, like right now, if you're having a shortage of medical care in the rural areas because there's just not enough providers, is it possible, like, so right now they have a CRNA and a CAA in the same operating room. Is that accurate or that's not accurate?
Not a CAA and a CRNA in the same operating room, no.
So as a doctor, as a physician, and if I can supervise like up to 4 operating rooms, can I in one of the operating rooms have a CRNA and in the other operating room have a CAA and I just supervise them and I'm still giving care?
Yes, Medicare rules allow what's called medical direction. That means that the physician anesthesiologist can medically direct, supervise up to 4 CAAs or CRNAs or a combination. So they would be supervising 4 operating rooms with CAA, maybe in all 4, or CAA and a CRNA combination. Medicare rules allow for that, a 1-to-4 ratio.
So this is gonna be a yes or no question. And if you answer yes or no, this is gonna be the end of it for you. Hint, hint, hint. So right now, I'm a physician and I've got a CRNA in one operating room and I've got a CAA in an operating room. And they're doing the identical thing. Is that yes or no?
Yes.
Okay, thank you.
Members, other question? All right, thank you for your testimony.
Yes, sir.
Is there anyone else who wishes to testify on, for, or against House Bill 5274? Were you registered
Yes, sir.
to testify?
Was not.
I'm sorry?
I was registered, but I wasn't registered.
What is your name?
First name is Edward, last name is Boytim, B-O-Y-T-I-M.
Chair calls Edward Boytham, CRNA, testifying on behalf of self against House Bill 5274. You have 2 minutes.
Thank you, sir.
Thank you.
I think some of the confusion comes from the care models. When CRNAs were working independently in the rural areas, that is not anesthesia care team model. Anesthesia care team model typically happens in the larger facilities where anesthesiologists are. I also like to point out the history. Nurse anesthetists started in the 1860s. Anesthesiologist program started in the 1940s. So as far as nurse anesthetists practicing anesthesia, we've been doing it for a while. So this is not nurse anesthetists trying to play doctor. We've been in the field for a long time, and so we're not trying to play doctor. We're just trying to provide anesthesia. So that's all I really wanted to say was there's a long history.
Okay, thank you. Members, any questions? All right, thank you for your testimony.
Thank you.
Now, is there anyone else who wishes to testify on, for, or against House Bill 5274? Not, Chair recognizes Representative Cunningham to close.
Thank you, Chairman Van Dever, and I want to thank everybody that came here tonight, those for and against, and also want to thank my maid right here, Ann Johnson, because it was Ann Johnson, when she brought the surgical smoke, that made me think about licensed people in a surgery room. And I've been hearing licensing all day. I mean, I've got, whatever they are on wheels, giving IVs and stuff. I got midwives that are licensed. If I'm going to be getting a surgery and somebody's going to put me to sleep, I want them to be licensed. And with that, I close.
Okay, thank you. If there is no objection, House Bill 5274 will be left pending. Is there objection? Chair hears none. House Bill 5274 is left pending. Members, that concludes today's agenda. Thank you for hanging with us today on the dais.
Everybody's here.
Is there any further business for the committee to address? If not, the chair moves to adjourn. Is there objection? Hearing none, Committee on Public Health stands adjourned, subject to the call of the chair.